Good morning, everybody. I'm really happy and honored to be here today. Many thanks to the organizing committee for inviting me and us all to participate to this oncology update session. I would like to invite all speakers to respect the time of 10 minutes. And if you want at 8 minutes 30, I will tell you that you have 1.5 minutes left. I propose to ask and answer questions just after each lecture. And I would like to start our session with Professor Vasilis from Ellis, who is Professor of Immunology in the University of Paris. Vasilis, please.
Thanks a lot, Dimitri, and thanks to the organizer for the kind invitation. So I'm currently on leave of my university position. I'm a clinical hematologist by training, and I took on a position of Chief Medical Officer at Okin since March this year. And I wanted to tell you some recent advances in how we can use artificial intelligence for personalized medicine in cancer. This is basically the problem for many therapies across diseases. Is not cancer specific. This is from the dexamethasone trial, the recovery trial, dexamethasone in severe COVID-19. And here you can see, after related to the statistical analysis, how many patients actually benefit from the drug in yellow, 12 patients out of 100, as compared to the 60 patients in blue already likely to recover independently of the drug, and to the 28 patients here in red that will die even with a new drug. So this is 12% of the patients benefiting from the drug. And this number is about the same for most of the FDA-approved drugs, including blockbusters like anti-TNF in rheumatoid diseases, and so on and so on. So the point is, how can we improve that? And this has to go through patient selection and identifying subgroups with certain features that will actually... Do we have a pointer here? Oh, yeah. From this mixed heterogeneous population, basically the question is, can we identify those patients that will benefit from the treatment? So those 5, 10, 20, maximum 30%. And stratify the patients according to some biological, radiological, histological, clinical features, and then find a way to select those patients in routine clinical care in order to treat them with the right therapy. And here, of course, it's not a trivial process, although it looks very simple. And I wanted to address 2 points, is how complex can be the data integration and data analysis here at this level, but how simple should be a companion diagnostic or a patient selection algorithm and biomarkers at the clinical level. If you are asked to select patients based on 300 variables on genomic, transcriptomics, proteomics, and so on, it will never be applicable to clinical practice. So can we address this using artificial intelligence and simplify the data types that we will use? So the first example I will tell you is using AI on simple data modalities to identifying patient subgroups. So the first stage of grouping identification. And this is a study that was published by the Okin team. It's called Mesonet. Is an algorithm to predict prognosis in malignant mesothelioma using simple H&E slides. So here, basically, you start with a large cohort, all having H&E slides. There's a validation cohort, and with impact on prognosis. And I will take you through the steps of how to use H&E slide and extract features. So this is the whole slide image that is associated to clinical annotation. The image is processed in tiles, and here it's broken down in 10,000 slides per 10,000 tiles per slide, and each tile is decomposed in a matrix of 2048 actually additional pixels, and through autoencoders, basically there are features extracted from these tiles that are scored versus prognosis. So basically you transform histology images on omics data, these are sometimes also called histomics, and in that case the prognostic algorithm was very efficient and predicted survival better than already known algorithms. Now, what about if you have very complex data like transcriptomics and you want to bring them to the clinic and simplify the process? Can we predict the complex data modality with the simple one? And this is something that is also feasible, and through the recent advances of deep learning and artificial intelligence. And this is another recently published example from 2020, where basically we have developed, again, a data analysis and deep learning algorithm to predict transcriptome features and transcriptional signatures from whole slide H&E staining. So once you find a transcriptomic signature that identifies a subgroup, you can use the H&E slide to extract features that will be a surrogate of your transcriptomics. And this is very easy to apply in routine clinical care. And a third aspect, so this is examples of biomarkers that we have today in different areas, like lymphoma, solid tumors, breast, pancreas, prostate, that actually correspond to predicting one complex data modality using H&E slide as a simple data modality. And a last example an issue I wanted to address is the fact that in cancer, and especially in rare tumors, but also in frequent tumors, you need large patient populations to integrate and generate predictive models with the right performance. And this is usually requires to actually access data from different hospitals, different teams. And so how to do that when the hospitals are reluctant in sharing their data? And there is a technology that, I don't know if you've heard of it, it's called federated learning, that breaks data silos, because instead of bringing all the data to the same servers to perform actually the data analysis and data integration, basically you leave the data where they are. And the federated learning allows to integrate the data without the data leaving their space. And this is a solution to actually create large consortia. This is some example of industry academic consortia that actually use this technology, including one French consortium with Institut Curie, where Dimitris, Léon Bérard, Assistance Publique. And basically it creates a synergy between all those centers that can actually integrate their data while keeping them in-house, and it also solves data of GDPR compliance and security and confidentiality. And so this is my last slide, basically about, obviously it's snapshots of a complex problem, but really some important advances that make personalized medicine a reality or contribute helping personalized medicine a reality by breaking silos to actually integrate data from very large patient cohorts in different institutions, going then through multimodal patient profiling using a diversity of data modalities that can be very complex, but then designing simple biomarker and patient stratification and patient selection algorithms so that they are applicable in routine clinical care and not just left in a high-impact journal without translation into the clinics. Thank you very much. Yeah.
Yeah. Yes.
Thank you. That was an excellent talk. My question is about the AI thing. It's artificial intelligence, but what I see in our field is that actually is brute force analysis. So like you take a huge computer and analyze the data, and then you do prognosis. We do that also in hematology. You know, I mean, you're a hematologist, so you look at the slide and then, you know, you say, that's a blast, that's a promyelocyte, that's a myelocyte, etc. And then the computer will tell you, you know, the blast count is 28% or something. And then you say, okay, it's not yet AML, or it's already AML, etc., etc. But that's actually, it's not intelligent. It's just, you know, huge quantities of informations are analyzed. So when are we going to see the next step? Is the computer telling us that it found out a new prognostic model or a new prognostic marker learned from all this information that has been generated, and instead of analyzing it and telling us prognosis, instead actually tells us that found a new model or found a new opportunity to treat or found a new drug, because it said, okay, listen, I found that BCR-ABL is, you know, the confirmation is this, and we actually need another, and if you had this and that, and then, you know, somebody from a pharmaceutical industry will say, okay, let's you know, put this together.
Well, thank you very much. I would need 1 hour to address the whole, you know, the question. But some hints, you know. First of all, AI is doing way more than what I showed. Obviously, it's just examples. Drug design can be dramatically improved by AI. And in terms of intelligent use of AI, I have just two comments. The one is, for example, the HE to RNA, how you can predict transcriptomic signature with H&E slide. This is, I think, pretty intelligent. I don't think a human brain can actually do that and look at an H&E slide and see what are the features there that can be associated to a transcriptomic signature. And then the second point is about interpretability. So what I showed is maybe suggesting a black box type of thing, where, as you said, there are a lot of huge computing power that processes a huge amount of informations extracted from the slide. But in fact, all that is interpretable. And the model can tell you in the H&E slide which are the tiles and the features in the tile that are associated to prognosis. And by discussing that with pathologists, with oncologists, you can go and say, oh, in these tiles, first of all, they're in the stroma or in the tumor, or they have vessels, and maybe some features in there can be interpreted as associated to prognosis. And then you can go back to these features to even try to understand mechanisms and perform in situ transcriptomics or other special transcriptomics or other things. So there is also a progress in the interpretability of the AI models, so that basically you understand which features are actually associated to a given endpoint.
Are there any other questions? No, Vasily, thank you very much.
Okay, thank you.
Thanks for respecting the time.
Morning. I'd like to introduce Charalambos Menekakos, General and Visceral Surgeon from the Werner Forssmann Hospital in Berlin, Brandenburg, Germany, who will be with us online. Good morning.
Good morning. Thank you very much for the invitation to be online here with you today. I would like in the next 10 minutes to talk about a rather underestimated topic in surgery, especially among general and visceral surgeons. That's the staging laparoscopy in gastric cancer surgery. These are my disclosures. And dear colleagues, we all know that gastric cancer has a high prevalence. And up to date, the gold standard treatment is the gastrectomy, combined with perioperative chemotherapy according to the stadium. But we have to know that almost 40% of our patients appear with metastasis, and especially with peritoneal disease, which make the prognosis very poor. We have many tools for the diagnosis and staging of gastric cancer, but it's clear that clear measurements of the extent of the primary tumor are often lacking. What tools do we have to stage the gastric cancer? We have the endoscopic ultrasound, which is very good for T1 or T4 tumors. We have CT scan, but CT scan has a very low sensitivity in detecting the peritoneal metastasis. And for selected patients, we also have the PET scan. The diagnostic staging laparoscopy has appeared as a feasible and simple laparoscopic method to accurately stage the cancer and find the peritoneal metastasis. And the two clinical questions that arise are, why should we do this procedure? And second, which patients are candidates for this procedure? If we want to ask the second question, we have to say that we don't have many well-designed studies, but the studies we have now at our disposition, they show that we have an avoidance of laparotomy from 8 to 43% of patients. And this is the magical word why we should do this staging laparoscopy. Because if we find peritoneal metastasis, we can avoid surgery. About the indications which patients could profit from this procedure, the SAGE's recommendations say that especially patients with T3 or T4 tumors will profit, while patients with T1 tumors are not likely to profit because they, in majority of them, they don't have any peritoneal metastasis. And here's a paper from MD Anderson Memorial Sloan Kettering from Hen Yosi, and you see here that almost 20% of patients have peritoneal metastasis which are not seen with other methods, for example, CT scan. And 2% more of these patients will have positive cytology, so that all these patients can be excluded from a gastrectomy. And a very interesting study is the cohort study from the Dutch databases, for Hen Bokstein. They practice studied patients retrospectively who had a gastrectomy. And in two groups, patients who had laparoscopy and non-laparoscopy. And the takeaway message from this study is that they found a high rate of avoidable surgery in staging laparoscopy group. In other words, these patients who have peritoneal metastasis, they don't have to get a gastrectomy afterwards. A study from Brazil, which confirms the high accuracy and specificity rate of laparoscopy. We see here the trocar placement. The colleagues there are doing the procedure before the gastrectomy. So if they don't find any peritoneal metastasis, the laparoscopic gastrectomy would take place afterwards. This is not the standard. And two studies from Japan. As we know, Japanese colleagues are pioneers in gastric surgery. We have here a study from the University of Tokyo. The colleagues studied patients with high-stage Bormann tumors or nodal disease. And the takeaway message from this study is that the peritoneal disease was identified in about 47% of the patients. And for all these patients, the treatment concept was changed. These patients did not get a gastrectomy afterwards, because gastrectomy will not bring any profit to these patients. And one more study from Japan, from Dr. Ishigami. The authors here did a step forwards, and they did not only did a laparoscopy to find the peritoneal carcinosis, but patients who had peritoneal carcinosis did take a chemotherapy. And after that, they did a second laparoscopy, and patients with no signs of peritoneal implantations, they get a gastrectomy. And I would like to say that this is also not a standard in all institutions. And the last study is from Leek, Dr. Leek in Canada. They did a meta-analysis about the indications accuracy of laparoscopic staging. And what we should keep from this meta-analysis is that the laparoscopy has a high accuracy and specificity rate of about 100%. And once more, the takeaway message is the avoidance of laparotomy, the avoidance of surgery. And in most of the studies, ranges from 13 to 44%. That means about 44% of the patients who are getting this laparoscopy, they have metastasis, they're not suitable for gastrectomy. About the technique, this is a relative simple procedure, laparoscopic procedure. You can establish the pneumoperitoneum either in open technique or with varus needle. I prefer the open technique. If we don't find any ascites, we can irrigate the abdomen so that we have a cytology. And it is very important to meticulously examine all the regions of the abdomen, not only a quick round look, and because this won't bring very much. We have exactly to examine all the abdomen quadrants, as we see here, the peritoneal cancer index. And these are in detail the anatomical spaces we should examine. And some examples of peritoneal lesions, small, medium, or confluent. Are there contraindications for laparoscopy, for this laparoscopy? It's the main and common contraindications for each laparoscopic procedure. Most of the patients are suitable for laparoscopy. About the disadvantages, there are colleagues who say, okay, we can do a laparoscopy because we could not examine the lymph nodes, especially the retroperitoneal lymph nodes. That's correct, and the answer comes from Japan. Colleagues here have developed a hand-assisted laparoscopy. They use a laparoscopic port so that they can palpate the lymph nodes, and if we want, we can take a sample of lymph nodes. As a conclusion, the staging laparoscopy can identify metastatic disease in about 50% of the patients, despite negative preoperative imaging studies, and this is very, very important. The method has high sensitivity, high accuracy, and high specificity. And as a takeaway message, this method is appropriate for patients with a stadium higher in CT scan or ultrasound, higher than T3, because these patients, if they have peritoneal carcinosis, will not profit from a gastrectomy. Gastrectomy can have only a palliative purpose if patients have bleeding or a stricture. My references, and thank you very much for your attention.
Thank you. That's excellent talk. Thank you, Dr. Menekako. Masipate, you told us about the prognosis, which is so important in laparoscopy. What I wanted to talk about, if you can tell us on the human side, since 50% of the patients are found to have peritoneal disease and cannot benefit from curative resection, how do you handle the discussion with the family and the patient after the discovery of peritoneal disease? And how do you approach that as a surgeon ethically and that discussion?
You know, here in Germany, the medical policy is that all the patients are in detail informed about every step of treatment we take. Every decision we make is discussed with the patients. And if a patient has a peritoneal carcinosis, we discuss openly the findings with the patient and with the family, so that the patient knows that the life expectancy, the survival, is limited, and but we do have options in terms of chemotherapy or palliative chemotherapy. So all the patients are well informed about the findings. nothing is hidden. Patients and family are in detail informed about the situation they have.
Thanks again for a great talk. Just one quick comment. You showed that the PET-CT is a possibility in staging patients with gastric cancer. I just want to point out that in diffuse gastric cancer, we often get PET negativity, even in large amounts of tumors. So I want to stress that laparoscopic surgery, laparoscopic identification of tumor masses is of utmost importance. And I would actually like to stress even more that it should not only be done in T3 tumors, but also in T2 tumors, because very often our endoscopists are not sure about the exact stage of the tumor, and therefore I'd like to stress that I would be a little bit more aggressive even than what you pointed out.
This is true what you're saying. We do have patients with T2 tumors who have the laparoscopy. We have to combine all the staging features we have for each patient, and all together will make the final decision at the tumor board where all these cases are discussed. I agree with you that some T2 patients are now suitable for laparoscopy, especially if other findings of the staging say, okay, do the laparoscopy, for example, if the patient has lymph nodes, or if signs, CT signs that the patient might have peritoneal implantations. But you're correct, also T2 tumors can be suitable for laparoscopy. About the PET CT scan, I mentioned it only as a staging modality. PET CT cannot always find the peritoneal carcinosis, and it's not the method of choice to find the peritoneal implantations.
Any other questions? I just have a yes or no question, Haralambe. Thank you very much for your talk. Would you, for patients that have limited carcinosis with a PCI less than 7, local peritoneal carcinosis, would you consider cytoreductive surgery and HIPEC?
Only under protocol settings. Here in Berlin at the Charité University Hospital, Professor Rao, which is a pioneer in HIPEC in Europe, runs a study about HIPEC and cytoreductive surgery in gastric cancer. But all this is under study settings, and we don't have the results so far, so that we can say this patient can take this treatment as a standard. In the most institutions, once we see peritoneal carcinosis, these patients go to the palliative scale of treatment.
Thank you. Dr. Dimitriou.
We would do in this case cytoreductive surgery without HIPEC. So the HIPEC data in these cases in gastric cancer are not good. Even with just mitomycin, they are just like okay, but really with very good willing. So I think it depends on the PCI score, and the local peritoneectomy is a goal for the patient with a gastrectomy. Yeah, but just with intensive chemotherapy afterwards. But the HIPEC in gastric cancer is, the data are not good.
Yeah. In France, we had a double-blind prospective study, Gastric, which randomized patients with T3 or T4 and with preventive HIPEC. So we don't have, the study is closed, but we don't have the results. Haralambe, thank you very much.
Thank you also.
So I'm really glad to present Dr. Ioannis Dimitriou, who is general surgeon, head of the surgical department of the St. Barbara Hospital in Gladbeck and St. Marien Hospital, Gelsenkirchen, Bauer, Germany. Yanni.
Καλημέρα. Ευχαριστώ πολύ για την πρόσκληση. Thank you very much for the invitation. I'm very happy to speak here for all the Greeks of the diaspora. Yes, I'm head of surgery of 2 departments, and I have a few Greek doctors in my team, and I'm very, very glad that they came from Greece to Germany, like Dr. Kanakis from Rhodes. And I want to speak about surgical treatment of locally advanced pancreatic carcinoma. And for a surgeon, the first slide is the best I could finish my talk after the first slide because curative treatment of pancreatic carcinoma, surgical therapy is the only potentially curative treatment for pancreatic cancer. So the point is, which cancers are really good for surgery, which patient and which cancers, and where is the end? Because we surgeons, we all know it, sometimes we are like little kids and we just want to play and we don't find sometimes our end, so we have to protect the patient from ourselves. Okay, chemotherapy or radiotherapy should not be given to patients that are judged to be resectable. There are really good data from Doi et al. The thing with the minimum number of cases, it's really difficult. The data are not good, and the point is not how many pancreatic complex surgeries are given in hospital, but the point is we need an entire quality of hospital structure and processes. We need interventional radiologists, we need endoscopy 24/7, and of course in experienced ICU and IMC in case of a complication. So preoperative staging laparoscopy, we just heard it about the gastric cancer. It's not so en vogue like in gastric cancer, but it's coming even more and more, especially in cases in the CT scan clinical suspicion of peritoneal carcinomatosis, when you see ascites or when you have a CA99 that has more than 500 without cholestasis, you can handle this. And we know that up to 1/3 of cases reveals findings which exclude curation in surgery. So the surgical goal is the resection in health, in a healthy state. We know then the patient has the greatest chance of long-term survival, and the prognosis is better further the tumors from the resection margin. But the problem is every resection in health a resection in health? So what do we need? We need standardized marking by the surgeon. I think that is the most important thing. And important mark, the surgeon has to mark the retroperitoneum. That is the green mark. We just need for sure the D. Pancreatic surgery, head resection without the D mark it's wrong. It's not just not good, it is really wrong. So we need that to say, what about the R status? So of course we need a standardized histopathological workup and an extension of the R classification, the CRM concept, but I think the circumferential resection margin is even more coming. So we don't need here. So what about the criteria for resectability? We have the ABC criteria, C for condition. The age of the patient is not a criteria for refraining from section, okay? And we have the ECOG status, so the patient has to be fit. We have the biological criteria. I'm a surgeon, so I will skip this slide. And I'm coming now to the really to the anatomical criteria. For sure, we need at the beginning good contrast enhanced CT imaging. Anyway, we need a CT scan. it's not enough to have an MRI. The MRI and the MRCP is not enough. We need a contrast-enhanced CT imaging for seeing what about the vessels. Are the vessels involved or not? I stopped, like just 1 year ago, we did a CT scan and afterwards an MRI. Now we don't do an MRI. We stopped it. And very important, tumor infiltration into neighboring organs should not be a contraindication for oncological tumor surgery. That is a really very important point. The vessels are the problem. So contraindication with respect to the locoregional vessels, okay, infiltration of the celiac trunk, the superior mesenteric artery, of course, the aorta, the hepatic artery, the mesenteric superior vein. And now what about the portal vein? We all know in case of infiltration of the portal vein. So the resection, it depends on the status of infiltration. The resection is possible with a portal vein resection, and the most common resection is the tangential resection. The graft resections has really more complications. The end-to-end anastomosis is a second point of finding the goal. So pancreatic head carcinoma, we know all the Kausch-Whipple procedure, all the pylorus preserving Traverso-Longmire procedure, and in rare cases we can do pancreatectomy and the resection of other organs. So what about the lymphadenectomy? Here the data are, in Europe we do the lymphadenectomy, and in France and in Germany, especially in France, we do it really, 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 really good, I think so. And we need at least 12 regional lymph nodes, and the pathologist should show us the ratio of affected lymph nodes to total lymph nodes, so the LNR. We don't have any goal for the patient with an extended lymphadenectomy, so we should not perform it. And now what about laparoscopy? We hear a lot about laparoscopic approach and robotic approach, and the Dutch Leopard trial showed us that the distal pancreatectomy can be performed for pancreatic carcinoma if the surgeon has experienced. The data for the pancreatic head resection are really bad, like a lot of studies are were really stopped because of death. So we need more data for pancreatic head minimal invasive surgery, and of course I think we need more experience in robotic surgery. I think that will be maybe inexperience and the possibility to do it minimal invasive in a laparoscopic way. So now the a bit of theory ends. I want to show you just two cases. Here's one young patient with a distal carcinoma. With a distal carcinoma is showed here, corona and axial. And okay, the video's already started. I just want to show you the laparoscopic approach. Laparoscopically, it's really easy. It's much easier than in open surgery. We just see, we open the bursa ommentalis, we do the flexure, we see the carcinoma, we do the preparation down there is the pancreas. We are just finding the lienal artery over there. We do now the transection of the lienal artery, and just clip it, and it's really not so difficult. Afterwards, we can go on the lower part of the pancreas, prepare it. We have a much better view than in open surgery. We see there from the lower side of the pancreas the lienal vein, and we dissect the vein and do the transection. And it's laparoscopically just easier because you see it just better. And with in robotic surgery, you see it even better. So it's really easy, and if it's easy for the surgeon, then it's good for the patient as well. So that is the patient 1 day and 5 days after the surgery. On the 5th day, on the 5th post-operative day, the patient was released from hospital. And you never see this in open surgery with a laparotomy from the left side to the right side. Never. So now I want to show you some multivisceral resections. Here we have a patient with an en bloc Whipple procedure with right hemicolectomy. The tumor was involving the meso of the right hemicolon. You see here the preparation is a bit different than in the standard preparation of the Whipple procedure. We start the vessel preparation from the superior mesenteric vein. We do so the transection. Here's the resections. You see on block the Whipple resection and the right hemicolon. It's the preparation at the vessels are not so easy, but it's at the end you are really happy that the patient has an resection in health status. Here you can see the situs after the resection. And it's really not a problem. The patient was like 2 weeks after the surgery in hospital and could go home. So here another multivisceral patient resection with en bloc Whipple procedure with tangential resection of the portal vein and right hemicolectomy and right nephrectomy. It was a young patient. It was his own a way for living, and we did a resection in health, but the patient of course needed afterwards chemotherapy and died 14 months after the surgery. So just a few pictures of reconstruction. I don't know if you are surgeons, you know it. It's a standard procedure, the pancreatic anastomosis, the biliary anastomosis, and of course the other anastomosis. So some impressions. Thank you for your attention.
Thank you very much, Jens, for your excellent talk. Very clear. Are there any questions from the floor? So, you know, if they asked me to do this surgery, this talk, I would point exactly the same points as you. So you spoke of everything in a very clear way. I just want to ask you a question. For a portal vein reconstruction, except for portal vein, would you consider any other vascular reconstruction for pancreatic surgery?
No, the point is there is a triangle operation. I don't know if the triangle operation for cancers of the body with caval vein reconstruction and of course arterial reconstructions. But the long-term survival is not better with surgery. So we don't do this. Okay. I don't do in pancreatic cancer, we don't do any arterial reconstruction.
Thank you. Thank you.
I have one question for our radiation oncologists. You know, in Europe, in Germany, but also in Europe, we are kind of reluctant to do preoperative radiotherapy or radiochemotherapy in pancreatic cancer. I hear it's still relatively standard procedure in borderline resectable cases.
Yes, and there are procedures, that you can do. We do fiducial placements and SBRT procedures with radiation, different protocols to upfront. Although I must say it really is institutional dependent, and in many centers we have phase 1 trials, and we're not adopting pre-op radiation. So I think that's also moving in that direction in the US as well.
The last question for Yanis.
Yeah.
You're very clear about laparoscopic procedures for tumors of the head of the pancreas, and I think everybody is okay with what you said. Do you think that robotic surgery would probably overcome limitations of laparoscopy?
Yeah, I'm doing head resections in open way just now, and I never tried in laparoscopic way because the data are really not good, and we wait for the new data from the robotic system. We in our hospital we just do left resection with the robota, and of course colorectal surgery in cancer. But I think there are a few much more experienced departments that are doing head resection with the robot. I think in 2, 3, 4, 5 years, the data will be clear. But I hope the robot will open our eyes.
Thank you very much. Thank you again. I'm happy to present my co-chair, Professor Stella Limberis, who is clinical professor and director of quality initiatives in the Department of Radiation Oncology in the Grossman School of Medicine, New York. Stella.
Kalimera sas. Thank you. It's such an honor and privilege to be here today. It's the first time that I'm giving a scientific lecture in Greece, and it's a very moving experience. Thank you. Θα σας μιλήσω σήμερα about brachytherapy. And we really stand in the shoulder of giants. It's important to pay tribute to George Papanikolaou, who is also the founder of the Hellenic Medical Society in New York, where I have served as vice president in the past. And he is a Greek physician who we all know, pioneer of cytopathology and early detection in cervical cancer. May we all strive to make contributions in medicine like distinguished physicians like George Papanikolaou. My specialty is in brachytherapy, and it's a technique where we can deliver radiation into the tumor using catheters. And the word brachytherapy also derives from the Greek, the word for short, brachis, referring to the distance between the therapeutic target and the lesion. This is an example of a case that I have performed for cervical cancer. And as you see, we are basically delivering radiation within the woman's uterus directly to the cervical tumor using catheters. And the radiation source is demonstrated. The isodose line in yellow, it depicts the 100% isodose line delivering 7 gray of radiation to the cervix and uterus. Imaging has really improved our conformal ability to treat cervical tumors or GYN tumors, and it really has supplanted. When I was a resident, we had 2D imaging and then CT imaging, and then now we are using MR imaging, and the tumors appear enhancing and hyperintense on T2 imaging. And really using MR imaging in treatment of tumors with brachytherapy is essential, and different protocols need to be used so that we can better delineate the gross tumor volume and targets. We also benefit from PET-CT imaging for nodal staging, and you can see here that's metabolic imaging that shows activity of the tumor metabolically. From Vienna, Austria, for the last 30 years, there's groups that have integrated the use of MR imaging to better delineate targets, as summarized in the JEC-ESTRO guidelines. But now we're moving into doing more interstitial. Here you see there are multiple catheters that we're placing in the tumor, and that gives us better geometry. When we put one catheter, you can only have a radial delivery of dose. By putting asymmetrically left and right multiple catheters, you can deliver more dose to the right or the left and better conformally target your region. That requires skill and experience in the OR to place the catheters, but it's a lot of fun and very gratifying that we can better target the tumor and spare normal tissues, including bladder, rectum, and small bowel toxicity. We also take pride in thinking of quality of life and toxicity from our treatments. We use, for endometrial cancer, most women, to reduce the risk of local recurrence, we use something very simple, which is vaginal brachytherapy, which is just a cylinder in the vagina to treat the vaginal cuff and reduce the risk of local recurrence. We have seen that for women that sexual function is important and it's something that they are concerned about. By fractionating treatments and giving more treatments, you can actually spare the mucosa of the vagina and reduce the scarring that can happen, narrowing and shortening of the vagina. So I think it's just an important comment to make, even though internationally, I think the most common regimen is 7 grade times 3, which is only 3 fraction. By reducing the number reducing the dose and increasing the number of fractions, you can spare vaginal toxicity. And as a radiation oncologist, I think what is most paramount is really reducing late effects, toxicity from radiation. And that's what our patients want. And that's what, as doctors, really we need to concentrate on as we deliver care. Another advance in radiation oncology is the utility of intensity modulated radiation therapy, otherwise known as IMRT. What this is, basically in the past, we used radiation in 4 fields. So we were treating just from the angles, left, right, and post, and we would deliver a dose that was a square. You see in yellow, it's just a square. That doesn't really conform well. You treat a lot of small bowel, a lot more bladder, a lot more volume. With IMRT, we can create the U shape that you see on the right. That is basically the radiation is delivered circumferentially from around the patient, and we can actually create different shapes of the isodose conforming radiation and spare, again, acute and late effects. Multiple studies have demonstrated efficacy in this, comparing the 2 techniques, and we actually have insurances that pay for the advanced technology because of the demonstration of improved reduction in GI and urinary scores, as you see here in the RTOG 1203, that led to payers actually allowing the use of adopting this technology, even though it's more expensive because of the benefits, both short-term and late effects, including small bowel obstruction or other complications that would happen late after radiation, which are greatly reduced. You can see the benefit in early endometrial cancer here, high intermediate risk. There was a study, GOG 249, that compared pelvic radiation with vaginal brachytherapy and 3 cycles of carbotaxol. And the take-home message, this is the eligibility criteria, including stage 1 and 2. The take-home message is that even though the relapse-free survival and overall survival is the same, the acute toxicity from radiation was remarkably less. So the pelvic radiation, 11% grade 3 toxicity, vaginal brachytherapy with chemotherapy, only 3 cycles of carbotaxol, 64% acute toxicity. So again, another point, we should be using pelvic radiation more. With IMRT, we can really make a difference. Just want to jump to stage 3 endometrial cancer. 2 large trials, the PORTEC-3 and GOG 258, comparing basically as their experimental arm, radiation and chemotherapy versus pelvic alone in the PORTEC trial, and GOG 258 comparing the same arm of chemoradiation with chemotherapy alone, 6 cycles of carbotaxol. Overall, the survival overall survival was not different, but I think, again, I just want to make a plug for the benefit of radiation to prevent local recurrence. That's what we're good at. We're good at controlling the nodes. We're good at controlling the pelvis. And in GOG 258, there was a statistically significant reduction in pelvic and periaortic recurrence that you see here in red. That's the chemo alone arm, and you see a distinct reduction. So really, you have to tailor the treatment. And I think in stage 3C1 endometrial cancer that has nodal involvement, there is an important role in utilizing radiation. But we are moving to the molecular age, okay? Finally, in GYN, we have trials that are actually looking at molecular characteristics, because not all endometrial cancer is the same. And we're waiting, and we're very excited about the trial of PORTEC-4A that is looking at tailoring treatment based on molecular characteristics. And we already know that, and we are already utilizing in the clinic, that POLE mutations, for instance, have very low progression, an excellent prognosis and very favorable. And maybe they don't need those patients don't need chemotherapy or chemoradiation, or perhaps any treatment at all. So it's a very exciting time. I think over the next decade, we will learn more as we integrate molecular diagnosis into our management. Just want to show you a couple of examples of things that we do in the clinic. This is an example of a case of medically inoperable treatment with brachytherapy alone that could be utilized for patients that cannot tolerate surgery, and has excellent result in controlling bleeding, and even can be utilized for curative intent. What I most enjoy is practicing interstitial brachytherapy with multiple catheters. Those are cases that are very challenging, and each case is very different. Try to figure out how we're going to get to the tumor, how we're going to access it and deliver radiation. This is a template that is utilized perineally with the vaginal obturator, and we guide different needles, as you see, into the patient. I'm going to show you an example of a recurrent endometrial case at the vaginal cuff. This is the tumor pre-external beam radiation, demonstrating after 5 weeks of chemoradiation excellent response. This is what it looks like when you place the needles. I know it's kind of graphic and it looks pretty scary, but the patient is obviously under anesthesia, and we place the needles in collaboration with our surgical colleagues with laparoscopy to reach the vaginal cuff, as well as kind of reach the peritoneum. Your goal is to pass the needle a centimeter above what you need to target. So, you really want to get to that peritoneal reflection. And you see here we're demonstrating the sigmoid, moved all the small bowel out of the way, and demonstrated good position of all our needles. We use CT for planning, but really MRI is the standard for any tumor delineation. And this is an example of a case that I did with a pre-plan on the left, and then the actual needle placement on the right, allowing us to move the dose not just in a circle, but really extend laterally to cover the extent of the tumor disease. Thank you so much.
Thank you very much, Stella. Any questions? Vasily.
Thank you, Stella. It was very interesting. I was thinking of nanotechnologies as the ultimate, brachytherapy, because the nanoparticles, they really go inside the tumor. And I know of some companies, Nanobiotics in France, but you may know of others that develop these methods of, nanoparticles that are charged with radiation, and then they deliver the radiation really inside the tumor. So do you explore, what do you think about these technologies? And can they function also in synergy? Can you imagine external radiation plus kind of nanoparticles, and how can this be developed?
Yeah, that's very exciting. I'm not so knowledgeable in that delivery. I think the challenge is, as a chemical engineer, we many years we've been studying delivery. The question is the penetration, and how you get to the tumor. What I think is moving, we're using imaging more. And in radiation oncology, the MR-Linac technology, I think, will be revolutionary. We're going to be adopting one at NYU, but most centers doing research already. And even in pancreatic cancer, there have been some exciting work where basically each day you will be able to image with MR imaging and then do adaptive planning and replan for the next day. Right now we do a plan and we deliver the radiation for 5 weeks based on that day. I don't know, and then 2 weeks for planning with a physicist, and then we start. So with all of these, all of the cancers, all the GI cancers, which really MR targeting, I think is beneficial. Having that in real time and replanning will not only reduce the toxicity from radiation because you can be more conformal, but will be more accurate. Nanotechnology, we're not really live with that yet. But I think that is something that's very interesting. But with radiation, you also have to think of the dissemination, right? So the delivery, whether it's with polymers or locally, you have to be very accurate in the delivery. You don't want systemic circulation of a nanoparticle. So I think there's many components in that technology to make it effective, but surely, in oncology, it moves so quickly. Every 5-10 years, we have new developments. So it is very exciting to keep abreast of that.
As regards nanoparticles, we have some experience. There was a study in France with hafnium nanoparticles for lymphsarcomas that have been used as potentializers of radiotherapy with very good results. And now worldwide, there are many trials. The cases that are most that will benefit more from this type of potentialized radiotherapy are cancers that we will not operate. So cervical cancer, for example, I think it's good cancer, but cervical.
But we get to it. We can get to it.
We're going to get it.
We can access those tumors, but for the ones we cannot, I think that is very interesting.
I think that all pathologies that you presented, Stella, are a very good example of how technological advances have really, really changed the care of these patients. I would just like to ask you, a lot of these cancers happen to young patients. How do you deal with personal issues and sexual issues?
Yes, it requires a trust in a relationship. I think that the most crushing diagnosis is for our premenopausal patients, whether they're diagnosed with breast cancer or with a gynecologic cancer, early cervical cancer, or late cervical cancer at a young age. Losing fertility at such a young age is devastating. We do take steps to try to do whether it is like harvesting or actually have frank discussions with the patient on their wish to carry a pregnancy if that's possible. But sometimes it's really the time is not there. You have a 6-centimeter tumor in the cervix. You really don't have time to lose time to do ovarian transposition or to harvest eggs. So you have to be frank about it. I've seen many young patients, advance to metastatic disease and die within a short time. So we really, I think, ethically have to not be afraid to have the honest discussions that this is serious, that time is of the essence, and we really have to begin treatment right away, kind of like a mother would, but a physician mother that is looking for the best for the patient. There's a lot of fear about radiation. There's a lot of misconception about the treatments, but actually you can help, again, by developing that relationships, not being afraid about asking sexual function questions. Is the patient sexually active? Do they wish to be? Is that something important to them, even though they don't have a partner right now? empowering them, and teaching them how to use a vaginal dilator and telling them how important it is to use it consistently, so that they are able to be comfortable and not have problems like painful intercourse and dyspareunia and other complications down the line. But I think first, as physicians, we have to be comfortable to ask those questions and be okay with asking whether it is any sexual orientation, whether a woman is engaging in what her practices are, and be comfortable with that. So you have to first look within, and then you can really have those discussions with your patients. But I think that's really important. And we talk about sexual function with men. I think we've been doing it with prostate cancer for a lot longer, but it's happening for women too, and it's okay to want to survive cancer, but also have to reduce these side effects and with survivorship, address sexual function, frankly, and and reduce the stigma about it.
Thank you so much.
So it's my pleasure to introduce Aristotelis Ioannidis from Clinic for Oncology, Hematology at the Marian Hospital, Düsseldorf. Thank you.
Thanks very much for the invitation. And I realize this is the mostly surgical and radio-oncological symposium, but I'm going to tell you about the new developments in oncology and hematology in internal medicine. And let me start from Paul Ehrlich, who in 1908 got the Nobel Prize. You see how they worked at that time with literature that was piling up in their office. And B, he introduced the notion of magic bullet by saying that we would have drugs that are aimed at one single target. And he also introduced the notion of antibody. He had the side chain theory, for which he got the Nobel Prize, and was really the first to understand that there are receptors on cells, and that these receptors could be targeted. And then later also developed a drug with a Japanese co-worker, and this was the first successful synthetic drug in infectious diseases. So if we want to go into precision medicine, there are different things that we need to talk about. It's that we have genetic abnormalities, which may be isolated or may be very complex, that we can get to those genetic abnormalities by gene inhibition or by viral vectors, that we may inhibit pathways, that we may inhibit surface structures like checkpoints, or that we may guide the immune attack of the body against certain tumors. And one very important example is chronic myeloid leukemia. You know that chronic myeloid leukemia is a disease that is fatal and that leads to death in a median time of about 2 to 3 years. It's a translocation between chromosomes 9 and 22 that happen. And this translocation leads to a genetic abnormality called BCR-ABL translocation. And this BCR-ABL translocation leads to proliferation of white blood cells. And these white blood cells at some point transform into leukemia, and that leukemia kills people. And when you look what happened in the past, this is a monogenetic disease. It's just BCR-ABL, which is translocated and rearranged. And you see that people died between 1965 and 1975, an age where you couldn't do much about the disease, within 3 years. And you see that nowadays, after 2000, you see that overall survival is dramatically improved. These people take 1 tablet a day, and the survival is about 90% after 7 years. So are there other examples of monogenetic diseases in hematology and oncology? Yes, there are. We have acute myeloid leukemias, we have lymphomas, but we also have solid tumors, melanoma, we have non-small cell lung cancer, and many others, which have specific aberrations, gastrointestinal stroma tumors, etc. We know that these aberrations, genetic abnormalities, can be targeted with single drugs. They may not be fully functional as in the BCR-ABL, but in combination with chemotherapy or with other therapies, we do extend lives incredibly at this point in time. And then we have specific cell structures on the surface of tumor cells, and we are targeting them with monoclonal antibodies, and that's the map in the word of the antibody. So you have rituximab in B-cell lymphomas, ofatumumab, it's all maps because it's monoclonal antibodies, alemtuzumab, daratumumab, but also in solid cancers, we have monoclonal antibodies, cetuximab, bevacizumab, etc. And they are being developed at a pace that we as oncologists struggle with really knowing the latest innovation because you have to be reading all the time to stay abreast of these developments. The next thing is pathway inhibition. So you know that a pathway in a cell, a signal transduction is activated, and you want to inhibit this pathway. So that's like you want to come into this room and you close the door. Obviously, some people will find another way to come into this room, but still closing the door will probably inhibit 90% of people from entering the room. And this is what we are doing with EGF receptor inhibition in non-small cell lung cancer, with B-cell receptor inhibition in lymphomas, and lately also in colon cancer. Some subtypes of those colon cancers have KRAS mutation, and special KRAS mutations can now be targeted with special drugs. And one very important development, albeit it's only feasible in 1 to 2% of patients, but one very important development is that you have tumor agnostic applicability of those drugs. For instance, if you have the neurotrophic tyrosine receptor kinase NTRK rearranged, you can give an NTRK inhibitor, and that's actually been approved for all types of cancers. Whenever you find NTRK, you can actually use the drug. So that shows that it has gone beyond, I have this type of cancer and need this type of treatment. We do have the possibility now, and probably we will get more possibilities in the future of extending treatments to a large number of tumors, independent of the organ of disease. Another example of this kind of inhibition is in breast cancer. We have cancers that now can be treated with a tablet. These are hormone receptor positive cancers. And what you do is that you inhibit the transformation, you inhibit the way the cell can proliferate. You don't let it go from G1 phase into S phase. And this is being done by inhibiting cyclin-dependent kinase 4/6, which needs to associate with other cyclin-dependent kinases, and you can inhibit that. And by doing this, you get nice tumor regression, you get doubling of overall survival time, and it's just a tablet. You don't have the tremendous hair loss that you see with chemotherapy. You have much improvement in well-being of these patients, and it's been a fantastic development. And therefore, even in the American Barron's magazine, you see that the gene therapy revolution gets real, and that's true. It's an enormous development that takes place at the moment, and I think also for investors, it's a fantastic opportunity of investing. One last point is the checkpoints. The checkpoints, in the past we had the checkpoints in the middle of Germany. That was checkpoint Charlie between the Russian part of Eastern Berlin and the western part. On the cell surface of a tumor, we have so-called checkpoint antigens, and they are called programmed death antigens, and you have programmed death receptors on the T cell, which usually is there to kill a tumor cell, and you have the ligand, the programmed death ligand on the tumor cell. And if the tumor cell expresses this programmed death ligand, the T cell cannot dock on and kill the cell. And what has been developed are so-called checkpoint inhibitors. So you actually inhibit the programmed death ligand 1 or 2, and by this, the T cell can actually attack the cell, and this leads to dramatic improvements in overall survival. We see now patients who would have died after 12 to 16 months, we see them live over 5 to 10 years actually with tumors. First, it's been developed in melanoma, but now we see this in many different tumors, and it's a development that has just started and is probably going to be continued. And as I say, every 2 to 3 weeks, every 2 to 3 months, we have new additions to this development. And here you see the different responses that can happen. You have the conventional response with shrinking of the tumor. You have slow tumor regression, or you have initial progression because tumor cells now, the T cells now invade the tumor. It actually blows up, and then it actually shrinks and vanishes. And that's actually pretty difficult for our colleagues of radiology and us oncologists to actually make up our mind whether it's safe to continue with the treatment or whether we need to change the therapy. And the latest advancement is CAR T cells, which stands for chimeric antibody receptor T cells. And that means that you take a T cell, a cytotoxic T cell of the patient, and you insert a receptor into that T cell. So the T cell can recognize a structure which it could not recognize beforehand. So that means that this cytotoxic T cell now attacks certain structures on the surface of cells, of tumor cells, obviously. You're trying to find structures on tumor cells, and you express those receptors in the T cell, and then the T cell attacks the tumor. And it's absolutely incredible that you see patients who actually would die in the next couple of weeks or so, and then you treat them with the CAR T cells, and the tumor actually can be controlled. It's mainly in hematology that we use CAR T cells, but it starts also in solid cancer with some caveats and limitations. That is that we actually target a single target. Okay, we have one receptor, and that is a single target. So if the tumor sheds the target and evolves without that receptor, then you have a problem. And then the other problem is how long will the T cell persist in the body of a patient? So if you have a patient's T cell and you give it back to the patient, but how long does that cell live in the body of the patient to actually kill tumor cells? So wrap up with the last slide. There is a fundamental change in treatment in hematology and oncology. Over the next couple of years, we will have novel treatment strategies. We will need to amend our response criteria. Imaging techniques will have to adapt. We will have a further specialization in oncology because it becomes ever more sophisticated. And obviously, we'll have more and novel interdisciplinary activities that will emerge. Thanks very much for your attention.
Excellent talk. Aristotle, can you tell us about the management of complications after immunotherapy treatments?
So that's a broad field. If you look at the checkpoint inhibitors, what we see is that checkpoint inhibition may lead to untoward effects regarding endocrine functions. That's easy if it's the thyroid gland, then you give them thyroid replacement therapy. But it may also lead to hepatic, renal, or gastrointestinal dysfunction with severe diarrhea, with renal impairment, with hepatic impairment. And then you have to stop the therapy, give them corticosteroids, give them immunosuppressants, and see how you can manage that. With CAR T cells, it's even more difficult because CAR T cells may lead to tumor lysis syndrome. So you actually put the T cell to the attack, and it attacks all of the tumor at once, and it leads to enormous lysis, can lead to very strong side effects. You need a very good equipped intensive care unit, and what is being developed in hematology at the moment is that you introduce into the cells so-called death switches, so that you can say, okay, you are overdoing it now, and then you activate the death switch in the cell, within the cell, and you switch down the cell, and this untoward effect will vanish.
Questions?
Maybe you take the other one.
Okay, thank you. Very interesting. Thank you for the nice overview. I have a question about the essentiality of all these abnormalities and pathways that are targeted. So in the BCR-ABL example, obviously the mutation is a main oncogenic driver and is essential to the development and the survival of the CML clone. In many other situations, there is a big variation about how essential is the pathway to the tumor. So you find 100 tumors with the same mutation or the same expression activity of a pathway, but those are do not have the same importance for the tumor from one patient to the other. So what is your view of estimating this essentiality of a pathway in a tumor in order to better drive the treatments to where the pathways that are most essential?
Yes, so you are absolutely correct. There are rare examples of monogenetic diseases where you actually switch off the gene rearrangement and kill the tumor. That's CML. That may be hairy cell leukemia with BRAF. You may inhibit BRAF well, but in other cases, just incremental. So in acute myeloid leukemia with FLT3, adding a FLT3 inhibitor will improve like 5 to 7% long term. You may have IDH1 and 2 abnormalities, and adding an inhibitor in acute myeloid leukemia will again improve survival by a couple of months. And I think that's actually development in progress. And what we need is artificial intelligence, because we need somebody to tell us where does the pathway find actually a way around the one that we inhibit. So we inhibit FLT3, but then it activates some other pathways and becomes even more aggressive. And then, if we knew this from the beginning, we would actually add 2 or 3 inhibitors and improve, improve our treatment. So in this case, this is what we need probably from artificial intelligence.
Yeah, to plant multiple hits. Yeah.
It's like heart in AIDS. You have highly active retroviral therapy because you use different structures of the virus that you inhibit, and then you can get the results.
Thank you very much, Mr. Ellis. I'm really glad to introduce Dr. Lorraine Chrysomalis-Valasiadis, who is a specialist of obstetrics and gynecology, but not only. She's a very active vice president of the Hellenic Medical Society of New York. And Lorraine, we know that you gather around you at least 40 or 50 young doctors of Greek origin. Please.
Thank you. Good morning, everyone. It's really a distinct honor and pleasure to be here amongst all of you and to speak to you at the first ever Hellenic Global Medical Conference in Thessaloniki. I would like to congratulate the organizers for taking on such a huge feat and for including me. Thank you. Today, I will not be presenting original research, but instead I'll be speaking to you about something that I have a real passion for. I want to use this forum so I can share some important information so that we can all join forces to eliminate cervical cancer around the world. Cervical cancer is the fourth most common cancer in women worldwide. In fact, 500,000 women are diagnosed with cervical cancer annually, and of these, 300,000 actually die. That's one woman every 2 minutes. Here we see a slide of cervical cancer worldwide, and what's important about this slide is to note that about 90% of the cases occur in the low and middle income countries, such as Africa and South America. In the high-income countries like the United States and Australia, the incidence and mortality of cervical cancer have radically decreased due to screening and vaccinations. With regular screening, you can prevent the progression of cervical cancer as shown in the diagram from left to right here. So on the left, we see a normal cervix. And on the right, we see a cervix that is friable lesion that's fungating. This one shows invasive cervical cancer. Now let's talk about the culprit. HPV, the human papillomavirus. This virus has been so closely associated to cervical cancer. What's most important to know about HPV is that it's transmitted through touch, not only through sexual activity. So most people who have HPV do not develop symptoms for the viruses. In fact, 90% of the cases, the body's immune system just clears it naturally. However, to date, there's no accurate way of knowing of the people who get HPV who will go on to develop cervical cancer or any other health problems. Now, one way to prevent HPV is by causing cervical cancers by administering the Gardasil vaccine. It's important to get the vaccine before getting exposed to the virus. In the schematic shown, we can see what happens in the two different scenarios. On the left, when the vaccine is not present, you can see that the antigen or the virus is just attacking the cervix directly. On the right, when the vaccine is administered, the antibodies form these immune complexes with the antigen, and the body recognizes that as foreign, and the immune system just clears it naturally before it even gets to the cervix. Now, what are some of the recommendations about vaccinating the young? The CDC recommends that you vaccinate children between the ages of 11 and 12, and it's approved for use in both boys and girls in the ages of 9 to 45. If given before the exposure to the virus, it can prevent genital warts, vaginal, vulvar, anal, and cervical cancers. And now, vaccinating boys is critical as they function as vectors and they can transmit the virus. Let's talk a little bit about HPV, the vaccine effectiveness. Since the vaccine was recommended about 15 years ago, it's radically decreased the incidence of HPV infection, genital warts, and precervical cancer. It's most notable in the countries that have implemented these public health measures, such as mandatory vaccines, accessible vaccinations, and increased screening recommendations. In this map from the WHO from 2020, we can see that the countries that participated in the National Immunization Program, we can see here that America and Europe have the highest rates of vaccinations at 85 and 77% respectively. We can also see there's still very many countries that have not implemented these national immunization programs. And in this group, this is where we see the most active cases of advanced cervical cancer. Now, what are some obstacles to getting this HPV vaccine? Some are just this lack of awareness of the perceived risk of cervical cancer. There's also a stigma associated with it because of the sexual activity and the concern for safety. Others are cost and availability of the vaccine. Let's talk about HPV vaccination in Greece. In Greece, there's a national program that actually funds vaccines, and they're available free of charge. This is a wonderful thing. However, in Greece, there's no official registry for screening and HPV vaccination. The general consensus in Greece is that 30 to 40% of women are vaccinated. In the US, we do a little bit better. The rates are closer to 55% for the fully vaccinated, and about 74% of women actually get screened. However, Australia is the country that's leading the pack in that 80% of females are vaccinated there and 76% of males are vaccinated there. So since 2007, Australia has actively been trying to decrease the rate of cervical cancer. And in fact, there's been a 92% decline in the prevalence of HPV. Now let's just talk briefly about the goals for the future. The WHO has set standards of 90, 70, and 90 for the age of 2030. Now, what do these numbers mean? Well, ideally, we want 90% of the girls to be vaccinated by age 15, 70% should be screened at 35, and then again at 45, and then 90% should be screened with precancerous lesions, and others should be treated, and the others should be managed, the ones with the invasive cancer. Together, we can all work together to achieve these numbers. So let's join forces to reach these goals and help eradicate cervical cancer globally. I'd like to dedicate this talk to my two daughters, Nicole and Victoria, and to my office assistants. I hope that cervical cancer is a disease of the past during their lifetime. I'd also like to give a special shout out to someone who's in the audience. That's Panayota Zisiadis. Panayota was probably one of my most challenging deliveries in 1997, I must tell you. She's currently a medical student here in Thessaloniki, and it's only fitting that she wants to be an OBGYN. I thank you for your attention.
Lorraine, that was an excellent talk and very inspiring. I wanted to ask the audience, do you know any relatives who have children of this age that have received the vaccine? We vaccinated our kids, boy and girl. Okay, so there's some hands, which is encouraging. Lorraine, also for the young boys, for the oropharyngeal cancer, we know that has been rising, and radiation for oropharyngeal cancer can also have so much toxicity. And since it could be so easily prevented, another plug that we should be vaccinating boys and girls, not only for cervical cancer, but also for oropharyngeal cancer, which is actually rising in the US and I don't know, in Europe as well. Any other questions?
Hi, my name is Flora Conta-Georges and I'm from South Africa. And we have a huge challenge facing female health in that a large section of our population is HIV positive, as well as HPV high risk positive, and do not have access to screening. So most of our screening is done at primary healthcare centers, by nurses or midwives or family practitioners. The second challenge that faces our country is there are cultural stigmas, and there's a very small group of young males being vaccinated. What would your advice be when it comes to screening? Because we're pushing to screen on an annual basis, if we possibly can, particularly our high-risk HPV positive, HIV positive young females, because there are implications for fertility. And in Africa, as you well know, fertility is very important to our socioeconomic setup.
I agree. I think that getting them screened yearly would be a great thing to do, just because they are a high-risk group. It must be very challenging for you there. I'm so glad that you brought up the point about HIV. Yeah, thank you for that.
Secondly, I'd like to ask, because we have a huge section of our population in rural areas, they do not have access to a female midwife, female primary healthcare worker, female doctor. Are there any other ways to get screening? I've heard that in the States they are making progress in using, I think it's a tampon that you insert rurally as a woman, and it is sent to a local lab via courier, and it gives some evidence as to which patients have progressed and have either atypical cells or CIN or SIL. Is that available in the States?
I haven't used it in New York, but I'm sure it might be somewhere else. I really don't know that much about it.
I think it would be an
Seems
option.
reasonable.
Actually, I think they're developing just from the sanitary napkins.
Yes,
like
yes.
And even menstruation.
Yes.
Just giving a sample, you can detect HPV from that. So there's different concepts to do that I think would be
very interesting for our country.
In South Africa.
Thank you very much. It was truly an amazing talk.
Oh, thank you. Thanks for that.
Okay. I'd like to introduce next Dr. Nikolaos Vasos, Professor of Surgery from the University Medical Center, Mannheim, Heidelberg, Germany.
Thank you for the kind introduction. I would like to thank the organizing committee for inviting me to participate in this really interesting conference of the Hellenic medical diaspora and to talk about the advanced surgery and the locoregional therapies for soft tissue sarcomas. We do know that surgery remains the main cornerstone of treatment in this kind of patients. But in order to achieve a good quality surgery, some conditions are required, and we have to follow some rules too. So we do need excellent knowledge of anatomy and anatomical planes, and appropriate imaging and accurate biopsy and pathology, which is decisive for the surgical approach, and a well-trained and experienced surgeon. So the goal of sarcoma surgery is the unplugged surgical resection of the tumor with clear margins, and at the same time, the function-preserving lymph conservation. So during the last decades, we had the term compartmental resection. This term was introduced in the 90s by the orthopedic surgeons and actually was used mostly for the bone sarcoma surgery. But during the last years, a question actually has been raised. If we have, for example, a tumor in the vastus medialis, a small one, why do we have to resect the whole anterior compartment? So actually the term that we have introduced the last years is the compartment-oriented resection. In these terms, we do perform a wide excision for low-grade sarcoma and a radical resection in terms of compartment-oriented resection for high-grade sarcomas. Of course, we have to consider, though, that in any case, the surgical strategy, the resection strategy, has to consider the subtype of the tumor. So in this case, for example, we do have to consider the strategies before the operation, and we can see here that we have to perform a vessel replacement, and at the same time, we have to perform a epinurectomy of the sciatic nerve and a resect of the crest of the tip of the bone. So the key is to start thinking even before the operation. Having, for example, here recurrence of a lipomatous tumor in the thigh, of course, actually, we have some problems, which are, for example, the recurrence, first of all, the deep location, the location down to the hip joint capsule, the location that is behind the femoral vessels, and the question if it's actually this tumor is a real lipoma. And it was performing, of course, a preoperative biopsy, as we can see here, and we achieved actually to preserve every branch of vessels and every branch of the femoral nerve. So in cases of well-differentiated liposarcomas of the extremities, the surgical plan is quite simple. We preserve the structures and we have a block resection of the tumor, or even here in the popliteal space, preserving any branch of the nerves. But the advanced surgery of sarcomas refers mostly to cases, to high-grade sarcomas with, for example, vascular involvement. We can see here the vascular involvement of this solitary fibrosis tumor, and we did actually achieve to preserve the branches of the femoral nerve, but of course, we did have to resect the femoral nerves and to perform a reconstruction, within the ponnat of the saphenous vein. The same case, or a similar case, with high-grade sarcomas with nerve involvement, where actually, of course, we can see here the involvement actually quite clearly. We did have to perform a resection of the nerve and to reconstruct them later. And the last case is the sarcoma with infiltration of the periosteum. We can see here that we have actually an infiltration of the periosteum of a length of more than 20 centimeters. So in this case, we did actually perform and the addition of an osteosynthesis plate in order to achieve a stabilization of the limb and, of course, a good quality of life for the patient. So we have to start thinking, though, for other disciplines too. We do need to reconstruct the vital structures, the nerves and the vessels, but we do need to reconstruct even the soft tissue and the skin. For example, we can perform here, like, for example, a mini flap, an adequate skin closure, or, of course, we can perform even a free flap through actually the plastic reconstruction for our colleagues from plastic surgery. So, going to the next issue about locoregional treatments, there are a few of locoregional treatment options nowadays regarding the sarcoma surgery of the extremities. The intraoperative radiotherapy, the external radiation therapy, the hyperthermia, and the isolated limb perfusion. I would like to focus on the first and the last one, which is actually for me the most important during the last years. So the intraoperative radiotherapy compared with the external boom radiotherapy has been, in the last 3 or 4 years, has been established in the surgery of the extremity of the sarcoma in the extremities. And why is that? Because an intraoperative boost results in a much smaller irradiated volume, because it can be precisely guided to the higher risk region under visual control, of course, without additional margins to compensate for daily positional errors. And the organs at risk, including, for example, major nerves or even skin, can be excluded for the target volume, which further reduces the late toxicities and improve, of course, the functional outcome and the quality of life of the patient. But even more important, the high local control rates can be achieved, yielding to similar or even better oncological results. We have a typical example here of recurrent undifferentiated pleomorphic sarcoma. The patient did receive external radiation therapy about 3 years ago, and now have actually the recurrent tumor. We did have to perform a resection of the whole tumor together with the vastus intermedius, with the vastus lateralis, and as you can see here in the picture, we did have to perform a resection of the periosteum and in this length of 5 centimeters of the cortical bone. So it's actually, it's a quite rare occasion though. Normally the soft tissue sarcomas do not penetrate the bone, but if they do, or if we have the suspicion of this fact, then the intraoperative radiotherapy offers us a great help. So we can see here, for example, how the intraoperative radiotherapy, how the intraoperative radiotherapy takes place in the operating room with a flat applicator, just of about like 5 centimeters length, with an effect in a depth of some millimeters in the bone, and the grades that which were usually used is about 6 to 10 for about 15 and 20 minutes. The whole procedure, as I told, takes place in the operating room, which is actually a great advantage for this kind of patients. So the other option, the other important option, is the isolated limb perfusion. This option was introduced to avoid amputation in the setting of limb-threatening extremity tumors. And we have to point out that this option is indicated for high-grade sarcomas, not for large sarcomas. It's only indicated for high-grade sarcomas, which are located in tricky, let's say, locations. So the indications for performing this kind of technique are patients with primary tumors, infiltration or encasement or fixation of motor nerves and major vessels are present. Patients with primary tumors were expected to suffer from relative toxicity from perioperative chemotherapy or radiotherapy, or even patients with recurrent tumors, mainly were undergone already radiation before. And of course, we can use even this method in the palliation setting for local symptoms or to achieve limb salvage. In brief, the surgeon isolates and exposes the vessels of the limb and cannulates these vessels by a tourniquet from the systemic circuit. So the heat which is actually provided to the limb is about 39 grade Celsius, and then the agents, the TNF alpha and melphalan, are given. So the cannulation level, of course, depends on the location of the tumor. We have here a typical example of a tumor who is actually located here in the elbow. So we did actually cannulate the limb proximal from the tumor using the brachialis approach, cannulating the brachial vein and the brachial artery. This procedure is a neoadjuvant procedure and leads to the devitalization of the tumor, so that even close margins without vital cells, though, in tricky locations can be acceptable in the sarcoma surgery. So the key element of the success of this option, of this treatment, is to understand that destroying the vascularization of the tumor, we can destroy the tumor itself. And we can see here how important is the histological tumor regression in the surgical oncology, in general, and especially in the sarcoma surgery, providing us a great resectability. But even more important is that the most significant, let's say, histological tumor regression can be offered through the isolated limb perfusion. This is actually what we expect to research through a European initiative of the Transatlantic Sarcoma Group. We do actually have already the first results. We have already submitted them. So we're actually expecting the next results, the more interesting results. So actually, if anybody want to join us, he's very welcome. I would like, though, to close my talk with the first slide. We did say that sarcoma surgery, the good quality sarcoma surgery, requires some conditions: anatomy, imaging, biopsy, pathology, training and experience of the surgeons. But from the point of the surgical oncology, even the most important thing is actually the knowledge that the interaction of different modalities has a great advantage for the patient. Without the pathologist, without the clinical oncologist, without the radiation oncologist, the surgical oncologist is limited in his own value. Of course, the quality of surgery, as I told you, remains the main element of the multimodality in sarcoma treatment. And furthermore, centralizing the care of sarcomas is very important, not only because of the rarity of these tumors, not only because of the diversity of these tumors, but because of the fact that expertise in all areas of management requires considerable simulating experience. And this has been shown on our last study from the transatlantic sarcoma group, showing that the overall survivor and the disease-free survivor have been improved when patients are treated in experienced sarcoma centers. This is actually what we have established in Germany too. Almost every state of Germany has its own sarcoma center, which is actually very important for the healthcare system. The sarcoma center of Mannheim, Heidelberg, is located here. So I'm closing my talk. Thank you, and I thank you again for the attention, and feel free to contact me if you have any further questions. Thank you so much.
Thank you, Dr. Vassos. We're going to be moving to the next lecture, and we'll have questions related to sarcoma at the end of both, because we're staying on the theme. I'd like to introduce Dr. Dimitri Tzanis, who is our moderator today for this session, from surgeon oncologist at the Institut Curie, Paris, France.
Thank you very much. So as I have minus 25 minutes, I'll try to be as quick as possible. So for retroperitoneal sarcomas, there is a strategy which starts with diagnosis, as everywhere in medicine, because not every retroperitoneal tumor is a sarcoma. You can start with tumor markers, which will help you to find out if the patient has a germ cell tumor, a neuroendocrine tumor, probably a lymphoma, but you will always finish with a percutaneous biopsy. So sarcomas are just a small group of retroperitoneal tumors. And of course, biopsies and the way that we should perform them are very well described in guidelines. So biopsy for retroperitoneal tumor comes from the retroperitoneal way with a double core needle and a needle of at least 14, 16, and sometimes 18 gauge. So the second step after the diagnosis is to tailor the surgery to the histology. If you have a histology that's chemosensitive, you will start with neoadjuvant treatment, as here with the Ewing sarcoma, which will not change the type of surgery, but it will render your surgery much easier. Another example is desmoid tumors. With the last advances, we know that almost 2/3 of desmoid tumors are indolent tumors that may not evaluate or may regress in about 15 or 20% in different studies. So upfront watchful waiting is the treatment for desmoid tumor. Here is a very good example of an intraperitoneal tumor which regressed with no treatment. Anyway, when you have a retroperitoneal tumor, you have two categories, fatty and no fatty tumors. When you have a fatty, purely fatty tumor, biopsy is essential because you might have a totally benign tumor as lipomas, myelolipomas, or angiomyolipomas, where you perform a limited surgery and enucleation, and you may have well-differentiated liposarcomas where there is the place for large surgery. When you have no fat and your tumor markers are negative, you do all your upfront exams, CT scan, and you do the biopsy, and according to your biopsy, you plan your strategy. When you have chemosensitive histologies, you start with chemotherapy. When you have other types of retroperitoneal tumors, large surgery. And when you have benign tumors, as desmoid or other tumors, you have upfront watchful waiting. The first step to correctly planify your surgery is to recognize your tumor, because very often in the setting of the differentiated and well-differentiated tumor, the well-differentiated part may be underestimated, and so that exposes to a partial resection. And of course, a partial resection is a piecemeal resection. We will see what it gives. So in these examples, radiologists saw the solid part of the tumor, while the whole tumor is this. And of course, guided by this misdiagnosis, you have a residual tumor of the well-differentiated part of the tumor. This was more tricky because the differentiated part of the tumor was much bigger, but there was tumor behind the kidney, and you have an HER2 resection. Afterwards, you have to pay attention to special surgical and anatomic structures, and you have to be sure that the tumor you're dealing with is a tumor of the muscle or of everything that's not bone, because bone infiltration may be present, and you might have a bone tumor. Criteria for resection. There are criteria that would render surgery impossible. There are not many ones. You have to check the superior mesenteric artery axis. If it's free, like here, even if the tumor is very big, you can proceed your surgery. The extent of surgery. So we did extrapolate just what Nico said about lymphsarcomas. We extrapolated the compartmental notion of surgery to the retroperitoneum. The retroperitoneum is not a real compartment, but we try to consider it as a compartment, removing the tumor, what's in the tumor, and most often is the kidney, what's behind the tumor, and most often is the fascia of the muscles or the muscles themselves, and what's in front, and most often is the colon and the mesocolon. So this is a multicenter analysis of the Fred sarcoma group that show that piecemeal resection and no piecemeal resection are completely different as regards relapse-free survival and overall survival. These are the two leading articles that were published in the same volume of Journal of Surgical Oncology. The first one is of our group in Paris, and the second one is from the Italian sarcoma team of Milan, which shows that compartmental surgery increases overall survival and relapse-free survival. A newer notion is adaptation of the extent of the surgery to specific histologies, because all retroperitoneal sarcomas do not have the same physical natural history. Liposarcomas have a locoregional extension, while leiomyosarcomas or liposarcomas of grade 3 usually have give distant metastasis. So this is the same new article that treats the same notion in modern way, and of course the standardization of the technique has been very important. It started with a masterclass research that took place for the first time more than 10 years ago, and now guidelines from ESMO and Transatlantic Working Group describe exactly what a resection of retroperitoneum looks like. This left retroperitoneal differentiated liposarcoma, and that's what the specimen and the operating field looks like after this kind of surgery. This is a right retroperitoneal differentiated liposarcoma, and the results of all this is a five-year overall survival of more than 60%, and a low mortality, if you think what this surgery includes, and need for intervention of about 12%, And these are the results of the Transatlantic Working Group publication of more than 1,000 patients. What's very important is to see that the 5-year-old survival guaranteed by this technique is 67%. And here we dare to compare it to the SEER results. Why? Because there is no compartmental resection, no treatment in specific specialized centers. And there is a difference of 4 years in the overall survival. If we put Gleevec aside, I don't know any other treatment that could give these results. And what's the price for it? It's a morbidity of about 16% and a mortality of less than 10% in reference centers. Morbidity is dictated by the type of resection and not only the number of organs, but the pattern of resection. When pancreas vessels are included, morbidity is higher. Other factors that have been underestimated till lately, and most among them is the nutritional status, which is now taken very seriously, and it shows that when patients when they have a correct nutritional status, have better results and shorter hospital stay. Of course, results differentiate, as I said, with histology. The worst survival is for leiomyosarcomas and differentiated liposarcomas of grade 3, just because they can be metastatic. The French sarcoma group showed lately that there is a great survival benefit when the surgical management of retroperitoneal sarcomas is done in reference centers as regards overall survival, ROC and local recurrence survival, and even metastatic survival. This is the paper that Nico shows, and it divides this care in 2 periods, the more ancient one, the recent one. What about other therapies? This is the STRASS study, a randomized international study, which randomized standard treatment, which is surgery alone, with standard treatment preceded by radiotherapy. The primary endpoint was the abdominal recurrence-free survival. The study was negative for all histologies, but for the subgroup of lipomatous tumors, there is a benefit for grade 1, grade 2 liposarcomas. And now there is the STRASS-2 study, which randomizes standard treatment, surgery alone, to surgery alone preceded by chemotherapy. We'll see what it gives. As regards recurrence, I will be very quick. If you can operate recurrences with the good indications, well-selected patients and well-selected tumors, it's always better. And you can say that surgical resection of metachronous metastasis should be proposed as an upfront treatment for oligometastatic patients with a considerable disease-free survival, and after chemotherapy for patients with a shorter disease-free survival or a higher number of lesions. Synchronous metastasis can be proposed as an option for resectable residual metastasis when patients are responsive to chemotherapy. And we also have to keep in mind that repeated resections are feasible, but selection has to be done very carefully. So this compartmental, a block resection for the tumor and its contiguous organ offers the best control in retrospective studies, but a balance must be reached between this expected morbidity and the clinical benefit according to the number and the pattern, the nature of organs that you plan to resect. And of course, this type of approach is better for histological subtypes for which local control is the main issue and not metastatic issues. Thank you very much.
Any questions?
Thank you for the great talk. I think sarcoma surgery is really a surgery of specialists. So I'm a surgeon as well, but I think sarcomas are better in your hands. The only thing is that I think that if you have a big retroperitoneal sarcoma and you talk about the pancreas, for example, I think it's sometimes we need more interdisciplinarity because and very good on block resection is the main point, but the patient has to go home. So we have to work together, and we need more centers like your center in Mannheim, Heidelberg, and of course yours as well. And I think that we have a good goal for the patient.
Thank you very much, Jens. Of course, I'm of the same opinion like you, but pancreas is better in your hands than in other centers. So there's always specializations. As regards pancreatic resections in retroperitoneal sarcomas, are really challenging resections because we operate on healthy pancreas. There's no fibrosis, so the percentage of fistula of leakage is more important. As regards distal pancreatectomy, I think it's almost the same as in pancreatic surgery, so nothing to add about it. As regards cephalic duodenal pancreatectomy, all parameters have to be taken in account, but sometimes in very challenging patients, when we know there are other factors, we have decided to perform total pancreatectomy in order to prevent the complications.
In this case, for sure, in our cases as well, the total pancreatectomy is the best procedure. And I would say in these cases, of course, the total pancreatectomy with the splenectomy, because
exactly
the spleen afterwards often makes problems. So
when we perform caudal pancreatectomy, we always perform a splenectomy in sarcomas in our institution. We do so, Nikos?
Yes.
And of course, when we do total pancreatectomy, we always take out the spleen.
I would like to comment your right comment about the sarcoma centers. I tried actually to point out the importance of a good quality surgery, and this quality surgery or good quality treatment, if we want to include it, we have to include the radiation oncology, the clinical oncology, every expert who has actually to do with sarcoma patients. This good quality treatment can be carried out only in experienced sarcoma centers. These kind of patients are quite tricky, like the tumors that they carry, so we have to respect them. This is my message.
Thank you. With that, we will close the session. Excellent presentations from everyone, and thank you for your participation and engaging comments.
Thank you. Thank you all. Except not our apologies for the late time. We try to do as quick as possible. Thank you.
Dear all, thank you for coming today. I would welcome you to the session regarding, you don't hear me yet. I would like to welcome you to the session regarding the modern management of brain tumors. We have the pleasure to host experts from UK, US, and Germany. Some of them will join us virtually. Within 50 minutes, we'll try to cover some aspects, basic aspects of this topic. Each presenter will have 10 minutes available for each speaker, including the talk and the invited questions from the audience. I would like to invite the first speaker. Due to the delay from the previous session, we'll change the speaker. So I will invite Professor Bechrakis, ophthalmologist from the University Clinic of Essen, to talk about the ophthalmic manifestation of VHL syndrome.
Thank you very much. Can you hear me?
Can hear you.
Thank you so much, Costa, and thank you for considering this change. Since I am in Munich and I'm in a different meeting, so I need to speak in approximately half an hour on a different topic. It's a big pleasure for me, although it's virtually. I would like to be with you there, but nevertheless, it is a big honor for me, and many thanks to Mr. Chrysoulakis, who made this possible for all of us joining the Greek doctors or medics from the diaspora. Well, I am one of those, having working about almost 30 years abroad, and I'm an ophthalmologist, and it's a special honor also to talk in a session that deals with brain tumors. Well, most of you probably associate the eye with refractive surgery, cataract surgery, and something like that, glaucoma, so on. But there are also tumors, and in fact, the eye is an extension of the brain. So actually, it is something that fits into the session. Now, I don't see my slides. How can I see my slides? Okay, I think I got it. So you see, my topic is in von Hippel-Lindau disease. I hope you see my slides. And just to give you an introduction of what von Hippel-Lindau disease is, it's one of the ocular vascular phacomatoses. We have three of them. Well, the one that I'm going to be talking about is the von Hippel-Lindau disease. That is a retinal cerebral angiomatosis. But there are other ones, like the encephalofacial angiomatosis, Sturge-Weber syndrome, with a port vine stain, in the face, and the choroidal hemangioma, the retinal cerebral angiomatosis. Von Hippel has a retinal angioma, completely different. And the third one is the arteriovenous communication, Wyburn-Mason syndrome, which basically is not a hemangioma, but it used to be called a racemose hemangioma. On a historical note, this disease, this entity, was described by Eugen von Hippel, a German ophthalmologist, early 20th century, and he described the angiomas in the retina. And Arvid Lindau, a neurosurgeon from Sweden, described the syndrome, and Möller from Denmark was able to describe the genetics, the autosomal dominant pedigree of the disease. And this disease is a complex disease that comprises retinal hemangioblastomas, cerebral hemangioblastomas, of course, and spinal hemangioblastomas, as well as pheochromocytomas, pancreatic cysts, kidney cysts, as well as in later stages, renal cell carcinomas. You may note that from the incidence, the first one that usually comes to manifestation is the retinal hemangioblastoma. The disease is caused by a tumor suppression gene mutation located on chromosome 3, the VHL gene, that is a suppression, cause suppression of hypoxia-inducible factor. So if this gene is not expressed, we have a lack of suppression of angiogenesis and production of VEGF and so on. And so these tumors and cysts arise all over the body. It is a rare disease. It's a heritable cancer syndrome, and the prevalence is 1 to 50,000, and the incidence about 1 to 40,000 live births. So it's about half of the incidence that we have in retinoblastoma, actually, which is also a very rare tumor of the eye. And we have approximately 350 patients in northern Rhine-Westphalia, the area where my department is. In order to classify clinically a VHL syndrome, if we have a positive family history, we need just another manifestation of this disease, either the eye or the brain or whatever, to have a von Hippel-Lindau syndrome, even if we don't have a confirmation by genetics. Obviously, genetic confirmation is very, of paramount importance, but even if we don't have it at hand, then we can define also a von Hippel-Lindau syndrome if we have two manifestations of the disease in various organs. I'd like to give you a glimpse of a picture of the inside of the eye. What you can see here is a photograph of the inside of the eye. You see the retina, and you see these two orange lobules here. These are angioblastomas, hemangioblastomas, benign tumors of the retina. And if you have two of them, you definitely know that this patient has a von Hippel-Lindau syndrome. But the interesting thing is that even if you have just one, about 40% of all patients with von Hippel-Lindau disease have just one. So it's not an exclusion if you don't have multiple ones. And what I find extremely important is to see the age of manifestation of retinal hemangioblastomas. You can see this very nicely in the very nice PhD work by Bindrup from Denmark. You can see that the incidence and the prevalence is in the teens of the patients, just before they become 20 years of age. And in later on come the cerebral hemangioblastoma, which is extremely important for us ophthalmologists, because if we see these patients with these hemangioblastomas in the retina, we know we need to inform them they might have the disease, so they have to go and screen and do all the checkup in order to be sure that they don't have other problems in the body. And of course, also the renal cell carcinomas. So these are some images of the imaging that we can do in the retina. So you see here an enucleated eye, and these are angiomas in the retina. But in vivo, we can visualize them very nicely with optical coherence tomography. You see this hemangioma here in the retina. This is the retina, this is the choroid. And this is a histological section, which you can see how similar this is in clinical description. And also, what is important is that they do produce traction, and traction means in the vitreous, and traction in the vitreous means the possibility of retinal detachment. And this is the reason why these patients get blind if they're not treated. And you can see here a patient, 30 years of age, actually from Thessaloniki, that was sent to me to do surgery on this patient, where you can see multiple hemangiomas. Here one, there is one, this is a big one here, and you see how damaging this is for the visual vision. We classify angiomas as microangiomas, and I think it is of paramount importance if we see these microangiomas that are really difficult to visualize clinically, but you can see them very nicely on angiography. So if we see them, it is extremely easy to cure them. You just coagulate them with a laser coagulator, like in this small angioma. They can become bigger if they're not treated, and even more bigger. And if they become that big, size 5, they are approximately 3 to 4 or 5 millimeters, then they are really difficult to treat. So we are talking about a really very, very small angiomas that can be treated nicely because we can visualize them by our imaging modalities. And with respect to treatment options, there are various treatment options. Laser coagulation, I've been talking about this with 532 nanometer laser. Photodynamic therapy is one treatment option. Thermotherapy is one treatment option. We do a lot of brachytherapy and proton beam irradiation in Essen. We'll see how if anti-angiogenesis will be effective. And especially, I hope to be able to introduce HIV inhibition of belzutifan, which has been recently approved for the treatment of renal cell carcinoma and von Hippel-Lindau's disease. We will see about that. And it is important to know for the general ophthalmologists and also for the neurosurgeons and neurologists and pediatricians what the screening recommendation is. So in Germany, we start screening at 5 years of age. Obviously, if we know that the patient is in danger of having von Hippel-Lindau's disease, and then annually. In order to exclude these cerebral and spinal hemangioblastomas, as you can see here, and also the cysts in the abdomen, and obviously to be able not to wait until these renal cell carcinomas become huge and treat them as early as possible. And with that, I would like to leave you and tell you that this is the center where we work. Ophthalmology is not only about cataract and glaucoma surgery. We have the biggest eye cancer center in Europe, in Essen, and this is only possible with a large team that I'm happy to lead. Thank you very much for your attention.
Dear Nico, thank you very much for the excellent, comprehensive talk. I think we have one time for one quick question. I invite the audience. I realize you are in a hurry. You have another talk soon. So thank you again for your contribution. We move to the next speaker. I would like to invite Konstantina Karabatsu, consultant neurosurgeon from Manchester, Salford Royal Hospital, to talk about management of low-grade gliomas.
Good morning. It's a real privilege to be here amongst everybody and not only to exchange our clinical and scientific content, but also to get to know each other, because we are here today because actually we are not here. I thought I'll just talk a little bit about me, just to make it a little bit more personable. I did my medical training in Athens Medical School and started my neurosurgical training in Greece. I believe I was probably the first female adult neurosurgeon to have gone into neurosurgical training. Found it quite hard to get the training I wanted for myself and moved to UK in 1998. And trained in various places, predominantly in Liverpool, and I had the privilege to do a specialist fellowship in neuro-oncology and pituitary surgery in Toronto under the leadership of Professor Gentili, who was an amazing mentor. And I got my fellowship of the Royal College of Surgeons in 2005. And I was lucky enough to be appointed as a consultant neurosurgeon at Salford Royal Hospital in Manchester, where I've been there. It's one of the biggest centers in UK, especially for brain tumor surgery. We do about 800 brain tumors a year, and have been appointed the clinical lead for neuro-oncology since 2008. These days, I only do brain tumors, predominantly low-grade gliomas and pineal tumors. And I have other educational roles and administrative roles. So, coming back to the main topic today, which is low-grade gliomas, I have some data here from statistics from UK. As you all know, they are quite rare tumors, less than 30% of all primary tumors with a significant number of types. In UK, we have 12,000 new primary brain tumors a year, 33 every day, and it's the 9th most common cancer in UK. As you all know, very few people survive the disease for 1 year or more, as the majority of brain tumors are malignant, and about 1 in 10 of people diagnosed with a brain tumor survive more than 5 years. So the statistics, the numbers are still quite grim. And as I said, the vast majority of brain tumors are malignant gliomas, followed by meningiomas and pituitary tumors. And I'll just focus this discussion today on low-grade gliomas, which is an area that as neurosurgeons, we feel we can do a bit more to improve their quality of life and improve survival. The challenging bit is that they usually involve eloquent areas, affect younger people, and they comprise of about 15% of all adult brain tumors. The majority of people present in A&E, accident emergency with seizures, so there is no way that you can screen for people with brain tumors. Personality changes, focal symptoms, and quite often people have scans for other reasons, and it's a purely incidental finding. As I said, the challenge in their management is that usually they affect critical areas of the brain, that surgery can be quite difficult. And also we know from their natural history that as I said in my title, they are not actually benign tumors or low-grade tumors, and we always inform our patients that invariably they will progress and they will become malignant. So other than the clinical manifestations, it has a huge psychological impact on patients with anxiety, cognitive changes affecting memory, anger, frustration, low mood. And affect not only the patients, but their families. So there have been a number of different classifications over the year. That was the one before the latest one, where the tumors were not only classified by their phenotype, but also we have the genotyping parameters. So there are the layered diagnosis, what you call the ICN Harlem format of layered diagnosis. So our pathologists now are even more important in helping us in diagnosing those tumors and their exact DNA and giving us treatment options. Obviously, we are surgeons who like operating, and there is a little doubt in the literature that surgery is paramount and maximal safe surgery is what we aim to achieve where possible, not only because we want to have histological confirmation, but also to enable patients to enter into trials, improve their seizure pattern, and facilitate research, and obviously reduce the need for steroids. I'll have some more slides. The prognosis is based on the size, location, eloquence, and histological subtype and degree of resection. So there's enough evidence to suggest that if you remove most of the tumor with less than 1 cubic centimeter residuum, obviously you achieve a much better prognosis for your patient. So there is a new classification now in 2021 that came up that has added, made the classification a little bit easier. So dividing the low-grade gliomas to astrocytomas and oligodendrogliomas, 1p19q co-deleted grade 2. So how do we treat patients? As I said, we tailor the patient management and their prognosis is defined by molecular markers. We do have a multidisciplinary approach. Every single patient is being discussed at the neuro-oncology multidisciplinary meeting, which is attended by oncologists, surgeons, neurologists, neuropsychologists, palliative care, and advanced health practitioners. I'm sure everywhere in the world now there is the area of subspecialization, even within our brain tumors group. Still, some of us subspecialize in particular, like for example, insular gliomas, only a few of us will be doing them. We are helped by advanced imaging. We have now all the options of having diffusion, diffuse perfusion imaging, functional MRI, etc., that guide us towards our approach, and spectroscopy to sometimes differentiate between other possible diagnoses. What is more important to the patient, though, is the impact that their tumor has in the quality of life and their implications in leading a normal life. Certainly, we work very closely with our neuropsychologists because these patients are very much affected by neurocognitive problems induced by the tumor or subsequent radiotherapy. As I said, most of the tumors are in critical areas of the brain, and that's the reason we advise for patients to be treated in high volume specialist centers. And what we have now that makes the subsequent treatment following the surgery very important is the ADH status and the 1p19q co-deletion. And most importantly is not only to remove as much tumor as we can, but to prevent neurological deficit. So this is a quite busy slide here, but you may not be able to see, but what it highlights is the importance in treating each patient individually. For example, if you have an oligodendroglioma, WHO grade 2, and you have a good resection and you are young, then you may not need to have additional treatments and will watch and wait very closely. But if you are older, you have residual tumor, then you may be considered for radiotherapy followed by PCV chemotherapy. Similarly, for astrocytomas, WHO grade 2, depending on the degree of resection and the histological status, we may decide now to watch or treat with radiotherapy and temozolomide chemotherapy. Again, this is the new integrated classification of major diffuse gliomas in adults. It's quite important to have all this information in hand, and that's the importance of having very good neuropathology and genomics department to assist you in the diagnosis. In terms of surgery, obviously we do a lot of awake craniotomies with functional mapping, and we have our neuropsychologists and speech therapists and physiotherapists helping us during the surgery. We have a lot of gadgets. We like gadgets in neurosurgery, neuronavigation, ultrasound. We don't have intraoperative MR in our department. This is an example of case. And also what we monitor is not only language and motor, but also cognitive functions and emotion. This is a recent example of a case where we used all the gadgets that were available to us, and these are the functions we test during intraoperative mapping in awake surgery. Also, we use intraoperative monitoring where possible for cases that are motor strip, sensory strip, to assist us and also to detect any seizure activity during surgery. Nonetheless, no matter what we do, we can only preserve the functions we're able to test. It can be challenging in multilingual patients, and it's quite common in UK. We have to test patients in their native language and in English. And the patient should be very well prepared before the surgery, and very important to have a team you are familiar with and work together for quite some time. Post-treatment, depending what we decide, patients may have had radiotherapy or chemotherapy, but then we have robust imaging protocols. And when there is a recurrence, again, we rediscuss at our MDT, and all options are re-explored, and always reconsider surgery where possible. And what I've learned from my patients is that when life is hard, you learn to adapt. This was something I found in one of the big Kew Gardens in London, in the Alpine section, which is very true. And you see how the patients come very scared when they are first diagnosed, but how they learn to cope, and we are there to guide them. And that's actually our most important role other than the surgery. And that's an old saying I found for our role is we're not always able to cure, but we should relieve often at comfort always. And I think that's the principle I go by. Example of a pre and post insular glioma. So I mentioned briefly about additional treatments post-surgery. I won't go through that again, but some slides about radiotherapy, which is very visualized. And actually, I just want to say the importance of late effects of radiotherapy, which we monitor very closely with regular neuropsychology assessments, and chemotherapy, as you know, is temozolomide and PCV. This is our unit, and we work very closely with the Christie Cancer Centre, which is one of the biggest cancer centres in the UK, and participate in all ARTC trials. That's our team. We cannot do things without having a good team around us. And when it gets tough, you have to do something else. And I do a lot of gardening, baking, and dancing to keep myself sane. Thank you.
Thank you, Konstantina, for your talk. Is there any question from the audience? I have a quick question. You mentioned tailored management of patients, taking into account molecular changes or molecular markers.
Yes.
Do you consider also genetic features via next generation sequencing, for instance?
This is something, as I said, is that layered diagnosis. So obviously, we're always looking for actionable mutations. As you know, there are not that many chemotherapy options that are available other than PCV and temozolomide. There are some probably for glioblastomas, a very small percentage of people that might respond to other treatments. But obviously, we'll always check for BRAF mutations and whatever is available. This is something new we have introduced to have a good genomics department. And I think it's the future. I think surgery is here to stay, but the future, I think it will be, as you said, next generation sequencing and tailor the treatment based on the patient's molecular profile.
Thank you, Konstantina. So we'll continue with the next speaker. I'll introduce you, Dr. Theophilus Zaridis, is oncologist, neurologist at the University Hospital of Bonn, at the currently a postdoctoral fellow at the Previs Medical Discovery Institution at San Diego in USA. I think you're trying some coffees more, waiting for us. Please proceed with your speech about the current and future therapeutical concepts in glioblastomas.
Great. Yeah, thank you very much for the kind introduction. Thanks a lot to all the organizers and particularly to Dr. Gusias for setting this whole session up. Thank you. So yeah, today we're going to talk about current and future therapeutic concepts for glioblastoma. If we start with the most important clinical trials of the past 20 years concerning pharmacological treatment of glioblastoma, I mean, of course, we had surgery, but after surgery, what happens then? We start 2005 with one of the most important studies that showed that radiotherapy plus alkylating chemotherapy with temozolomide is superior to radiotherapy only. So this was a fairly early concept that was established back then that holds until today. It then took us 12 years to get to the next positive trial, unfortunately. And this trial was a novel therapeutic modality called tumor treating fields, which in fact, so those are transducers that are on the head of the patient and cause alternating electric fields and thereby disrupt cell viability. And this study in 2017 showed that a combination of tumor treating fields plus chemotherapy plus radiotherapy is superior to radiochemotherapy only. Now, there are a few issues with that study. Among other things, that there was no placebo arm and how is the real life visibility. But nevertheless, it was a positive, the first positive trial in a long time. A couple of years later, we were happy to published this trial where we selected glioblastoma patients that have an MGMT promoter methylation, so patients who per se benefit from alkylating chemotherapy, and intensified treatment with lomustine and temozolomide, so CCNU plus temozolomide, and saw that combination treatment led to a clear survival benefit compared to temozolomide only. Now, there's also issues with that study, the small patient size, then the question whether there's a certain Karnofsky performance cutoff, so a subset of patients to whom we can offer that treatment, but nevertheless, the first positive pharmacological trial in a long time. For recurrent glioblastoma, that is a history of failures, unfortunately. What we can do is temozolomide rechallenge, especially for patients with the MGMT promoter methylation. Otherwise, CCNU, lomustine, funnily enough, there is no randomized phase 3 trial showing a clear benefit for this substance, but it has been a control arm in most clinical trials. So we do offer it. 2019, there was an exciting study that came out studying regorafenib, a multi-kinase inhibitor for the first recurrence of glioblastoma. And it also showed that patients benefited from the treatment as compared to CCNU treatment. A very modest effect. There was a trial from Bonn and Tübingen that showed that patients with hand-foot reaction as a secondary effect to regorafenib had actually better survival compared to patients who didn't have this secondary effect. So this could possibly serve as a biomarker for clinical routine. But nevertheless, we're talking about very modest effects. So, we have our homework to do. We've heard in the previous session a lot about immune checkpoint inhibitors, and they have revolutionized treatment in oncology. Unfortunately, that is not the case in neuro-oncology. So PD-1 inhibitors, particularly nivolumab, was negative both for recurrent and for primary setting in glioblastoma. In last year's conference, SNO, the data for the methylated trial were presented, and unfortunately they were also negative. Here, there is a subset analysis of patients whose tumors have a PD-L1 expression of at least 5%. And you cannot really see it, but this is the nivolumab arm. So you could assume that they have a slight benefit compared to the control arm, but a very moderate retrospective analysis, and of course not statistically significant. So no positive trial yet. Probably the best data we have from a CAR T-cell therapy, so a chimeric antigen receptor T-cell therapy in glioblastoma, comes from pediatric neuro-oncology, and particularly from DIPG, which is a very aggressive form of glioblastoma for children and young adults. And this very exciting study from Stanford actually showed that CAR T-cells against GD2, glycoside, applied intravenously and intraventricularly for DIPG patients had striking results. The patients had a median overall survival of 20 months, which for DIPG is amazing. And the two important key points, A, that they had a sustained response for several patients, and B, that there was no off-tumor toxicity, and it was generally well tolerated. Here's just an example of a patient. As you can see, before treatment and after treatment, you can see significant decrease in tumor size, and that translates into clinical benefit. So you see the facial palsy that is completely gone, basically, after treatment. So encouraging data on that score. The other sort of future concept will be targeted therapy. We've also heard a lot about that. One of the most exciting concepts in trials of the future would be umbrella trials, flexible statistics, experimental arms based on molecular data. And one good example for that is the N2M2 study from Heidelberg, which is a phase 1/2 trial for first-line treatment of MGMT non-methylated glioblastoma patients. Again, treatment based on molecular data. As of November 2021, unfortunately, 4 arms have closed, either because they were not effective or because they didn't have enough patients to recruit based on the molecular alterations. But temsirolimus is apparently positive. So for mTOR phosphorylated tumors, they show a survival benefit, which means that if we do our homework properly, then we might have a benefit for these patients. A fascinating and unfortunately also devastating part of glioblastoma biology is that in fact it's not a focal disease. It affects the whole brain. The cells use neuronal networks, so they have synapses essentially and are interconnected in the brain. And a study from Bonn showed actually that meclofenamide, which is an FDA-approved non-steroid anti-inflammatory drug, inhibits gap junctions and also have a cytostatic synergistic effect with temozolomide. So there is a phase 1/2 trial with temozolomide and meclofenamide in first recurrence of MGMT methylated glioblastoma patients. We hope that the recruitment will start soon. So this would be another concept of targeted therapy, really considering biology. And we also heard very nicely in the previous talk that our patients have severe issues that are not directly that are related to the tumor, but that are not connected to chemotherapy or to targeted therapy, but are other issues like seizures, edema, thrombosis, infections, depression, cognitive deficits. We always have to think about rehabilitation. We always have to communicate sufficiently with our patients. And maybe the most interesting Kaplan-Meier curve I've shown today is a study from 2010 where the authors had a look at tumor patients with non-small cell lung cancer and saw that early palliative care not only improves quality of life, of course it makes sense that it improves quality of life, but it actually prolongs survival. So please consider these issues, and especially if you have the option, involve the palliative care team early enough, because that's the point from which patients benefit most. So thank you very much. Greetings from beautiful San Diego. Good night, and I hope that we spare some time for questions or for the next presentation.
Thank you, Theophile, for your excellent talk and for respecting the time. You'll be punished and you'll be asked more than one question.
Yeah, for sure.
I have the first question, and if I ask you to name the sexiest agent currently for systemic therapy, you would probably mention CAR T cell therapy or GD2 CAR T cell therapy. There are some studies for intraventricular delivery. Would you suggest this agent also for local delivery apart from ventricles? It's a question which relapses with my next presentation.
Yes, exactly. But I was about to say wait for the next talk. But if I can say one thing, due to time reasons, I didn't include that. But there is a fascinating also study from just around the corner, City of Hope, where Christine Brown's group delivered CAR T cells against IL-13 receptor alpha 2, and they did this. So they published this in New England a couple of years ago, and you can see that the tumor had a really good response to the CAR Ts. And I guess what's also interesting is that the median overall survival in this small cohort of patients was 10.3 months, but we're talking about heavily pretreated patients. What I found interesting, this is a picture from the conference, so I apologize for the low quality, but 33% had already had bevacizumab, which means they really were heavily pretreated. So I'm sure that intratumoral delivery is extremely very sexy, as you said. And also in terms of local versus intravenously, if I can say one thing about the GD2 CAR T cells from Michel Mongi, so they also describe in this Nature paper with 4 patients that they saw better results when they did the intraventricular injection. So now for the phase 2 trial they're planning, they're actually focusing on the intraventricular delivery. So of course, yeah, as you said, intracranial and intraventricular delivery are probably even more interesting than. Yeah.
Thank you, Theophile. Sure. More questions from the audience? It's not the case. Thank you very much again, Theophile. We'll move to the next speaker, who is me. I'll briefly introduce myself. My name is Gusias. I'm director of the neurosurgical department in Lünen Academic Hospital of the University of Münster. I would like to thank again the organizing committee for the invitation. It's an honor and pleasure for me to be in my country and give a talk about glioblastomas. So what I'm going to talk about today is a topic which concerns me a lot during my daily practice with patients with glioblastomas, namely the local therapies for these tumors, since the systemic therapy seems rather ineffective. I'll begin with this MRI. This MRI shows a glioblastoma, the most malignant primary brain tumor, which shows poor prognosis even after complete therapy consisting of surgery, radio, and chemotherapy and application on tumor treating fields. The degree of the resection at the initial stage is critical for the cause of the disease and the patient's outcome. If we're willing to resect beyond the tumor borders as seen in this MRI, then we may have the chance to see MRIs like this also 2 years later without tumor recurrence. Nowadays, we all agree that the goal of the glioma surgery should be maximum safe resections, and we have some gadgets, some surgical procedures to maximize our resections, since this is these procedures are well known among neurosurgeons. I will skip further details. So the main local therapy for glioblastomas, namely the tumor resection, has shown tremendous advantage in the last decades. The systemic therapy following the resection, though, is rather ineffective, since most of the patients recur in some months and show overall survival less than 2 years. So we need urgently new treatments. And since the blood-brain barrier is speculated as the main reason for the resistance of glioblastoma to the systemic therapy, then we should additionally work either on local therapies or on techniques to allow local drug delivery, overcoming the blood-brain barrier. Electric fields and thermotherapy belong to the local therapies. Tumor treating fields are alternating electric fields transmitted via transducer arrays applied to the scalp, as seen in this photo, and connected to the external portable device. Low electric fields deform the mitotic spindle and promote apoptosis. As you may see in this stainings, tubulin marked with green, marking green, is being deformed, thus also the cytoskeleton, which inhibits mitosis. Combined therapy with temozolomide and tumor treating fields prolonged the overall survival in the EF14 trial, and since then, tumor treating fields are part of the established therapy for primary glioblastomas. Laser interstitial therapy is the most studied thermal therapy, and consists of an optical fiber inserted stereotactically into the tumor, which generates heat for several minutes over 40 degrees Celsius through a laser light at 1000 nanometers wavelength. This procedure is associated with apoptosis and necrosis of the tumor cells, transient opening of the blood-brain barrier, and sensitization to radiation and chemotherapy. However, this procedure is associated with severe and frequently apparent adverse events, whereas no survival benefit has been shown. Photodynamic therapy has been developed more recently and could be applied either directly after the surgery or in the later stages at the time of the recurrence. In principle, we need a photosensitizing agent, in our case 5-ALA. This sensitizes and marks the tumor. The patient takes this medicine 4 to 6 hours before the surgery, and this 5-ALA is converted into protoporphyrin 9 into the tumor. After the tumor resections, we place the PDT laser accordingly to the tumor resection cavity to damage the remaining tumor cells. Upon exposure to the laser light, the tumor cells undergo an oxidative stress, generate ROS, with consequent extensive DNA damage and apoptosis. The Indigo trial has confirmed the severity of this procedure. However, no studies have confirmed yet a survival benefit. The main disadvantage of this procedure is the limited penetration of the laser light into the tumor, which is calculated at about 5 to 10 nanometers. This means deeper seated tumor cells, which are not reached by the laser light, remain unaffected. The idea of local drug delivery overcoming the blood-brain barrier is, of course, tremendous. However, the first attempts with tumor cavity treatments have not been successful. The placement of glial wafer into the tumor cavity after resection may indeed allow high-dose chemotherapy over a longer period of time, approximately 30 days. The local complications are, however, severe, and the survival benefit has not been proven. More interesting appears the implantation of Mayer reservoirs, which allows similarly high-dose local chemotherapy, but also repeated therapy during the treatment. The adverse events have not been significant, and there are some studies who showed positive results after application of nemustine through the Mayer reservoir. I would like to say this reservoir is ideal for resection cavity. In case of a solid tumor like this image, then a conventional enhanced drug delivery is more preferable. one or more catheters are placed stereotactically into the tumor and connected to an external pump, which establishes a positive pressure gradient to generate constant microinfusion of the drug into the tumor in terms of bulk flow. So this procedure shows higher penetration, diffusion, infusion of the drug into the tumor. We have also some positive studies like this from Saito et al., who found a favorable response in the group of the high dose nimustine administration. Again, this procedure is easily to be understood, cannot be used for 3 months. The time is limited. We can administer medicine only for up a week. In case of a chronic CD device, we could perhaps have more impressive results. To this end, University of Columbia conducted a phase 1 prospective study delivering topotecan, it's a topoisomerase inhibitor, in 5 recurrent high-grade gliomas after implantation of a percutaneous chronic system, and has delivered this medicine for 32 days. The results on the safety are not published yet. Intraarterial delivery combined with opening of the blood-brain barrier has gained again interest in the context of the tremendous advances of neuroradiology. The purpose of this procedure is to deliver the drug supraselectively through the tumor feeders, arterias, which are marked in green in this MRIs. We can also monitor the transcatheter perfusion through real-time MRI. This procedure allows higher perfusion through arterial feeders of tumor and could be repeated during the surgery several times, during the treatment several times. The latest studies have not confirmed the severe complications reported by the oldest one. On the contrary, this procedure is safe and oncological relevant. For instance, Patel, the research group of Patel, has conducted a clinical single-center phase 1 study, including 31 patients with glioblastomas who received, additional to the standard therapy, also 3 times intraarterial bevacizumab, and showed an impressive overall survival of 23 months. Synoptically, I would claim that local therapies appear as a promising therapy. We have now the technological potential to treat precise and local the tumors. Is today perhaps the right day, the right time to treat aggressively the tumors, even before the recurrence appears? The last slide depicts a rather aggressive treatment schedule. But nowadays, precise combined intracavity, intraarterial, and systemic therapy is feasible. If it is also reasonable and indicated, it's open to discussion. So thank you very much for your attention. So I would like to
with regards to the use of the Ommaya reservoir to infuse chemotherapy, what is the penetration with that low pressure system into beyond the resection cavity?
Yeah, it's small, and if you have a solid tumor, it's not appropriate. It's the reason I mentioned for solid tumors, we should rather prefer the convection enhanced drug delivery. My idea with this Ommaya reservoir is to have this inserted, for instance, 1 month after the resection, where we don't have any tumor yet, and to prevent the recurrence if we can. Ommaya reservoir has no penetration. Perhaps some studies speak about 2 millimeters. It's nothing, and in such a case, we have already tumor cells, we should not use this method.
Thank you.
Yeah, hi. Thanks very much for your talk. Going back to the last or the slide just before that, with the pumps sign and everything, my question is, how far are you to realize this kind of schedule when you're treating patients?
Could you put my last slide again? As I said during my speech, it is an aggressive treatment schedule, and it does not exist yet. It's a proposal. It's my proposal. Show the last one. Okay, this one. Okay, it's my proposal in AORTC, and it's currently under consideration. But we need, of course, preliminary data, and they will start soon in my clinic in terms of a phase 1 clinical study after getting the ethical approval.
Thank you.
Mr. Zarides has also a question. I thought you sleep already.
No, not before your talk. So you talked about methods to open the blood-brain barrier. What about focused ultrasound? How far are there any? I mean, I know that we're trying to do it in mice, but yeah.
So focus. I think you asked about focused ultrasound.
To open the blood-brain barrier.
Yeah, it's one of the methods to open the blood-brain barrier, and for some hours. And I think Columbia University is also a pioneer, and I think a Greek physician is also in charge. Elena, okay, I have the name not apparent. So it's a useful tool, but it's not the ultrasound you use the diagnostic. We need low intensity ultrasound at about 200 kilohertz. I'm sorry, and it's one of the methods to open the blood-brain barrier. I think the best method. We have the other methods like mannitol administration or heat, but thanks for asking. It's my next investment in my clinic, since I'd like to focus on my future scientific plans focus on this topic, local therapies. So I find the focus ultrasound a perfect gadget for this. So I think we have some questions. I would like to ask from the next speaker, Alexandros Boukas from London. Hi, Alexander.
Hi.
You talk about skull-based surgery, so you may take over. And thank you for your contribution.
Well, thank you very much for the invitation. First of all, I'm extremely honored to be amongst specialists like yourselves talking. I watched all your talks with a lot of interest, and I've realized that this is highly scientific. Mine is a bit more practical. It's about the work we're doing in King's College Hospital in skull-based surgery. I'm sure you know most of the subspecializations are multidisciplinary, but skull-based surgery especially does involve a lot of people. Not only neurosurgery, but also otologists, maxillofacial surgeons, ophthalmologists, and also the diagnosticians. But the center I've put are advanced nurse practitioners, which is a modality that we use in United Kingdom, where highly specialized nurses are liaisons with patients, and they are extremely useful in running the whole service. So starting with the endoscopic approaches, I have two images here just to appreciate that if in the top right hand corner, you can see a midline sagittal view, and you can see the that with the endoscope you can go from the top of the C2 essentially to all the way to the anterior cranial fossa. But if you move parasagittal, especially because of the anatomy of the carotid artery, things become a bit more complex. So my presentation today is about talking about starting from the most simple one to getting to more complex complex endoscopic approaches. Obviously, the key is to plan and prepare. You need to study the scans very well, and you can see why. You can see all the appropriate planes. You need to have when in theaters, you need to think about the patient positioning. You need to think what you're going to do inside, including not only how you're gonna take the tumor that you are aiming to remove, but also how you're going to repair the hole that you've made. Now, in terms of bleeding, there's many ways. I've watched many other webinars, and everyone across the world basically is using pretty much the same things. Patients are positioned in reversed Tendelbook. We use very frequently Moffat's nasal preparation by the ENT surgeon who created it, which is a mixture of adrenaline, cocaine, and sodium bicarb diluted with normal saline. We like to keep the pressure, the systolic blood pressure around 100, and if there is bleeding inside, you can use non-invasive ways to stop it if it's from mucosa, such as adrenaline-soaked patties, warm saline with irrigation. We use a lot suction monopolar gadgets in the King's, and we favor that to bipolar coagulation acids. The fact that it can suction and coagulate at the same time, find it extremely useful. And obviously, we all know the hemostatic products, and we more and more frequently use tranexamic acid as a way to stop bleeding. So every time we see a scan and we discuss these scans in the skull-based MDT, we discuss different approaches of how would you tackle with different problems. And starting from anatomy, we have to be able to think about where the approach is going to get us, and what we're going to see in front of us, and how can we get there safely. The first case I'm going to present you is a challenging pituitary adenoma. Unfortunately, I don't have a video for that, but I have one slide or picture which is enough to for everyone to understand what we're talking about. A pituitary adenoma who had previous 2 endoscopic surgeries, and it was growing again. She was brought back to clinic, and it was discussed about further surgery. The problem, as you can see, is that there's extension of the tumor towards the left side of the cavernous sinus. And this is what is becoming more and more popular now with the advanced imaging and with advanced optics of the new endoscopes. We can really see and approach these places where previously were not possible safely. And here you can see that the medial side of the cavernous sinus has been mobilized, and we have after hemostasis, we're able to resect tumor through the cavernous sinus and see the postoperative result. The second case is a tubercular meningioma on a woman who presented, a young woman who presented with visual failure. And here we can still see the video. And as we can see that we have already approached the pituitary fossa, and we're performing an extending endoscopic approach with using the drill and upcuts to, sorry, my apologies. Yeah, sorry, I would like to stay here. So after we have done the bony removal, we prefer to do in these tumors a longitudinal incision, just so we can coagulate the intercavernous sinus before continuing, which is above it, so we can coagulate it in front of the back. And then we start with a tumor mobilization. If we could see from the beginning, these are the tumors that we prefer to resect endoscopically. Meningiomas and the tuberculous meningiomas are the small ones, and this is because we have found that the endoscopic approaches for this kind of tumors creates a high rates of CSF leak, and these are CSF leaks which it is believed widely that they're probably underreported in literature, and therefore and at the same time there are many other ways which you can safely resect these tumors without having to worry about CSF leak. So you can do with mini-pterional or with eyebrow incision, and that's the end result with the resection of the tumor, and this is the Haddad's flap at the end of it, and this is the post-op scan. The last case I'm gonna discuss and present you is a chondrosarcoma. These are more complex lesions which arise from the petrosphenoidal junction. They are malignant, although low-grade malignancy, and they normally present in the middle age. There can be there are 3 grades, and the mainstay of treatment is surgery plus minus stereotactic radiosurgery for any residual. This is where we can expand the endoscopic approach to the parasagittal area, where we're gonna have to tackle the carotid artery in the petrous bone. And so I have, and again, the way we train how to do this and how we start doing these things is obviously again going to study the anatomy very well, study your images, and go to the lab and practice your dissections, so you can appreciate the anatomy before you embark doing them. Obviously, it's important to have in such complex operations very experienced colleagues who can guide you through that and can help you with the resections. And I'm very extremely fortunate and to have trained for my fellowship in King's College Hospital with neurosurgeons such as Mr. Thomas and Mr. Barazzi. So here, just before we go to the video, when you are approaching the parasagittal area of the nares, you have to appreciate that you, rather than lateralizing the middle turbinate, it will be medialized. You will see the uncinate process and the bulla ethmoidalis, and after you resect the mucosa, you can drop into the maxillary sinus. From there, anatomical landmarks such as the Vidia nerves will be visualized, and that will help you to get to the foramen rhodontum and the V2. But also, as you drill down, the Vidia nerve is also an extremely useful anatomical landmark for the foramen lacerum, and the safety of the drilling when you are tackling with the carotid pillars and the paraclival carotid artery. So here we have the video where we start with a standard endoscopic approach. In these cases, we prefer to start with a standard midline approach first, and then move to the parasagittally. So you can see here we've identified the sphenoid ostium, and through that we will drop into the sphenoid sinus. There it is. This is a patient who had a very well pneumatized sphenoid sinus, which is always helpful as it reduces the amount of drilling that you have to do. It's important to identify both sides. So then we, after we crack the septum in the midline, we go submucosally and identify the other side, and then we resect the sphenoid voma. Through that, we can now drop into the sphenoid sagittal safely, and now we start going into this parasagittal plane. And on the right side, you can see the bulla ethmoidalis, and these are the ethmoids that slowly, with a blunt instrument, we prefer use large blunt instruments when we do especially bony work, as they do not penetrate and they cannot injure vessels. So moving down now, we will identify the VDN nerve as shown in the picture earlier, and that will be our landmark to get to the carotid, and as we have to continue the resection lower, we dissect and coagulate the area of the VDN nerve, as there's always a bit of bleeding, and then we start after we finish that. We will soon start the drilling. So there's no skull-based neurosurgeon who doesn't love a drill, and the drill will head from, we're now heading south towards the clivus, and to mobilize the carotids and also towards the petrous apex. The drilling continues. This is the approach that will take some time till you get there, and in the end we will have mobilized the medial temporal dura, and we can see and the petrous apex of the tumor. So the drilling continues. I think I'm just going to forward a bit, and there we are. We just now we are further south, and we are over the tumor, and we start the dissecting. We have thinned down the bone, and we there's always some extradural bleeding with these cases. But if you have a good anesthetist and who is maintaining the blood pressure, who has given tranexamic acid, the positioning is good, then you can just continue without worrying that much about this amount of bleeding. And now we drilling towards the clivus, and then you can see here. There you can see. This is the area where the tumor is in the petrous apex. We then do the urotomy, and now we're going to use some angled instruments. The good thing with chondrosarcomas are tumors who are generally soft and easily to be removed once you are in the cavity, and you don't have to go extracapsular. You just need to perform a very generous debulking or resection if possible, depending on the size of it. So this is the taking the tumor behind the left side carotid with angle instruments. And this is some pre and post-op imaging showing good resection on the left side. And here I would just put another case where we can see the amount of bony work you need to achieve in order to resect the tumor. Obviously, I've mentioned it before, the challenge or the biggest challenge in the endoscopic skull-based neurosurgery is repair of CSF leaks, and there are many reasons for that, and not because it's not just because of the big hole that you made in the skull base. It's obviously because there's you can have high flow leaks. it's difficult to put anything onlay, and if it is inlay, and if it's onlay, it's going to be under significant strain. And there's always the worry that if you try to do anything intradural to plug it, it may cause some pressure. And we found in our unit that the receptor flaps, they can be useful, especially when everything else fails, but they need to be done well. But also, it has a long way to go. So sometimes you need both sides to mobilize them. And obviously, what I've realized in the last, at least the last couple of years, that if you every endoscopic, every neurosurgical.
Alexander, maybe you may wrap up your.
Yes, I have to. I'm closing. Okay.
Thank you.
So it's a very a lot of different techniques. What we found, and I'm gonna close with that. I'm just gonna do the open because I had some slides for open repairs as well. Is that fat works really well. So layers of fat that can be supported with some nasopore and simple Vaseline gauze packing is something that can be used, and we have published the results that dropped the CSF leaks significantly. So as I said, I'm gonna skip the open approaches, and the only thing I'm going to say is I hope I've just shown, like in a very small presentation, how skull base it can be a long journey. This is the trail marathon of in Mont Blanc for the 100 miles run. You can see it's ups and downs, and always use this picture to kind of depict how I see neurosurgery training in neurosurgery careers is with its ups and downs, but you just have to keep going. Thank you very much.
Thank you, Alexander, for your excellent talk and the impressive videos. So we're out of time. I would like to thank you all for your participation, your patience, and the audience, and the excellent talks from the speakers. So you deserve a coffee break now.
Afternoon, please take your seats. Are all the speakers here? We're going to have a little change in schedule here, but we'll go on. Good. So I'm Dr. Spiros Mazidis from New York, assistant professor of endocrinology at New York Hospital, Cornell, and Lenox Hill Hospitals. And I'm the moderator of this session on metabolism. We have changed a little bit because we also have Dr. Chervenak here, our first speaker, who's going to speak on medical ethics. He'll be leaving after this talk, returning to the United States. So I want to introduce Dr. Chervenak first. Dr. Chervenak is a professor and chairman of OBGYN at Lenox Hill Hospital, Northwell System in New York City. He's former chair of OBGYN at the New York Presbyterian Hospital, Cornell. And we're very honored to have Dr. Chervenak with us because he has been working with the Hellenic Medical Society of New York, both on the annual Dr. Papanikolaou Symposium and the Hippocratic Symposium. Dr. Chervenak is a world traveler. He received the honorary degree from the University of Thessaloniki a couple days ago, and we're very honored. Dr. Chervenak will speak to us today on medical ethics. Please, Professor.
Wonderful. Wonderful. Spiros, I thank you for the kind introduction. It's the one that I'm honored and humbled to be at this wonderful conference. I love this country. I love the people. I love the city. And Spiros, you are wonderful. I've worked with you for several years. You're a wonderful person, a brilliant organizer, and it's wonderful to be with you today, but I have to move quickly. In New York, as throughout Greece, we've emerged from the COVID crisis. And I've been inspired to deal with this issue of teleeducation. And teleeducation has two big advantages: convenience and cost savings. And I think you'll know that this is a big industry. The price of Zoom has skyrocketed because of the COVID crisis. I think you all know this. And please, we've survived because of Zoom, because we've been out of commission. We can't hold in-person meetings for over 2 years. Now, how am I going to contest this? I am convinced that we owe so much to the Greek philosophers from over 2,000 years ago. Socrates, Plato, and Aristotle. Now, we can debate who was the greatest, but Plato is the only one the Athenians didn't want to kill. We all know the story that Socrates was killed by the Athenians. Aristotle was a little bit smarter. He got out before the Athenians had a chance to kill him. Plato, at least they didn't want to kill. I think everyone here knows Plato. He taught at the academy. He was the brilliant one who at least codified Socrates' teachings. Socrates was brilliant, but he didn't write anything. Alfred North Whitehead, a more modern person, said it so well. All of Western philosophy is but a footnote to Plato. Now, I'm going to do my best with this. Some of you, I think, know this better than I do. Knowledge must have a secure basis in ideal types, what Plato called the forms. For each object, there's a specific form. So for a tree, there's the image of a tree. Now, what I've learned in Greek, mimesis is a common word. In English, we don't use the word mimesis. Let's develop this. There's the ideal form of beauty, what it is. Each of us has our own concept of what beauty is. And now they're individual, beautiful entities. Then they're imitations or mimesis of beauty. And this is what the artists do. So mimesis is an imitation. I realize those of you who are Greek use this word in your Greek, modern Greek language. It's a foreign concept for us in American English. Martin Luther King said it well. Everything we see is a shadow cast by which we do not see. Teleeducation is a mimesis. It's artificial. It's not the true reality. Bear with me for a moment. This is a thesis I want to advance with you, but I'm going to stay on time, 10 minutes. I want to develop with you what I consider the most important metaphor or allegory. Allegory is an extended metaphor. Indeed, many consider this the most important metaphor or allegory in all of philosophy, not just Greek philosophy, and all of philosophy in 2,500 years. What the metaphor of the cave says is that all of us are down here. We're chained. We're chained. And we're chained to see shadows that are projected on, that are shown to us. And forgive me if I show politics a little bit. Some people in America see shadows, let's say by Fox News, and that's all they see. They don't see the reality. And this is unfortunately what we're bound by. We often don't see reality. We just see the shadows or the mimesis of what reality is. Now, I argue this is what reality is. We have person-to-person interaction in the classroom. Some of you are young enough to be in classrooms to have that person-to-person interaction. It's beautiful. Now, there are limitations for teleeducation for the teacher. I'm able to read the room, who's paying attention, who's not paying attention. You have eye contact, body habitus, the inability to listen to sounds, who's whispering, who's shifting around, the inability to respond by voice or gauging, the inability to use hand gestures with the appropriate emphasis. For the learner, there's a big problem. The teacher and the learner are in front of a camera. Personalized eye contact is limited. Learners can turn off the camera. I hate to tell you, I'm sure at our grand rounds, when we had teleeducation, some people were doing it from their bedroom, and they turned off the connections. They could do whatever they want in their bedroom. I confess, sometimes I turned off the connection at some meetings and did my emails surreptitiously on my cell phone. The learner can no longer pay attention. The sophisticated technology of teleeducation appears to create an immediate, unmediated relationship between teacher and learner. But it's a mimesis. It's not a true interaction. And I suggest this powerful cave allegory is so important. And I want to leave you with this image that's so important, that we need to escape the cave. And Plato showed us this 2,500 years ago, that a few people are fortunate enough to escape the cave and see reality. Some people can break out of what they're being fed, the false images. They're able to break out. So I've decided as chairman of my department, come September, we're going to have in-person grand rounds. So not the mimesis of teleeducation. As long as we're able to do it without fear of infection, we're going to have the real grand rounds and have true real person. And can I say there's some evidence this works? Here we see the price of Zoom has plummeted once COVID is ended. So some people are taking this to heart. Don't get me wrong, teleeducation is important. It had its place and it has its place, but in-person meetings such as this wonderful meeting is much better. And I think you all know this. The in-person interaction we have is so, so much better. There are two important factors for teleeducation: convenience and source savings. But 2,500 years, and please, during the COVID crisis for 2 years, we couldn't go out. I studied Greek philosophy, which I never had the opportunity to do earlier. Plato's concepts of mimesis and the metaphor of the cave are relevant today, and they're so important. And I'm going to stay on time, Spiros, just one more minute. Gratia capta ferm victoriam sapit from Horace. The Greek, I'm not Latin, forgive me, but it says so true. I know Tiffany knows what this means. Captured Greece, took captive the entire world. And it's so true. It's so true. These great philosophers took over the entire world. And I'm convinced of this. I have studied this, and please, Aristotle, even more than Plato. I'm a scientist. His concepts are so relevant to us today, and it's amazing. We've forgotten about this. It's a treasure trove, even in modern medicine, endocrinology, obstetrics and gynecology, everything we do. And here I show a picture that's so beautiful that ties us together. As you can guess, I'm not of Greek origin, I'm close, I'm more Italian than anything. With Spiros Mezidis, Apostolos Athaniadis, who is my connection here. He's professor and chair here of the medical school at Aristotle University. Panos Manolis, who's a brilliant chair of surgery at Lenox Hill, and with the first Hippocrates Award, which Spiros and I organized, and we'll have another one at Lenox Hill Hospital. So these bonds are so important today in this crazy world, the forces that separate us. This brotherhood and sisterhood is so, so essential. And there's more I could say, Spiros. I'm going to stay on time and respect the program. Thank you for the opportunity to work with you and to be here at this wonderful program. Thank you so much. Spiros.
Thank you, Frank. Excellent thoughts and speech, and for your Philhellenism. We really appreciate that, and you have a good trip home to New York. I will continue with my talk. Okay, good. Next slide. Okay. Good, thank you. So what I'll be doing and trying to stay within the 10 minutes, I'll be taking you through outpatient management of type 2 diabetes, how we do this today. And you'll see many slides here, but I'm going to stress in a whirlwind the concept so you can understand what we're doing. So the way our objectives of this talk here is to talk a little bit about the rising diabetes incidence, the pathophysiology complications and management options, to stress the goals of management and the combination therapy that my brother and I have spearheaded, and then the diabetic telemedicine platform that we're working on. So where are we in the United States and the world right now? 10% of the population has diabetes in Greece and the United States. About 30% don't know about it. And more than 30% of US adults have prediabetes. And they're in the millions, as you say, and this is related to family history and aging that we can easily understand, but also to stress, to our sedentary lifestyle, and to our diet. So how do we see these high blood sugars? Well, the pancreas is producing less insulin, and because there's less insulin, there are higher blood sugars. And when there are higher blood sugars, the liver is affected, less insulin action on the liver and insulin resistance, so that there's increased sugar production by the liver. That's our storage depot. Then this has impact on the fat cells. The fat cells are not inert. They produce substances that block insulin action. There's also increased glucagon secretion, again causing higher blood sugars. The muscle is not absorbing those sugars. They stay in the bloodstream. Muscle uses blood sugars as fuel. And there's decreased gastrointestinal hormones. These hormones are important for insulin secretion and for satiety. We have decreased satiation neurotransmission in the brain, and we have more sugar being reabsorbed by the kidneys. So we call this the ominous octet, causing high blood sugars. Now, the high blood sugars cause inflammation, and the inflammation is in the blood vessels. What does that mean? That means that the blood vessels thicken, they harden the inner surface, and there's increased risk for blood clots, so that we have the diabetic complications. And the long-term chronic complications are the microvascular, small blood vessel, retinopathy in the eye, major cause of blindness is the diabetes, neuropathy, nephropathy, the kidneys are affected, and then the larger blood vessels are affected. We have the heart attacks and we have the strokes. So how do we approach management? First is the cornerstone, of course, is diet and exercise. And as you see here, caloric restriction is important because most of the type 2 diabetics are overweight. So we want at least 500 kilocalories daily energy deficit. And we also work with a low carbohydrate diets. On top of that, we work with exercise. And the recommendation is 150 minutes of physical activity weekly. But also stress is coming more into our understanding, and sleep. So sleep and stress need also to be emphasized in diabetic patient. And then we move to therapy with medications. And one of the first studies that was written in this field was my brother's study from Colombia in 1992, where they combined insulin with glyburide, which is an insulin secretagogue, the oral medication. Today, we have many agents that we use for treatment of diabetes. First, we have agents, we have insulin that can be replaced exogenously. You move forward from there. This is not doing them. Okay. And agents that reduce insulin resistance, and you see the names here, biguanides, thiazolidinediones, dopamine 2 agonists. Next are agents that are involved in glucose wasting. Those are the SGLT2 inhibitors, so they block kidney reabsorption of sugar. Then we have agents that block the absorption of sugar by the gastrointestinal tract, the disaccharidase inhibitors. Sorry for the delay here. I have a little issue. You're right. So we have the glucose production reducing agents. I'll work with this. Okay, thank you. And there you see the names of the agents we have in the promoting agents with a GLP-1 and GIP. Now I want to stress GLP-1 because this is maybe the newer agent you've heard about. The tirzepatide that just came on the market, the Mounjaro, is the trade name in the United States. That's a GIP, gastroenterotropic peptide, and GLP-1 agonist. So this agent, it does what the body in a normal person does. It increases satiety and it slows gastrointestinal absorption and causes increase in insulin, and there's weight loss. Now, the weight loss has to do with the satiety that we have in the brain. And this agent, the new agent, the GLP-1 GIP agonist, it offers up to 20% weight loss in patients over 72 weeks that the studies have shown, and it offers about a 2% reduction in hemoglobin A1C that I'll explain further as we go along. So now, apart from the oral agents, we have insulin analogs, meaning insulin types of insulin that work the same way. So the insulin is a peptide, there's replacements of amino acids, and you get the duration of action being different with insulin products. So we have the long-acting insulin. The long-acting that you see, the green line and the yellow line over there, those are insulin agents that act over 24 hours, and we use them once a day. And then the rapid-acting insulins are the other curves that you see that we use for meals. And this is the way most of the patients administer insulin nowadays, with insulin pens, where they change the needles with each injection. Now, it's important to understand what we look at when we treat a patient with all these agents. How do we combine these agents? And we go according to complications that a patient may have, cardiovascular complications, kidney disease, for example, liver disease, and the hemoglobin A1C. And what is hemoglobin A1C? It's the 3-month sugar average. So it's one blood study that tells us over the past 3 months how well controlled the sugar is. So we want the sugar to be less than 7% in most of the patients. That's our treatment goal. And if the sugar is greater than 7.5, as you see here, we intervene with medications. Usually we go with one medication, one agent, and when the hemoglobin A1C is between 7.5 and 9%, we combine agents. So we go 2 oral agents that differ in their mechanism of action. We can go up to triple therapy. And then if we have a patient who comes in with hemoglobin A1Cs greater than 9% or average blood sugars greater than 200 milligrams per deciliter, there we look at symptoms. If the patient is symptomatic, diabetic symptoms include numbness and blurry vision and thirst and polyuria, then we administer insulin. If not, we try to continue with the oral agents, diet, and exercise. So these are various algorithms that have been developed by the major societies, the Endocrine Society, American Diabetes Society, Endocrine Society in Europe, and the American Association of Clinical Endocrinologists. So the therapy nowadays is a combination therapy, and with oral combination, we can use all these agents that you see here that work in different ways. The biguanide is the metformin. That's the cornerstone, the initial agent that we use if there's no kidney disease. And the combinations that you see here have been many studies that have been published. And in some of these studies, my brother and I have participated in office research and hospital research. And then we also have insulin combination therapy, where we start with the oral agent, we go up to 2 or 3 oral agents, and then we add the insulin, the long-acting insulin, to get that sugar control, hemoglobin A1C, less than 7.5%. But the important thing to understand is that we have to tailor it to the patient. And why do we have to tailor it to the patient? Because there are some modifiable factors and other non-modifiable factors. So as you see here, the disease duration, life expectancy, the comorbidities is something we cannot change. But we can change the attitude and expected treatment efforts and the resources and support systems that we have. So these management goals have been published in one of the major books in endocrinology, where my brother, who was at Columbia, now at Ohio University in Athens, Ohio, is professor and chairman of endocrinology. We published the management goals and the principles of diabetes management in 2015. And I want you to see how we work in the office and in the lab. This is a machine that gives us within 5 minutes the average sugar, that hemoglobin A1C. So this is something we can do in the office. And depending on the hemoglobin A1C, we can figure out how to administer and what type of therapy we're administering. Also, we have continuous glucose monitors now. And continuous glucose monitors means you put an electrode here, a little disc on your shoulder, and you have a monitor, a reader, what we call, or the iPhone or the phone, the cell phone, that can follow your sugar every minute for 24 hours and longer. These monitors are put on for 14 days. And you can get nice curves and know where your sugar is during the day and what types of adjustments need to be made. Here it has to be understood that what we're measuring is interstitial fluid, which is close to blood, but it's not blood sugar that we're measuring. We're measuring sugar that is about 10% almost 10% related to blood. But where the therapy is going is combination therapy with telemedicine. So what we're working on now is we're working on a cell phone application where the patient can communicate with the health professional regularly. And what happens is we enter all medical records on the database, including the CGM. When the patient enters their diet, their exercise levels, stress, sleep, medications, and adherence to medications. And then we look at improvement in health outcomes over weeks. And we've been seeing an improvement, a loss of weight. We've been seeing a decrease in hemoglobin A1C And we're looking at long-term complications. This is going to take longer, where we're going to be studying the neuropathies and the microvascular complications. This has become very interesting for the insurance industry because it lowers the cost of diabetes care. At this point, are pilot projects that we're doing in the offices, and hopefully this can move on into the community. Thank you for your attention. We're going to move ahead now with the next speaker, Dr. Kales from Boston, our professor at Harvard Medical School and Public Health. He's going to talk about the Hellenic Center of Excellence. Thank you. Okay, you also.
Good afternoon. Spiro, thank you very much for the invitation. Καλό μεσημέρι σε όλους. I have the privilege to speak to you today about the Hellenic Center for Excellence in Health and Wellness. At the conclusion of my talk, I will extend to you a personal invitation to attend our inaugural conference at the Grec Hotel's Creta Palace Hotel in Rethymno for an experiential conference, which I'll explain going forward. As Greeks, we should all be very, very proud that there is a very, very strong and widespread consensus that the so-called Mediterranean diet is the healthiest eating pattern for almost everyone in every country. This so-called Mediterranean diet is actually based on the traditional Greek diet and is a prototype in Crete. But it's also now recognized as, by the US government, not only as a healthy eating pattern, but it's recommended for all Americans. This was true in 2015 and again in 2020. The next recommendations will come in 2025, but I don't expect them to be any different. Today's #1 diet, again, is based both, as our first speaker said, on Greek philosophical as well as cultural traditions, including Metron Ariston, so the wisdom of the ancients. And as you can see, and you all know already, I won't go through them, but the health benefits are myriad. Again, referring to the ancients, the father of medicine, Hippocrates, he was wise enough to divide medicine into 3 branches. Physics, meaning pathologia or internal medicine, surgery, but also dietetics, from the ancient Greek word dieta, which didn't just mean diet in ancient Greek, it meant way of life. And as Professor Mezitis just said, talking about diabetes, lifestyle choices are key in all of the chronic diseases that plague us today and that plagued us throughout the pandemic. However, most of medicine, and probably it's even true in this conference, lifestyle is ignored. The focus is on medications, technology, and surgery. Thus, there's a need for such a center. What will the Center of Excellence do? We seek to advance healthier food and lifestyle choices worldwide, not just for Americans, not just for our foreigners, but also for Greeks. Using the traditions and history of the Cretan diet as the gold standard reference point for learning and research, the center will couple varied education and research offerings with hands-on immersion experiences in Greece. This center will operate as a nonprofit entity, which is being formed right now in the US. Already, we have world-leading scientific and gastronomic advisors from Harvard and other fine institutions such as Yale and the Culinary Institute of America and the Athens Academy. These preeminent advisors not only bring their prestige, but they allow us the benefit of extended collaborations, cooperations for interdisciplinary and international research. And we utilize a smart strategic operational business model. That is, rather than asking the Greek government for millions of dollars to build a conference center, we have a strategic partner, which is the large Greek hotel chain Grec Hotel. Grec Hotel has a strong base in Crete, but we also have the flexibility of 40 different hotels in 12 top Greek destinations. This business model is not only consistent with the Greek National Tourism's organization strategy of η Ελλάδα του Ευζήν, or Greece of the good life, or Greece of wellness, but also the ministry and GNTO's mission for tourism 365 in Greece. So this means tourism throughout the year. And as you know, Crete has the climate with more than 300 days of sunshine a year and mild temperatures, both in the summer and the winter. It's an ideal setting. You can see here the locations of Grec Hotel. So this gives us flexibility. We can have conferences in Cape Sunio or Kerkia or Rhodos, but for now, the focus is on Crete initially. So a nonprofit in the USA and a strategic partnership with Grec Hotel. Among the pre-existing infrastructure of Grec Hotel is included the experiential organic farm and restaurant called Agreco Farms. This is a fascinating, wonderful place, 5 minutes from the Creta Palace Hotel in Rethymno. A vision of the founder, Mr. Nikos Daskalondonakis. It's a recreation of a Greek village where children and adults, Greek and non-Greek, young and old, can relive the experiences of a Greek village, hands-on, baking paximadia, milking a goat, etc. Why Crete? Historically, what we call Mediterranean diet is really based on the Cretan diet. And this is proven in modern history back, if you get the book from Princeton Press, the Rockefeller Report, the foundation in the 1950s, to their surprise, they discovered, going to a region of poor people who were suffering after a war and a civil war, that in fact, their diet of poverty, but also Greek Orthodox fasting, was a healthy one. They had adequate calories, but healthy calories. This was further proven in Ansel Keys' legendary 7-country study. While Keys was enamored of Italy, in fact, the Greek populations of Kerkyra, Corfu, and Crete outperformed those of Yugoslavia and Italy. Crete was the star of this study, with the longest life expectancy and the lowest rates of heart disease as well as cancer. So what Ansel Keys actually then afterwards named Mediterranean diet, the goal, or the prototype, the gold standard was Cretan diet and the traditional Greek diet. What has happened so far with the center? So in May, there was a closed symposium held by the Pontifical Academy at the Vatican in Rome. I was privileged to be a speaker there, and I had the honor to announce the center for the first time officially within the confines of the Vatican's Pontifical Academy. Immediately following the Vatican meeting, together with Grec Hotel and under the auspices of the ministry, the Greek National Tourism Organization, the tour operators of Crete, and also the auspices of the governor and the region of Crete, we brought elite professors from Greece, Spain, Harvard, and other leading institutions to Crete. In the words of Frank Hu, who was our current chairman of nutrition, someone who grew up in China and did medical school in China, and he's been studying Mediterranean and other dietary patterns for 30 years. But this was the first time that he really understood why the Cretans were so healthy, and he termed it monadiki ebiria tis zois. He said to the Greek, in English, it was his once-in-a-lifetime experience. As you can see from Kathimerini and also Cretan newspapers, the press coverage today, both in Greek, as well as in English, has been extremely positive and very helpful. And moving forward, we hope not to offer just continuing professional education, but next season, starting with wellness and medical tourism, but not medical tourism to fix your teeth or have an operation, for wellness, for achieving a better lifestyle, a farm store, both physical and e-store, olives, olive oil, and wine, education, and research. So, in closing, I want to tell you about our inaugural offering. Will be Cretan lifestyle, Mediterranean tradition, and modern applications. It will be held at the Creta Palace in Rethymno from November 7 to 11. This conference will couple elite educational offerings from Harvard, Yale, and other leading institutions and European institutions with hands-on immersion. The conference participants will see, they will hear, they will taste, they will try, and they will taste more, and they will live unique and unforgettable experiences in Crete, inspired by the land of Crete, the people, their history, and their legendary hospitality. Philoxenia. You can see here from the preliminary program, we have faculty from Harvard, the Culinary Institute of America, Yale, from Spain, from the Predimed study, Professor Martinez, the Athens Academy, Professor Trichopoulou, and all of the people that you see here are among the advisors that I mentioned, the preeminent advisors that we already have and count with at the center. So, in conclusion and respecting the time, I invite you November 7 to 11 to Crete, to Rethymno. You can see the hotel on the left. It's gonna be a little rough. You'll have to rough it. It's not that comfortable, okay? And you can see the farm on the right. So I think you'll enjoy. I appreciate your attention. Spread the word and enjoy the rest of the conference. Congratulations to the other speakers.
Stephanie, congratulations. Great talk, great leadership, and it shows what Greeks can accomplish when they get together. Next, we'll have Dr. Dimitrios Markouizos, our pediatrician, here speak on epigenetics and childhood obesity. A very well-known pediatrician in New York City and a leading member of our Hellenic Medical Society of New York. Thank you, Dimitri.
Thank you for the presentation. Good afternoon. I was going to say good morning, but it's good afternoon. Kalispera σας. First of all, I want to thank the organizing committee for the invitation. I'm very honored to be here to participate in the medical forum with esteemed colleagues around the world. And I'm very, sentimental because I'm back to my Thessaloniki, which is my birthplace. So what's happening here? Unfortunately, Greece is not spared from the epidemic of obesity. In 2017, as you can see here, 4 out of 10 children were considered to be overweight. So is obesity secondary to nature or nurture? Is it genetics or is it environment involved? Or both? We'll discuss that. Discussing the genetic causes of obesity basically is divided into single gene defects, for example, leptin deficiency or MC4R deficiency. When multiple genes are involved, that's called polygenic, obesity. But when environmental factors such as diet, exercise, endocrine disruptors, the microbiome, viruses and parasites are involved, which interact with genes, then we have what's called the multifactorial obesity, which is the most common cause of producing obesity. Some genetic syndromes that you should be aware of, which are related with obesity, is the Prader-Willi syndrome and the Bardet-Biedl syndrome. But remember, genetics alone and overeating of food cannot explain the increased prevalence of childhood obesity. There was always genetic susceptibility present, but it's becoming more and more evident due to the influence of the obesogenic environment. As you can see here, identical twins, the same genotype, different phenotype. Why? Because they were raised into different environments. The contribution of the genes into the obese phenotype is about 40 to 75% of the time. So what's epigenetics, our talk of today? It's a Greek word, as you know. Above genetics or beyond genetics is a study how environmental factors can cause changes that affect the way your genes express themselves. But, remember the word but, without altering your DNA sequence. So what's gene expression? It refers how often and when proteins are made from the instructions of your genes. While genetic changes can alter which protein is made, epigenetic changes affect gene expression by turning genes on or off. So is epigenetics the link between nurture and nature? Is it the link between your genetics and the environment? Possibly. So let's discuss the mechanisms of epigenetic modifications. These are the most common ones, which I will discuss. It's the DNA methylation, histone modifications and chromatin restructuring, and microRNAs. DNA methylation, you can see a cytosine base with the enzyme DNA methylase transferase. You add a methyl group in the 5th position, and you get methylation. As you can see here, when you methylate the CpG islands, which is right next to the promoter, then you have the gene expression repressed. The transcriptional process is turned off. Where you unmethylate on the tops, then you have gene expression present because you activate the transcription process. Some of the DNA methylation facts and examples are the following. DNA methylation happens to be erased during early gametogenesis and early embryogenesis, and then is reprogrammed thereafter. It's a reversible process. It's an inheritable process. It's usually a stable process as well. And it can be also labeled as transgenerational, meaning it's transmitted from one generation to the other. Some examples are X chromosome inactivation, genomic imprinting, and cell differentiation, where a pluripotent cell becomes very specialized. We need DNA methylation to happen. Histone methylation occurs when histones are the proteins that the DNA is wrapped around very tightly. Here, the histone tails have lysine, K stands for lysine residues. When you methylate these lysine residues, for example, K27 or K9 at the histone tails, you happen to close these structures, and therefore methylation represses the expression of the gene. In some occasion, when you methylate K4 or lysine number 4, you open up the structure of chromatin, and therefore you activate the gene transcription. Histone acetylation is more straightforward. When you acetylate, you open up the chromatin structure. The chromatin structure is relaxed. Transcription is activated. But this is a reversible process. When you deacetylate, then the transcription process is repressed because of the condensed chromatin. MicroRNAs are non-coding RNAs, and they happen to bind the messenger RNA. And when you bind the messenger RNA, basically you have no translation process occurring, and therefore no protein synthesis. So the mechanisms that I discussed that involve with epigenetics is DNA modifications, histone modifications, and RNA modifications. But they have to work with the environment, the interaction with the environment. So when you have an obesogenic environment, which I will discuss, then the situation is as follows. Maternal and paternal exposures to environmental factors such as diet, overnutrition, undernutrition, obesity, exercise, heavy metals, supplements, and so on, can lead to epigenetic changes in the gametes, the sperm and the egg. These exposures can continue in utero and can cause changes in the fetus, epigenetic changes in the fetus. Many of the pathways can be affected. Adipogenesis can be affected, gut-brain axis, and fetal growth. This is very important to know, and if you forget everything that I told you today, because it's a little confusing because of genetics, remember that the BMI of the mother during utero or even pre-pregnancy is one of the most important contributing factors whether the child will become obese or not. If one parent is obese, there's a 50% chance that the child will be obese. If both parents are obese, there's up to 75% chance that the child will be obese. These epigenetic changes are also found in early infancy, childhood, and remember also that when you have an obese child, the likelihood of becoming an obese adult is very high. Let's show some example. Insulin-like growth factor is an imprinted is produced from an imprinted gene. For those who don't know what imprinting is an epigenetic phenomenon that causes the gene to be expressed on one parent and silenced on the other parent. We have about 100 imprinted genes in our genome. So it happens that the the insulin-like growth factor number 2 is expressed in the father in this situation and is silenced in the mother, as in the Prader-Willi syndrome. They found out that paternal obesity is associated with hypomethylation of the IGF-2 imprint center. And when you have hypomethylation, what happens? It's associated with increased levels of the IGF-2 protein and therefore higher birth weight. One of classical examples of transgenerational epigenetic inheritance happens to be the Dutch famine. Children exposed to the famine the first 10 weeks after conception had less DNA methylation of the imprinted gene IGF-2 than the unexposed same-sex siblings. They also found that we had also increased levels of DNA methylation of the leptin gene for those people that were exposed to the famine. Also, the first generation and the second generation patients had increased risk for cardiovascular disease, diabetes type 2, and metabolic syndrome. Are genes your destiny? The FTO gene, the fat mass and obesity associated gene, when people carry that gene, you gain more weight, usually. But exercise has been shown to attenuate the expression of this gene, to decrease the expression of this gene. So maybe genes are not your destiny. What are the future directions? Epigenetics is still in early stages. The challenges are timing of epigenetic alterations and DNA methylation and its consistency in different tissue types. But knowing of these epigenetic modifications will lead us to development of new interventions and strategies of critical periods to reduce the risk of obesity. And finally, what are the ultimate goals here? Obesity epidemic is a real threat to any society. The costs of obesity are staggering. In the United States, they spend over $15 billion a year to manage pediatric obesity and close to $200 billion to manage adult obesity. So the numbers are extraordinary. And here, Greece, if you want to destroy a country financially, you let obesity get out of control. So what you should do? We should develop guidelines, policies, and preventive measures to combat pediatric obesity. And remember when I told you, limit the weight gain of an obese woman or overweight woman during pregnancy or even before pregnancy. Breastfeed the children. It's been found to reduce pediatric obesity. Use the rule 5-2-1-0. 5 stands for 5 fruits or vegetables per day consumption. Limit the number of hours, less than 2 hours of television time or screen time, 1 hour of activity a day, and 0 numbers of consuming of any juices or sugar-sweetened beverages. Remember, an obese child will become an obese adult. Let's focus then on the healthcare and the health of our children, the future of our country, and the society as a whole. Thank you very much.
Thank you, Dr. Marquizos. Excellent talk, and we always need to be thinking of what you're saying. And this marries the two subjects with Dr. Stefanos Kallis in your talk. Thank you. Next, we'll have Dr. Marietta Varvarikos here from Montreal, Canada, who's joining us. We're honored. She is associate professor at the University of Montreal, and she's going to speak to us about the emergency room and CPR guidelines. But I also want to say that she's been for years vice president of the Hellenic Medical Society of Quebec and leading member of the Federation of Hellenic Medical Societies of North America. Thank you, Marietta, for being with us.
Thank you, Dr. Mizziti. On behalf of the Hellenic Medical Association of Quebec, I wanted to thank you, especially for your invitation. You've always included us, and thank you to the organizers of the forum for having us here. It's our pleasure to be with you. I wanted to go through very quickly. It's going to be a challenge for me in the next 10 minutes to try to see what the recommendations for resuscitation are, and they're international, just to let you know, and to see what differences there might be here in Europe. Why would there be? The European Resuscitation Council is a member of the International Liaison Committee on Resuscitation, therefore there should not be many differences, but there sometimes are. I wanted as well to look at what still matters in resuscitation, and this is really important for you to understand. Because although we speak of medication, there are different techniques, what matters right now in terms of survival is really defibrillating early and high quality chest compressions. That, without a doubt, when the experts in the international committees gather together, that clearly shows better outcomes in survival. So CPR is really important, and a big congratulations to countries that encourage their CPR classes in the younger populations for those who are over the age of 12. I'm going to look at something that we've done in our hospital. We are a big university-affiliated hospital. I work at the CHUM, the Centre Hospitalier de l'Université de Montréal in Quebec, Canada, and we have a lot of personal support workers, and they do most of our chest compressions, our human chest compressions, and basically we have a big challenge because as master instructor of the Heart and Stroke Foundation, you can give accredited classes, and that is highly encouraged. It shows good outcomes. However, it's a challenge to try to train all of these people and have them regularly recertified. I have absolutely no conflicts of interest. I'm not paid by the Heart and Stroke Foundation. I give their classes, but I'm not paid by them. I just wanted to go back to the fact that founding members we have all over the world in terms of resuscitation. The European Resuscitation Council is a founding member of them. However, when you look into their guidelines, and I went into only the adult life support because I wanted, there's too much. I mean, we resuscitate, we do basic life support for the populations, the general public, and we go out to children, but there was a lot to look at. And I just wanted to give you the messages that we do not transmit to the people that we teach in North America. And we hold hands very closely with the American Heart Association, the Heart and Stroke Foundation. I just wanted to let you know there's one difference in terms of shocking. If there is a semi-automatic defibrillator somewhere here in the music concert hall, you will see that it is programmed to give one shock. Here, it is clear. I don't know if I've lost my microphone. I think, no? Am I okay? Can you still hear me? Perfect. So I just wanted to let you know if I go into a heart attack right now and it's sudden, obviously it might be from a shockable rhythm. So you're going to find that defibrillator and you're going to shock me once. Just wanted to let you know that they do make an exception on the European side saying, you know what, if your patient is monitored, which wouldn't be my case here today because I'm not on any monitor. If I was monitored, it was witnessed and it's a shockable rhythm, you can make that exception of giving 3 stacked shocks. So that's an exception they make. However, when they go into the definition of what refractory shockable rhythms are, a refractory person, so you've shocked me once, you've done 2 minutes of high quality CPR, you've shocked me a second time, you're giving me 2 minutes of high quality CPR, that third shock is the definition of refractory shockable rhythm. It's just to let you know that if I've done 3 stacked shocks in Europe, it's not considered refractory. You have to have done at least 4 minutes of CPR to consider me as being refractory. So it's really just something that we don't teach. The reason why is it's clear for the Europeans as well that when we look in the literature, when you minimize chest compressions, you're obviously taking away from survival rates. So we have to keep on the chest as much as possible. Shockable rhythms when it's refractory and you've shocked me 3 times and it's been 4 minutes of CPR. In advanced life support, we give medications and there's a big debate. They went into a big, a prospective randomized control trial which compared placebo, amiodarone, and lidocaine. There is no difference between amiodarone and lidocaine in the United States, in Canada, in North America, and probably in other associations that are members of the ILCOR. They basically say choose one or the other. The Europeans went out and said, you know what? Our national resuscitation councils will vote on this and look at the literature again. 21 out of 24 voted for amiodarone. Therefore, they say, I don't know if this is done in practice, but they say amiodarone first. And if you don't have lidocaine, if you don't have amiodarone, just give lidocaine. Chest compressions are fundamental. Like I said, the only time you're not chest compressing on me is if you've decided to give me 2 ventilations, 32. If there's analyzing a rhythm, the defibrillator, if he's analyzing, you cannot chest compress me. And if you're going to shock, you're not going to chest compress. Those are basically, in summary, the only 3 times you're not chest compressing. However, in the European Resuscitation Council guidelines, they do say, well, you know what, you can make some exceptions, which we shouldn't theoretically, because we know that we have to minimize interruptions as much as possible. But they say, for example, one example they gave was, you know, if you're intubating, basically, you know, you can ask that chest compressor to stop a few seconds so I can intubate the trachea. In our institutions, basically in North America, we say you're not able to, you find a better operator, you find another solution, you wait for return of pulse, and then when you don't have chest compressions, you intubate the trachea. As much as possible, do not take away from the chest compressor. And the other one was the bradycardia, unstable. Just to let you know, I've never taught this technique. I've been working in the emergency room for 20 years. I've been teaching since I've been a resident. And basically, I've never taught the technique of fist or percussion of the chest, which they describe in detail, to be honest. And this can be done when you have an unstable bradycardia. The ILCOR, International Liaison Committee on Resuscitation, says this type of a technique, it's giving basically, you know, chest blows on the lower part of the chest in order to mimic an external pacemaker at the rate of 50 to 70. This can be done if your patient is going to be going into cardiac arrest. This is done, and it's very, you know, it's a temporizing measure. It's extremely exceptional, but this is something that we don't teach. I was speaking to my cousin who's in the room today. She's a resident. She's here in Greece, and she is going to be doing emergency medicine. I told you, have they taught you this in the accredited ALS course here when you were doing this? And she goes to me, I've never heard of it. To be honest, maybe it's written in theory. I don't know if this is taught. Oh, did I just close my presentation? Sorry. So ILCOR, International Liaison Committee on Resuscitation, does recognize that there are gaps. If you look at their consensus statement at the end, they realize, you know what, there's so many topics in resuscitation, yet we need so many studies. And I decided once again to choose what matters, which is defibrillations and chest compressions. And this is what makes a difference in survival outcomes in our patients who are in cardiac arrest. They speak about eCPR, and this is sort of like a cardiopulmonary bypass that we can do on patients who are, again, are refractory to shockable rhythms. Once again, you've shocked me twice, you've done 4 minutes of CPR on me, I'm not responding, that's what's considered refractory. And this can be considered, however, it needs to be, first of all, it's not the traditional technique, it's not an open chest that we're doing, it's percutaneous, you know, catheters that we're putting in the femoral vein and the arterial vein. This is done in my institution, but in hospital. Congratulations to the United States. In 2020 in Minnesota, they're going on the streets with ECMO mobiles. They're doing this in their community trucks that probably would never go anywhere in any European city probably, but they're humongous operating rooms that are running around. And congratulations as well to the teams of Paris, the SAMU, Dr. Lionel Lameau, who goes out even into the Louvre in 2016 to do an eCPR on a patient who had collapsed in their museum. So it's just to say this is done in the community, but in international liaison community resuscitation, as well as the Europeans, say we don't have still that criteria to know exactly which are the best candidates. And this needs perfusionists, this needs people that have the experience, the expertise, and the equipment to do this. And that's why it's still not a standard of care. What about if you put 2 defibrillators on me? I'm not talking about the semi-automatic, but we're in a hospital setting and we have manual defibrillators, or you have a paramedic team that is advanced and they have manuals. Can you shock me twice? I've not responded to 3 sets of shocks. So you've done 4 minutes of CPR on me and I'm not responding. What about setting out a second defibrillator in a different position on me? So you're doing the traditional anterior lateral and then you're putting one anterior posterior. What about shocking me sequentially, not at the same time, because you're going to burn the machines and you're going to you're going to do one at a time, but you're going to do them sequentially. Would that make any change? It is clear the European Resuscitation Council says this is not a recommendation. We don't have enough studies on this and they do not recommend this. This is very clear. They're against it. Only if you're doing this in a research setting. If you're conducting a study, this is permitted. However, do not do it. On the International Liaison Committee, they mentioned at the end of the text a trial that was done, a pilot trial, and it's a Canadian pilot trial. And it's really interesting. They went out in the pre-hospital setting and they said, you know what, we're going to see the patients that don't respond to 3 sets of shocks and we're going to randomize them. We're going to put them, one is going to have conventional CPR, so we'll just continue doing those 2 minutes of 32 and then shocking them every 2 minutes if it's still shockable. And then we'll put the other group into changing the vector, changing the pad placement on the chest, and then the other group will just do double sequential defibrillation, so 2 monitors to shock them. Did they see a difference? This was a pilot study that was basically done, just to see if this was feasible and if there was no harm, because it's, with double energy on a patient, you want to make sure there's no harm, and you want to make sure as well that you're not going to blow up your equipment. Anyways, it seemed feasible. This is a trial. Basically, it's from Toronto, a group of Toronto, but they're doing this in the pre-hospital setting. This is from a neighboring province near Quebec, Ontario. They're doing this in Ottawa, London. They're big urban cities. They're going to try to get 400 people. They're doing this right now, and they've randomized them in those 3 groups, and results are coming back out in September of this year. And basically, we'll see if double sequential or changing pad placement on the chest make a difference in those who are not responding to shockable rhythms to 3 shocks, who are refractory. So this is just something that I wanted to speak to you about. Does it make a difference if I'm doing manual compressions or if I have a mechanical apparatus on me? And to be honest, humans are just as good as machines. There's no difference in the literature. When the experts look at this, there's absolutely no difference. What it is, however, it is practical. So when it's impractical or unsafe, basically it's good to have this mechanical apparatus. If the resuscitation is long, if you're doing an intervention, like for example, ECPR or any other type of intervention, basically it's helpful. It's costly, however, extremely costly, even in euros, Canadian, American dollars, or anything, it's very costly. And the other thing is you need to train your personnel, because the problem with this is if you don't set it up properly, it moves around on the person and it can create harm. The other thing is if you don't know how to install it, you're taking away from chest compressions, which we just said is really important in terms of survival for our patients. So you have to be trained for this. My hospital, basically, we have 730 beds, 70 beds in the ICU. We have about 270 intra-hospital cardiac arrests per year, and about 50 outside of the hospital come into our emergency rooms. And we have about 870 something personal support workers. They're like orderlies. That's sort of our synonym, but these are the people that do our human compressions in our hospital. And like I said, this is our challenge. How do we train them? Because we realize that when we do simulations, mock codes, training sessions, they're not that good. And at the same time, in real time, we realize we're having difficulties. So what do we do to train them? We looked at the literature, and the literature says, International Liaison Committee says that basically, you know what, we do not, over time, we basically lose our quality in CPR. It was difficult for us to try to train according to the Heart and Stroke Foundation, and it was going to be costly for institution. So we decided to look at what is supposed to be a good training session, and the International Liaison Committee on Resuscitation put out recommendations for how to teach effectively, because it is really clear that if we give effective teaching, we're able to save lives as well. So we decided to follow what they were saying, and they were saying if you do deliberate training, short training sessions that are simple and basically, that are repetitive, and you have feedback that's given to you, and you have objective assessments, and you are training your trainers, basically, you know what, you're going to get good results, probably in theory and practice, and maybe in real time as well. So we were able in May of 2019 to train 600 of our personal support workers in about 5 days, and we worked nonstop 24 hours a day in our hospital, putting up stations in 4 strategic areas. You saw a big hospital, and asking people while they were at work to come in to do 20-minute sessions. They were being paid during this time, and the people that were training them were being paid as well. We went out and said to our hospital, you know what, we think what we did was good, let's see the results. And basically, we published this, the research team, this is not me, I was a part of the resuscitation education part of the team, but the research team put out the results and said this proved to be effective for chest compression performance, and this hospital saved so much money. It was 3 times cheaper than having done an accredited BLS course for this for the personnel. 10 months later, we said, but are there long-term effects in this session that we did? For publication purposes, we called it the timely chest compression training. That wasn't the name that we had given it initially. And when you look back, we went back and published a second study, and basically, it shows that the people that had followed the session 10 months before had 50 chances better of getting an excellent score during our second session. The sample size of the study The second one that we did was a good size. However, it was done in our center because it was contextualized and adapted to our center. We decided that we were not going to do more than just chest compressions. We weren't going to do the whole chain of survival for our personal support workers. We was measured on mannequins. So the mannequins basically were giving feedback on how deep the chest compression was. It has to be a third of the chest. How quick it was. It has to be 100 to 120. If there was good recoil, they were getting metrics on that, and that's how they were being measured. There was also possibility of a convenience sample as well. Congratulations to the research team from my hospital who went out and put out these results. Our institution now only does this for our personal support workers. How did we get this involved? Because my colleague, Dr. Mezziti, says you have to tell them something that they can bring home. I don't know if this is reproducible in your centers. However, all I have to tell you was congratulations as well to the teams that were, training them, because we worked nonstop. We were also getting people from the floors. We knew exactly when they were working at what times, and if they weren't showing up for their training session, we were going back and getting them. So this might not be very easy for your centers, but it's something that is possible and that we did. Remember, in conclusion, the basics are really important. It's chest compressions, quality chest compressions, and defibrillating early. The best outcomes, the studies that I spoke to you about, show probably maybe we'll show something in terms of return of a pulse. I get someone back and he's coming back, he's come out of his shockable rhythm and he has a pulse. That's a good result, but that's not what we look for in resuscitation. We look, and this is what we tell our people, we want the people to come back exactly as they were before their cardiac arrest, neurologically intact. And that's the best results you can get in resuscitation studies. And I hope that what I've showed you from what our hospital did inspires you in doing something that's contextualized, simple, deliberate, and something that you can do repetitively for your centers in order to get the best outcomes for your patients. Thank you very much. And if you have questions, you can always email me as well.
Dr. Barbaricos, for your excellent talk, animated talk, and we hope we don't have any cardiac arrests here. Next, Dr. Stella Liberi's here, our professor of radiation oncology from NYU, will be introducing our next speaker, Dr. Alexandra Soldato.
Good afternoon. This year, in March, at the Hellenic Medical Society, we had the pleasure of honoring a NGO, a philanthropic organization that is doing very important work in Greece. And I wanted to just introduce Dr. Alexandra Soldatou and also send a message to all the physicians here of the diaspora that we can go beyond ourselves and our own practices and our own geographic location and identify philanthropic initiatives that really make a social and important impact to better society here in Greece by collaborating with organizations that do important work. The ELISA organization addresses child abuse. And I would like Mrs. Vana Marketaki to stand up. Outside, there is a booth in person that you can learn about the role of ELISA and its impact. Since its conception in 2008, they have educated over 6,500 physicians in detecting child abuse and helping to determine a methodology of impacting change. There's also many important webinars to educate doctors in screening, triage, and the management of child abuse, as well as the development of child safety acute care units in the hospitals here in Greece. Through our collaboration and within New York, they fundraised and they were able to open a unit here in Thessaloniki. So this is something we can all help, these initiatives, working from home to support the philanthropic efforts done here in Greece. It's my pleasure to introduce Alexandra Soldatou, Associate Professor of Pediatrics of the National and Kapodistrian University of Athens Medical School.
Thank you, Stella, for the kind introduction. It's a huge honor for me to join you. And hopefully in the next few minutes, I'll be able to share the work we've done over the past 7 years with the NGO ELISA. Having some trouble with sharing my screen. Okay. I hope you're on. Can you please let me know if you can see my slides? So can I go on?
Yes, please continue.
Okay, thank you. I could not hear you. Okay, so what we've done over the past 7 years is to establish some kind of response, of healthcare system response to a grave, a very challenging public health problem called child abuse and neglect. And I have the definition by the CDC because it focuses on even an isolated act from a child's caregiver or a lack of an act from a child's caregiver that might lead to a harm. So the focus is shifted from a severely battered child with a very broken and dysfunctional family to even an isolated incidence of abuse that might present in the healthcare system with very subtle findings. And that's where the opportunity is to intervene on time and prevent the loss of the child and the loss of the structure of the family. So it's what's very rewarding with this work is that it's a totally preventable condition. So what we use is the approach that we use in any pediatric healthcare issue. We need to know the red flags of the problem and be able to detect it. And we always keep the possibility of child abuse and neglect in our differential diagnosis. Then we need to know where we can focus on our clinical examination, the laboratory investigations that we need to request in order to establish our diagnosis, and also imaging studies play a very big role in recognizing the problem of child abuse and neglect. And without recognizing the problem, you're not able to take your treatment measures and manage a problem. Particularly in the case of child abuse and neglect, there are specific challenges because usually as physicians, we rely on an accurate and reliable history. In this instance, caregivers often do not want to face the consequences of their acts or lack of acts, as we said. And most victims of child abuse and neglect are pretty young. They're under the age of 3 years. So they're not developmentally able to talk and tell us what happened. And older children are often reluctant to actually tell us what happened because they're afraid of the consequences for their caregivers. And we as physicians are quite biased when we face these problems. We suffer from this nice family syndrome, meaning that I cannot believe that a family that looks a lot like my own could cause harm to their own child. So there comes the iceberg. This is a very challenging iceberg because the children we know about, that we hear about in the newspaper, are usually the only visible cases. Severely abused children that might lose their lives or remain disabled for the rest of their lives. So here comes our role. If you increase physician awareness, apply universal screening strategies in the healthcare setting, provide practical, easy to use clinical tools, and use an evidence-based approach, you can hopefully translate science into practice. And that's what we try to do in Greece. So Eliza managed to gather a very strong and committed team. Professor John Leventhal from Yale University has been an amazing mentor and teacher for all of us. He has actually introduced us to the rest of his team at Yale. And then my teacher, when I was a resident, Professor Resmiye Oral from the University of Iowa, who moved on to Dartmouth, have been very close collaborators in this effort. And from the University of Athens, apart from pediatricians, we now have the addition of colleagues from forensic medicine and the Department of OBGYN. And we all, what the core team tried to do is engage experienced pediatricians from all 7 medical schools around Greece to join this effort. They were empowered and trained both in physical and sexual abuse with a train the trainer module, and then went on to give this knowledge in several national campaigns. Before the pandemic, there was a national campaign that was conducted in person with 1,200 participants from all over the country. And we've conducted already 2 virtual campaigns with 1,600 virtual participants for physical abuse and 3,350 virtual participants for sexual abuse. So we've spread the word as much as we could. And we also provided several practical clinical tools that help with screening. They help with documenting what physicians may see when they examine children, and also move on to collaborating with colleagues within the hospital and also child protection services outside the hospital. And that can be done ideally in a private and child and family-friendly setting like the Child Safety Care Unit we have at the Children's Hospital of Athens. There is a second Child Safety Care Unit at the Gon Hospital. And hopefully very soon, there will be 2 more child safety care units in Alexandroupoli and Thessaloniki. And just to show you the impact of our work, we started our work in 2016, and you can see already at the beginning of our efforts that the number of children referred for the possibility of abuse rose significantly, and there's a doubling of the cases we saw from year to year. And interestingly, there's also an increased number of children with potential sexual abuse examined in our setting. And also, as far as the healthcare system is concerned, you can see the growing number of children evaluated in the outpatient setting, avoiding unnecessary hospitalization for these children, and also the length of stay during the evaluation has dropped significantly over the years, signifying better collaboration and improved coordination of the children's care. So I think there's a definite cost associated with child abuse and neglect, and we can save a lot of money by establishing and replicating an evidence-based child safety care model around the country. But we also have a moral obligation to save the children's lives and save families from the intergenerational effects of child abuse and neglect. And of course, a moral obligation to not have a preferential treatment of children who present in one healthcare setting versus another. Thank you so much for having me. My email and the website of ELISA for those of you who want to reach out to us. Thank you.
Thank you, Dr. Soldatou, for your very interesting talk. And I'll ask all the Hellenic medical societies around the world to support ELISA. We will do that as a federation in the United States and Canada. Next, before we continue, I would like to announce that the cardiovascular update is starting in SALTIEL 1. So that's the room next door. Whoever wants to follow the cardiovascular update in terms of time, they're starting now. SALTIEL 1. Thank you. And our next speaker who will be concluding is Dr. Catherine Tsiopoulos from Australia. She will be online. She's the Dean of the School of Health and Biomedical Sciences in the RMIT University of Australia. Thank you, Catherine, for being with us from Australia.
Thank you so much, Dr. Mezitis and Organising Committee for the honour of inviting me today to be amongst such esteemed colleagues. I've very much enjoyed the conference so far, and I look forward to the rest of the conference. And a few minutes from me on research on the Mediterranean diet down under in Australia. My talk is titled The Anti-Inflammatory Potential of the Mediterranean Diet. And okay, sorry, that was a bit slow on progressing the slides. And it would be remiss of me not to mention Hippocrates. Lots of our ancient philosophers have been mentioned today by other professors, but Hippocrates, as Professor Gallis has already mentioned, one of the tenets was diet, way of life, and Mediterranean diet or food as medicine was key to that. And just a few weeks ago, not very far from where Hippocrates was born, on the island of Kos, sorry, my slides are not advancing that well. Sorry, there we go. I was on the island of Leros, and we officially launched the Mediterranean Lifestyle Medicine Institute. The lead, Professor Laparoscopic, established a international group of medical researchers focused on lifestyle medicine, the Mediterranean way, and we will be working, and complementary to Professor Carlos's institute. I'm very much looking forward to coming to Crete, Professor Carlos. We will be working with across the 6 pillars of lifestyle medicine, producing frameworks for general practice to support the implementation of Mediterranean lifestyle medicine across the globe. So just to move back to Mediterranean diet and risk for chronic disease, most of the audience here will be familiar with the depth of evidence in support of the Mediterranean diet for prevention of chronic disease and early mortality. And this very elegant umbrella review by Dinu and Francesco Sofi and their colleagues conducted just a few years ago, meta-analyses of RCT's observational studies, 13 million subjects, demonstrating that for every 1 point increase in the Mediterranean diet adherence, and that's using the Trikopoulos score of 0, no adherence, 9, full adherence, there's approximately 10% reduction in mortality risk from all of these conditions. So it doesn't only prevent cardiovascular disease, which is where the story began, but many chronic disease. So my topic today is how to link Mediterranean diet. What is the way that it operates across all of these chronic disease areas? So diet, how does it affect low-grade inflammation? And we know today that chronic diseases are born at the vascular bed through low-grade inflammation, and that affects every part of the body. And this very lovely cartoon produced by Pontus Anderson, and there is the reference down the bottom, illustrates that we have low-grade inflammation in every cell bed across the body, and concomitantly where those cells are, that leads to a chronic disease that's related. So Alzheimer's, obviously, when we have inflammation in the brain, we've got inflammation in the heart and blood vessels leading to coronary heart disease, and diabetes where the pancreas is involved, and so on and so forth. And what we do in research and in clinical practice is to measure pro-inflammatory biomarkers, which are intermediate markers that can monitor the progress or regret or reversal of low-grade inflammation. And here are some there that we certainly measure routinely in practice. And what we believe the Mediterranean diet does is or the way it works is that it mediates this low-grade inflammation because it is rich in anti-inflammatory nutrients. Now, I want to spend just the next part of the talk just talking about lessons from the Australian diaspora. So the studies that we've done through the years, a good part of 3 decades, I must add, where my work began as a doctoral student in the 1990s, where we conducted the first study on type 2 diabetes using a reconstructed Cretan Mediterranean diet based on Ansel Keys' work, as you've reported, Professor Carlos. And from that point, many other studies across multiple chronic diseases, including dementia, including anxiety and depression, where we've shown reversal of anxiety, depression with Mediterranean diet. Lots of people to thank through the years for that work. Now, that first study, and I would love to share it with you, and my dear late mother, Theano, is there in front cooking dolmades, and Anna is there with her from scratch. What we did was reconstructed the Cretan Mediterranean diet, and we applied it in type 2 diabetes in Anglo-Celtic patients, so they were never exposed to the Mediterranean diet. Many of the ingredients were very foreign. Most of them hadn't consumed even extra virgin olive oil, which is quite ubiquitous now, but some of them had never eaten eggplant or zucchinis. They followed this diet for 12 weeks. We provided all of the food. It was ad libitum, and they loved it. And we found, because this was a crossover study, they wouldn't return back to their usual diet because they enjoyed the diet so much. And we found clinically significant changes in HbA1c in the order of single drug oral hypoglycemic agents, and many other findings which were anecdotal. My skin looks better, I look younger, my friends are asking me, what have I done? So all of these things that we didn't anticipate, which today we measure in studies. Now, before I move on to a couple of other studies that we've completed, I wanted to show you this novel approach to measuring inflammatory potential of diet. And this was a tool designed by Nitin Shivappa from the University of South Carolina in the States, where he did some excellent analyses across multiple studies and produced an algorithm of 45 different diet and nutrient parameters and determined a score. And those diets that scored +8 were very pro-inflammatory, and you can see with some of the nutrients there that are very pro-inflammatory, saturated fat being one of them, trans fats we know, and then -9 is the maximum score for anti-inflammatory, and you can see some of the nutrients and spices, etc., that score anti-inflammatory. So on the left, we have a diet that's very similar to a traditional Mediterranean diet, and on the right, we have a pro-inflammatory diet very similar to a Western diet. And Western diets, or high pro-inflammatory diets, or those that score high, are positively associated with inflammation, high blood pressure, obesity, metabolic syndrome, and coronary heart disease. And what Hannah Ma, who's a doctoral graduate from my team, has shown was that the traditional Mediterranean diet model that she prepared scored very highly, -4.55, very anti-inflammatory, and the low-fat diet only just anti-inflammatory. The low-fat diet didn't have the plethora of ingredients that the Mediterranean diet has, and all these culinary herbs and spices which ensure that it has anti-inflammatory potential. So just skipping through a few vignettes of studies in the interest of time, the OSMED heart trial is a secondary prevention trial, like the Lyon Diet Heart study that many of you may know, where we placed patients who had an MI on either a Mediterranean diet or a low-fat diet for 6 months. It was a parallel design. Dr. Hannah Ma led this study. Professor Colleen Thomas was a collaborator. And what Hannah Ma found was the Mediterranean diet outperforms a low-fat diet in the anti-inflammatory score. I've just shown you that data on the previous slide. Following a Mediterranean diet, and this is participants, so that's the outperforming. The Mediterranean diet is this long bar, very anti-inflammatory. Low-fat diet, only borderline. The second dot point there is showing that those following the Mediterranean diet closely improved their anti-inflammatory score of their diet. And thirdly, following the Mediterranean diet resulted in a reduction in pro-inflammatory markers like interleukin-6. These are intermediate biomarkers, and what we will do is follow up these patients in 12 months to see whether we have reversed the secondary heart attack, which is quite prevalent in those that have had a myocardial infarct. This study is a study we did a few years ago using a reconstructed Cretan Mediterranean diet, as I described before, against a low-fat diet in patients with biopsy-confirmed NAFLD, non-alcoholic fatty liver disease. So following 6 weeks, only 6 weeks on the study, Those on a Mediterranean diet, the light blue bar on the left, had a 39% reduction in intrahepatic lipid, whereas those on the high carbohydrate, low fat diet only a 77% reduction in intrahepatic lipid. And then insulin resistance, which is common in fatty liver, 35% fall in fasting insulin on the Mediterranean diet and no change on the high carbohydrate, low fat diet. So Mediterranean diet, good for reversing fatty liver and improving insulin resistance. This study is one of the first studies that we're aware of. We called it the SMILE study, where we demonstrated reversal of depression and anxiety by high adherence to a Mediterranean diet. Again, a parallel study, 12 weeks, Mediterranean diet versus standard care. And those that adhered more closely to a Mediterranean diet, quartile 4, had the highest improvement or greatest improvement in depressive symptoms, and a large number of them went into remission. So they didn't score on the MADRS scale as being depressed anymore after the Mediterranean diet. And the final study I'll share with you today is by Dr. Maria Papamichael, who completed her study in Athens, recruited 64 children with mild asthma, randomized them to a Mediterranean diet and 2 serves of oily fish per week, versus usual diet for the alternate arm, followed them for 6 months, and found that baseline that children in Athens were already consuming a poor diet. They were only scoring 5 out of a maximum 12 on the KidMed score, which is a score showing Mediterranean diet adherence in children. So this score improved dramatically on the Mediterranean diet, and I haven't shown it here, but up to about 8, not perfect, not to 12. At 6 months, those that followed the Mediterranean diet plus fish had a reduced lung inflammation as measured by fractional exhaled nitric oxide. So this showed that you can actually reduce inflammation in the lung by following a diet that is enhanced with oily fish. We've also shown that vitamin D status and folate status are very important in terms of responsiveness to treatment. Those that are deficient in these nutrients don't respond that well to treatment. We will know that from medical treatment as well. And finally, back to Australia, the Greek migrants, and they are in a time warp, still following a very cultural eating pattern to what they left behind 60 years ago from Greece. Antonia Thoudis did her doctorate on the Australian Meta study, and we collaborated with Demosthenis Panagiotakos from Athens, and we run the Australian arm with Antigoni Kouris. And what Antonia found was 75% of the elderly Greeks that she studied from Crete and Cyprus kept a home garden, even though they're in their 80s. They grew all of these vegetables, including olive trees in the backyard, and they had lower blood pressure. This was an association. It was a cross-sectional study, but they ate a lot of vegetables, shared their vegetables. What we have shown in other studies is that wild edible greens, or horta, have significantly high levels of beta-carotene and lutein compared to the common lettuce that you see in the supermarket. So growing your own vegetables, and here are my daughters in the backyard of my late parents' house, growing vegetables, cooking healthy dishes, and the benefits of growing your own veggie garden, physically active, as well as weight-bearing activity, because you're digging and bending. You're eating more plant foods, you've got more sunshine, therefore vitamin D. You're sharing foods with neighbours, which is that social connectedness, very important as Mediterranean way of life, socially active, and sustainable. You're eating sustainable, locally grown produce. So in conclusion, a beautiful photo of islands in Greece. Mediterranean cuisine is highly palatable, transferable to other populations, sustainable, and rich in anti-inflammatory cardioprotective nutrients, the perfect medicine for health and longevity. Thank you.
Thank you, Dr. Tsiopoulos, for your excellent talk. And since the other conference is running now, we have a little time for questions. And I would like a question on the Mediterranean diet, since we have all the experts here. Are the Mediterranean diet is considered the best diabetic diet according to American Diabetes Association guidelines? Do we have that in the other guidelines, like American Heart Association and other guidelines? Do they include the Mediterranean diet? Do we know?
I guess Professor Carles, probably you're best to answer that. I do know from my reading that certainly the American Heart Association has flagged the Mediterranean diet as being one of the healthier diets across Australia. most guidelines include the Mediterranean diet. Our Australian dietary guidelines, the broad guidelines for the whole population, have listed the Mediterranean diet as one of the healthiest dietary patterns.
Thank you very much for your talk and fascinating. Congratulations. I agree with what you said. I'm not exactly sure that they've rated it as like the number one, but I believe it's recommended as a pattern that heart and diabetes patients can follow. But in the US News and World Report guidelines, I believe in most of the last 5 years, such as for simplicity, diabetes, heart health, overall health, it came out number one in the consensus of experts, but it's not the same as ADA or AHA guideline.
Sure.
Any other questions from the participants? Yes, please.
What a terrific talk. I'm from California. I was born in Athens, so I live by the Mediterranean diet. But what ordinary physicians should do to monitor the inflammatory markers of the patients when you recommend the diet, and to follow them through in 6 months or the yearly checkup? I'm a psychiatrist, and I always ask all my patients, whether they are on meds or not, to get the profile of their labs at the beginning of treatment. And do you have a specific recommendation that you do in follow-up? What are your inflammatory markers or anything else that you guys follow for the patients that you put on the diet? Thank you.
Thank you for the question. I guess in brief, in Australia, in general practice, high sensitivity CRP would be the routine inflammatory marker. Most of the other markers I've mentioned in my presentation are done in research. So in terms of inflammatory markers, high sensitivity CRP is routinely measured, as well as the standard battery of tests for lipids and glycemic control, as Dr. Mezzitis has raised already.
Okay, thank you.
Thank you, Dr. Tsiopoulos. Any other questions from the audience? I have a question for Dr. Marquizos. Dr. Marquizos, we use medications for weight loss for adults. Are these medications also going to be used for children?
Yes. Thank you. Yes, metformin is used, glucophage is used for children, and Xenical, I believe. But they're working on medications for children. They're in trials. So basically, the main ones that we use is metformin, which is glucophage, and Xenical, to get rid of the fats. Those are the most common ones we use. The other ones are to be approved.
So the GLP-1 agonists now that are
is not yet it's
not yet approved, but
it's
there's
not yet,
some thinking by the FDA to approve these medications, right? Very good.
And if I may add, Catherine, Dr. Tsiopoulos was fantastic, and I think also the salt intake also should be limited as well, because that plays an important role in the inflammatory process as well. So I want to add that as well.
Thank you.
Thank you.
A good point.
Dr. Soldato, are you with us? No. Okay. Yeah. Yes. Dr. Kales wants to add something.
I just wanted to thank you, Catherine, for mentioning the Institute in Leros, founded by my colleague, Professor Sidosis. And I just wanted to let everyone know that we are, in fact, friends and colleagues. We're very good friends, and we wrote a textbook of lifestyle medicine together. I could not advertise more than one thing at the same time, so try to stick to advertising the conference. But I do encourage the book, and it's really was more of Lambros's baby than mine, but I was privileged to participate. And regarding the centers, I hope that, there are many centers throughout the Mediterranean. There's the center in Barcelona, Torribera Center, and other smaller centers in Italy. And we hope that going forward, we can form a network of all these centers, both not just in the Mediterranean, but also, for example, Yale has an olive center now. And hopefully at Harvard, we can have something as well. And I'm sure you and your colleagues down under have many initiatives, as you outlined as well. So thank you.
Thank you, Professor Carlos, and congratulations on the book. Practical applications of the pillars of lifestyle medicine for practitioners, and I highly recommend it.
Thank you. A question for Dr. Barbaricos. These CPR guidelines that you were alluding to, and you do so well in your hospital, are these going to be national guidelines for Canada? And how do they relate to the guidelines of the United States and Greece?
What we did was basically, I think you're referring to the training session that we did, that we published. It's basically, there needs to be more, to be honest, that we did this for our own institution. This was an example that I was giving to you in order that you look at your own centers, adapt it to what you're doing and who you have to help you out when you have patients in cardiac arrest in your hospitals or coming in through the pre-hospital. Is this accepted? For now, we've shown results that are comparable to the basic life support, but on mankins, this has to be translated to humans, and it has to, like I always said at the end of my presentation, the best results are the results that don't show just the return of pulse, but good outcome for patients, that they're discharged from hospital and that have good neurological function. This is something that we have not proven at all. But this is our way of trying to be respectful of the fact that we have to train our staff. They have lots of roles. Everyone in a hospital has to be able to recognize a cardiac arrest, maybe call code blue, be able to start chest compressions while they're waiting for the defibrillator. We decided in our hospital that our personnel was only going to be doing chest compressions, and we have other staff taking care of the other part of the but that depends on, I don't know if I'm answering your question. These are not national. We follow the guidelines of ILCOR and DRC, the European, followed international guidelines of ILCOR as well. What we did basically was to be able to train our personnel for what we thought was important for them. And for now, it gives results on mankins, but we haven't proven anything yet. We have to get the studies out in real time and do a randomized controlled trial.
And how was this affected by the...
So we did, how was it affected by the COVID pandemic? CPR in general, you mean?
In general,
well, when we look at the guidelines initially, it was very troublesome because CPR, like we said, emphasizes chest compressions and defibrillations, and that's what matters. However, because we knew that there was going to be a potential risk to resuscitation teams if we were not quickly taking care of the airway, then there was emphasis that was placed on quickly trying to take care of the airway and trying to intubate them as quickly as possible. So that did affect us. What we decided to do, the studies, sort of preliminary studies came out where they said defibrillating and chest compressions do not aerosolize. So when you have someone that in the general public, something happens to them and you're afraid you might get sick, there's no risk to defibrillate and there's no risk to chest compress. Nothing, put a mask on their face and do what you have to do. However, when it comes to the airway, it's better to secure it. So what we do now in our hospitals, when we've come to a point where we have to transfer the patient, he's put into an N95 room. We put protective equipment on. We make sure that we have the most experienced operator intubating that patient. And that has changed a bit our sequence of events. So they're put into, negative pressure rooms. We're wearing protective equipment. We're getting that experienced operator in there. But defibrillating and chest compressions in the pandemic should be done even if you're called upon during your vacation, and I hope not. So you shouldn't be worried about potentially, having anything transmitted to yourselves. That has changed since the pandemic.
Excellent. And any more questions? Then this will conclude our session in metabolism. Thank you for the excellent talks, our speakers, and for waiting online. We were a little off time, but we did well in this session. Congratulations to all. Thank you to the audience.
afternoon, everyone, and welcome to our aging session. We have some great speakers today from prestigious institutions from the US and the UK. They will be giving talks on a wide range of aging topics, from successful aging to frailty to dementia and age-related diseases. So I will be kicking off the session with discussing with you some findings on an interesting phenomenon we have been studying at Harvard Medical School. Advance the slide. So as we age, there's a certain amount of atrophy that is happening in our brains. It's not enough to be pathological, but it does affect our abilities, our cognitive abilities. And what we have been finding in all of our studies that we are studying older adults is that almost all elderly people present atrophy in the brain, except for a remarkable group of older adults who we call superagers. Superagers, despite their age, somehow they continue to have youthful brains and they manage to defy the age-related decline in brain power. You might be wondering, what is a superager and how can someone be one? I'm going to briefly review our studies and try to uncover their secrets. Talk about superagers, let me give you a brief background on the effects of typical aging on memory and the brain. We all know this. It's common for memory to decline as people age. And you can see that over decades, there's a decline in memory performance. So looking at this average data, one might come up with the conclusion that memory decline is an inevitable consequence of aging. I'm taking some advice here from Hippocrates, who said that it is really important to look at individual differences. So let's take another look at the same graph with a closer examination of individual differences. If I can direct your attention to the individual data points that I have circled here, you will notice that some older adults have memory capacity that really rivaling those of young adults. So now I'm going to change what I said before and say that memory decline may be common, but not inevitable. So what is it that makes superagers special? The first thing we wanted to do is to put superagers into the scanner. We're using in all of our studies neuroimaging techniques, conventional MRI, structural MRI to look at the neuroanatomy of their brains, and functional MRI. Functional MRI is a widely available technique that was discovered at Mass General Hospital in our department in 1991 with a seminal work that was published in Science. So this is a technique that measures the brain activity in real time in a non-invasive way. Before I show you how the superager brain looks like when compared to a young adult, let me show you how the healthy older adult looks like when compared to a young adult with a T1 MRI scan. A word of warning, this might be a little depressing for some of us who are aging, unless of course you're a superager. So on the left, there's the brain of one young adult, 25-year-old, and on the right, there's the brain of an older adult, 65 years old. As you can see on the right image, there is age-related atrophy observed in many brain regions, as shown here with the white arrows. You can see that in hippocampus, insula, prefrontal cortex, and cingulate cortex. And here we quantified this brain atrophy where we had a group of older adults and we compared them with a group of young adults. With all these yellow spots, the yellow colors, we highlight all those brain regions that have atrophied in older adults. As you can see, it is a pretty widespread effect. Now look at the brains of superagers compared to young adults. You see that there are not yellow spots at all. Remarkably, the brains are truly youthful. And when I say youthful, I mean statistically indistinguishable from young adults 25-year-old. And you can appreciate that at the individual level, where you can see that a superager brain has really maintained youthful characteristics. I'd like to note that superagers are not very common. It is a rare phenomenon. So let me briefly review our studies, and let's see why some continue to remain sharp even as decades roll by. So we discovered superagers in 2016, and in that first study, we wanted to identify a brain signature for superagers, and we compared the group of superagers with their peers, a group of older adults, typical older adults of the same age. But we asked the question, do superagers resist brain-related atrophy? And what we found was that early on, the scan showed that their brains avoid brain shrinkage, their brains look decades younger, and when they are compared with typical older adults, they have thicker cortex and larger hippocampal volume. And not only this preserved neuroanatomy in the cortex and in the hippocampus predicted their superior memory capacities. But the structure of the brain is not the whole story. So we know that brain regions are not isolated islands. So we used in our second study functional connectivity MRI, and we examined those brain regions that are important in memory, and we examined how they are communicating with each other. What we found was that superagers have more connected brains. Their functional connectivity is stronger compared to typical older adults. They have more efficient neural networks, and their brain connections are as strong as in the young brains. We wanted to better understand what was going on in their brains while they were actually doing a task. And so in our third study, that brought us to a follow-up study where we used functional MRI and we gave them a memory task and asked the question, what are the brain regions that are activated when they are learning and later on recall the information? We focused on the visual cortex. Why the visual cortex? Because the visual cortex, we know from the memory literature, is involved in a very specific, important neural mechanism of memory. We found that superagers, not surprisingly, have youthful activity patterns in their visual cortex. I mean, if you can look at this, if you could look at these triangles, that reflect the brain activity, they are almost identical. They look a lot like each other. We believe that this youthful activity in the visual cortex allows them to process information in a selective way, and later on, they create distinct memories that are easier for them to retrieve them. In our most recent study, we wanted to go a little bit further, and we wanted to test whether superagers are also resilient in stressors outside of the laboratory. And so we focused on a very common complication. We focused on surgery, which is a real-world stressor, and we focused on one of the most common complications after surgery in older adults. So what we found was that superagers are resilient to developing delirium after surgery. None of the superaging cohort had delirium after surgery. So that was a suggestion that superagers may have built-in protection against delirium after surgery. So to conclude our discussion, if I had to answer the question, what does it take to be a superager? In one sentence, I could say a youthful brain in someone who is 65-year-old or older. Before I finish, let's hear from one Greek superager, Sophocles, the famous Greek dramatist. He notes the existence of successful agers with the line «Και γάρι γέρορ εγώ, το τις δε χειρός, ου γεγύρακεν στένος». What if I have aged? My strength has not aged. And he himself wrote his strategy, Oedipus at Colonos, at age 92. So it is pretty extraordinary for people in their 70s, 80s, 90s to keep the sharp memory as someone decades younger. And this would be interesting to study on its own. But there are also other things we can learn from studying superagers that are relevant to Alzheimer's disease. One way we can study Alzheimer's disease is to look at what has gone wrong. Another way is to examine, to look at those individuals that are doing exceptionally well. By studying those individuals, those exceptional individuals, they can tell us who is going to be more vulnerable and who is going to be more resilient to Alzheimer's disease. And in fact, one of the plans of the one of the goals of the national plan for Alzheimer's disease that was discussed this March in the Alzheimer's Disease Summit is that there is a need to study the healthy aging to better understand the factors that make someone resilient to Alzheimer's disease to be able to effectively prevent Alzheimer's disease by 2025. So we believe that our superaging work can offer clues for possible interventions. We know from them that there are particular brain regions that are important for memory. So this information is essential for designing a clinical trial that targets neuroplasticity and improves memory. So we're using that information in a clinical trial that is going on right now at Mass General, where we're using innovative techniques that combine brain imaging and non-invasive brain stimulation to target Alzheimer's disease. The hope is that by infusing neuroplasticity in these brain regions, we will improve the function of these brain regions, and we expect to see improvement as a result in memory symptoms. So with that, I'd like to thank all of my collaborators who are my co-authors, my colleagues at Mass General, where all of our studies are being conducted, our participants and patients in our studies, and of course, you for your attention. Thank you. Now, thank you very much. Do you have any questions? Yes, please.
Have you correlated overall resilience to stress with superages? Because I think you should be studying PTSD survivors that are unusual, and I consider myself one of them. I'm a World War II baby, and I'm now going to celebrate 84 years. And my best time is now. I no longer have to worry about taking care of anybody except me after a family of 3 sons and a husband. So I'm done. 60 years married, 3 sons, all fine. My husband had to go. I had to take care of him. So I'm here. I am surprised. I'm really surprised. Every morning I say, my God, I'm still okay. Unbelievable. But I credit my resilience to the early life trauma and my capacity to survive. And I think that's an area that has not been studied, and it should be studied, because the effects of early childhood, and we're not talking about I'm talking big, I'm talking war trauma. I'm not talking the detailed family traumas that we're now studying, one person, one family at a time, which we have to do. I'm not minimizing that. But we are living in a time where it matters, where this nuclear stuff is unleashed, and we have massive casualties that are impacting everybody's life. So we really have to think big about this. So really, it's extremely important you pick what does it take, because you don't see the effects until after 65. You're not going to see it. And it's the pattern of resilience, and that needs to be the underlying biology, and especially the brain networks need to be studied in detail. You're doing God's work as far as I'm concerned. Congratulations. Extremely inspiring. Thank you.
Thank you very much. You're right. This is a very understudied area. As you said, we're currently having a large-scale epidemiological study on superagers that are going to look at lifestyle factors, history. Right now, we don't know. They come from all walks of life. What I can tell you is that there's no difference in education and in gender. So we have to look better, closer at their background. But thank you. Thank you. Thank you for your question and comment. Yes, please.
Congratulations for the outstanding talk. Any comments on the effect of intense aerobic exercise on brain aging? I'm very much interested in that. Personally and anecdotally, I've seen this type of reduced brain atrophy to non-existent brain atrophy in patients who like intensely exercise aerobically. And again, based on my own personal experience, I think there is probably a role for healthy lifestyle and especially aerobic activity in reducing brain atrophy. That's one question. The other question is, are we truly sure that brain atrophy is a very good correlate with brain function? Again, anecdotally, I've seen multiple times patients with Alzheimer's-like type of dementia with very, very limited brain atrophy and vice versa. So those two questions.
Thank you for your questions. I'd like to answer both of your questions. It's unfortunate that we only had 10 minutes to present our findings. In all of our studies, we do show what you just said, that there is a correlation between brain structure and brain function, a correlation between brain function and memory performance, so behavior. So those older adults that had larger, the thicker the cortex, the better the performance. The stronger the connectivity between key regions in memory, such as posterior cingulate cortex and hippocampus, the better the memory. The stronger the connectivity, the stronger, the larger the hippocampal volume, the more youthful activity patterns in the cortex. So they are all highly correlated, as you said. To answer your first question about aerobic exercise, we don't have findings about that, but there is a study that has shown that aerobic studies are increasing. There was a clinical trial, and they showed that they increased the thickness of the mid-cingulate cortex. The mid-cingulate cortex is a key superaging region that has been replicated in all of the studies in healthy aging, in successful healthy aging. So I expect that, first of all, more research needs to be happening in this area, but I expect to see positive outcomes by relating these two. Thank you. Yes. One more question, and we have to move on to the next session to be cognizant of the time.
Your excellent work. I saw in your last slide about the transcranial magnetic stimulation, and you mentioned earlier that there are specific key regions, for example, posterior cingulate cortex, which is part of the default mode network. So is it feasible to make some superagers by stimulating default mode network or other key regions?
I'm glad you asked this question. It's one of the clinical trials we're currently running, just to targeting this exactly region along the mid-cingulate cortex. As you know, transcranial magnetic stimulation stimulates only regions of the cortex and not regions that are deeper. But we are using this trick. We're using the fact that these deeper regions are functionally connected with the other regions that are more superficial in the cortex. So by stimulating those, by that way, we are increasing the connection, and that's the function of the region that is deeper. But that's one of the studies we are running in aging. And we're using that in Alzheimer's disease as well. Now I would like to move on to the next speaker. Could you please help me change the slide? There has been a change in the order. I'd like to invite Dr. Athina Angelopoulou, my esteemed colleague at UK. Dr. Athina Gelopoulou is a consultant in geriatric medicine. She's working at the Maxfield District Hospital in Manchester, and she will be talking to us today about frailty. Athina, the floor is yours.
Thank you. Good morning. My big pleasure to be here. And I would like to thank Mr. Chrysoulakis and all the people that worked for this amazing event. As I told you, I'm a consultant in care of the elderly, so my people are low, frail in origin. And let me introduce you to some of them. Mary is an 83-year-old lady. Jean is an 82-year-old lady. David, 93 years old, and Leslie, 90 years old, are my favorite patients, as you can see. Can you imagine how many days of the rest of their life do those people want to spend in hospital? 0, exactly. None. So what can we do as people that look after them for their health issues? We have to break the cycle and identify frailty. So we have to help them to avoid hospital admission in now nice Macclesfield District General Hospital, by helping them to have a healthy life in the community with the minimum support of their GP. But what is frailty and how can we break this frailty cycle? Frailty is a distinctive health state related to the aging process in which multiple body systems gradually lose their inbuilt reserves. So, it's a geriatric syndrome that predicts poor clinical outcome and is a process relating to ages with loss of physiologic reserve and increased vulnerability. It's very important to identify frailty as our population in Europe and United States and Australia is getting older. Around 10% of people aged over 65 years have frailty. 25 to 50% of those aged more than 85 years. And over the next 20 years, the number of people aged 85 and above is set to increase by 66% compared with the 10% growth in the overall population. Frailty has a pathophysiology. It's the pathophysiology of aging with a loss of functional homeostatic reserve, age-related changes to multiple physiological systems like neuromuscular, neuroendocrine, and immunological systems. And these changes interact cumulatively and detrimentally, resulting in a decline in physiological function and reserve. The frailty phenotype includes sarcopenia, anorexia, osteoporosis, fatigue, risk of falls, and poor physical health. I wonder, how can I go back to my previous slide? No, this is the next. Okay. We can have a look to this cycle. We can see the anorexia of aging, leading to chronic internutrition, to sarcopenia, to reduced strength and power, resting metabolic rate, reducing of walking speed, and as a result of that, falls, disability, and dependency. And overall, this reduced activity causes an unwell status of our old frail people. In order to classify the frailty, the geriatrician, we created the Rockwood score tool. It's a scale is a global clinical measure of fitness and frailty in elderly people. This score is based on 2 weeks before the patient has attended the hospital. That is the baseline, the normal baseline of the patient, and this should be discussed with the patient or family when talking a collaborative history at the time of hospital admission. This is the clinical frailty score. It's a big slide, so it's not very easy to read, but when we are talking for inpatient frailty patients, mainly are from 5 to 9. So patients with Rockwood score between 4 and 7 should be highlighted, refer to the acute frailty team. Frailty should be identified with a view to improving outcomes and avoiding unnecessary harm. Is an elective state of risk of death, and risk of death is compared with other people of the same chronological age. David told me, please respect me. Doctor, I'm not a robot and you are not my engineer. I have a social life and my own house where I want to spend the last days of my life. Please respect me. So we help Dave with the frailty assessment with our frailty team. It's very important team working. And we have a strong frailty team in our hospital. So this frailty team has a doctor, that's me, a physiotherapist, an occupational health therapist, who are helping with the functional and environmental assessment of the patient, mental health service, community mental health service is an important part of our team as well. And they work together with our hospital mental health team when needed. We have social services and we share information for social circumstances and social input when needed. We have community matron who looks after the people when they are in their homes after their discharge from hospital. GP service, families, and volunteers who are very important in frailty service as well. So we need only, as doctors, 30 single seconds guide to frailty syndromes. This is the frailty approach bundle. So I have a patient in front door, acute and emergency, and I need to assess this old frail patient for falls. The type of falls, syncopal, can be cardiac polypharmacy postural hypotension, or can be non-syncopal falls due to reduced strength, due to balance issues, due to vision issues, or to hearing issues. So we have to examine the causes of falls as a holistic. We have to assess immobility. A lot of people are coming in front door with off legs. Do they have cord compression after a fall? We met some people that after a fall, they had a spinal cord injury, and after that, they became very weak in their feet. And when they have end-stage dementia due to increased brain atrophy, the center of mobility is also affected, and they have very increased weakness. And any brain pathology can cause immobility. Delirium. Delirium is an acute confusion state. It's not dementia, it's something different, but sometimes we can have delirium on top of dementia. Can be hypoactive, so the patient presenting with a very flat situation, hyperactive, with are coming agitating, and or sometimes can be mixed from hypoactive to hyperactive delirium. And the cause of delirium can be a simple infection, like a urine tract infection, a hyponatremia, brain pathology, hormonal problems, vitamin deficiency due to malnutrition. They don't take adequate amount of vitamin D or vitamin B. After the operation, And due to environmental change, it's not a nice thing old people to change their home environment. Dementia is a common symptom with frailty. Polypharmacy, a big problem, so we have to reassess the medication. You are 90, you take statins. Why? Do you need statins in the age of 90? No, cross the statins. You take some medication for overactive bladder. A lot of them can cause confusion. We have to stop them. Or so we have to reassess all of the medication. My feeling is that as less they can take, as better it is. And painkillers can cause a lot of harm. Medications like gabapentin, pregabalin for chronic pain can also increase delirium and confusion. And incontinence. Incontinence plays role in immobility and frailty. And it's a very big problem, both urine and fecal incontinence. So we have some frailty inclusion criteria that we keep frail patients in hospital. They cannot safely be discharged. They have acute deterioration from reasonable independent functioning prior to admission. There are more than 90 years old or more than 75 years old presenting with acute confusion, falls, new urinary or fecal incontinence, significantly reduced mobility, and multiple pathology. And frailty exclusion criteria are the severe medical condition like collapse, myocardial infarct, acute abdominal, suspected stroke, TIA or CVA, major trauma with head injury, and of course we have to admit all people with Glasgow Coma Scale less than 9. This is a frail patient with Rockwood score 9, and this is with Rockwood's 8, again bed-bounded, again in hospital, but has the minimum effort and capacity to have her medications given by the nurse. And this is the group of my favorite patient dancing with Rockwood 1. So our target is to invert Rockwood scale, people that are 4 to 1, and ideally to avoid hospital admission. We have a nice discharge planning. As soon as the individual's problems have been addressed, they can return safely to their own home. Formal and informal support in their own homes, and early attention to comprehensive discharge plan. So community plays a big, and I think the highest role in the well-being of the old patient. So GP, community frailty team, occupational health team, and physiotherapists can play a very big role. And this is age well and stay well, live well with one or more lung conditions, support to complex and for accessibility, high quality person-centered acute care, good discharge plan from hospital, effective rehabilitation, and person-centered medicine. This is very important. We have to look holistically at our patients and to see all of their problems and to speak to them like individuals and not like machines. Thank you so much.
Thank you, Dr. Gelopoulou, for an illuminating presentation. Thank you very much. Are there any questions for Dr. Gelopoulou? All right. Okay, so I'd like to introduce you to our next speaker. Our next speaker is Dr. Kirana Tapkini, a mentor of mine that is dear to my heart and an esteemed colleague at Johns Hopkins University. Dr. Kirana Tapkini is an associate professor of neurology at Johns Hopkins, and she will be talking to us today about a devastating neurodegenerative disorder, primary progressive aphasia. Dr. Kirana Tapkini, the floor is yours.
Thank you. Can we start? θα μιλάτε με το μικρόφωνο.
How many of you have ever experienced the frustration of not being able to find the word? Okay, most of you. And if I may try it now, could you please tell me what this is? How do we call that? It is a trellis, yes. Thank you. I hope it was difficult enough and I just did it on purpose. When I first went to Johns Hopkins University 12 years ago, I started working with Dr. R.G. Ellis at her clinic, and there will be patients who would come to us and they will complain that they cannot find words, but they had no stroke, they had no memory loss, and the disease or whatever they experienced, the symptom was getting worse and worse with time. And it was not on these difficult items as trellis that I showed you here, but on things like tiger. On one day, a lady came and I showed her the tiger, and she said, I asked her what it is. And she goes, oh, that's easy. I know it. I can't find the word now, but I have two at my backyard. Then I say, this is a tiger and it is a wild animal. So a little later, I showed her a lion. And then I asked her again, what is that? And then she said, oh, I know that. I see them all over. And then I tried to give her a semantic cue. I say, it is a wild animal. It lives in the jungle. And then she asked me, what is jungle? So then I tried to give her a phonemic cue. It starts with a lie. It is a lie. And the patient who is smart enough, who has no memory loss, and still can deduce from what she saw before what to say, she says enthusiastically, liger. So this is the disease we try to study. It is called a prime progressive aphasia. It is what I described as just one type of this disease. It has, there are three main types. And one of the types is logopenic. Oops. Logopenic variant prime progressive aphasia with most posterior atrophy, non-fluent variant prime progressive aphasia with more anterior atrophy, and semantic variant prime progressive aphasia with more temporal, anterior temporal, and mostly left, but also right atrophy with different pathologies, as you see here, AD, FTD tau, or FTD TDP, and a little different symptoms. They all experience anomia though. So we thought with our team there, we thought, what can we do? These patients have no disease-modifying medication. They get nothing of support except from the neurologist checking every 6 months. And the only treatment, to the extent the insurance allows, is speech-language therapy, which works and it is good, but that's all. So we thought, why not trying a little bit of electrical stimulation, transcranial direct current stimulation. And there were a few good reasons for that. That first, it had been shown recently in post-stroke aphasia that it does change neuronal activity. It was very inexpensive. It had a very good, reliable sham condition, so we could be sure that we could do a good have a good control condition, and has very minimal adverse effects, so we could also individualize the therapy. And this is the scheme we adopted. The patient had, we targeted the inferior frontal gyrus as a common area for naming and lexical retrieval. The patient had this montage with the anode at the left inferior frontal gyrus and the cathode at the right cheek, so we avoid too much loop and reduce the spreading of the current. And this is the current simulation of where the current did go. So as you can see, it is a lot more basically in the area that we targeted. So the intervention was a very simple intervention that we had found before, we and others, that it helps and it maximizes the treatment. So they see a picture, they are asked to name the picture and then to write. So these are the following questions I would like to address and show you a few results from our studies. The main question was, is CDCS more beneficial than just language therapy? And then, of course, who will benefit most? What are the clinical characteristics, the cognitive characteristics, the neural characteristics of the patients who would be targeted so they can have bigger benefits? And how does it work in the brain? What changes in the brain? And finally, what are the lifestyle parameters affect CDCS efficacy? So for the first question, is CDCS more beneficial than language? So in red, you see the sham. Sham means here, no real current, but language therapy, which works. This is the gain that they had in writing, and red is CDCS. So we see about 15% in both items that were trained during therapy, and about 15% in generalization in items that were not trained during therapy. The next question was, who will benefit most? Who are the clinical characteristics that would be more beneficial? And then, of course, we had to look first for the different types of patients. That doesn't work. So it seems for the trained item, non-fluent variant was a benefit a lot, and semantic variant, not that much logopenic. For generalization to untrained words, we saw improvement in both logopenics and non-fluents, not in semantics as expected, actually. Then the next question was, what are the cognitive characteristics of the people who will benefit? And then we looked at a different range of factors, and the most important were the pre-therapy scores. Where do they start from? And then, of course, their learning ability and the working memory. For generalization, we also found, interestingly, the verbal short-term memory to be one of the factors that predict improvement. And these are the areas that answer to the question, what are the neural characteristics of people who would benefit more? And here you see the posterior cingulate, here the middle, normal, known kind of areas, the left middle dorsal prefrontal cortex, left angular gyrus, and supramarginal gyrus. And we also found the dorsal, different effects of the dorsal and ventral language strip in using white matter tractography. And then we went to the question, how does it work in the brain? What changes in functional networks in the brain? And just very briefly, wanted to show that we looked at resting state fMRI, which is signals from the brain recorded at rest when people do nothing. So for every pair of nodes that you see there, we measure the disease of synchronization, like time course, signal time course correlation. How do they synchronize? And here's a comparison with healthy controls. So this is correlations between the different colors or different brain networks. This is the left infrafrontal gyrus that we targeted, and all the other, and the connections in healthy controls of this area with the other networks, the other areas. And this is what happens in prime progressive aphasia in these patients. So we have more connections in general, and this is what TDCS does. It reduces the connection, it decouples, and here, but sham does not. And here you see how this hyperconnectivity, the abnormal hyperconnectivity, that is actually correlated with a significant CDR, which is the global cognitive measure, how that is dropped and normalized to almost healthy controls numbers, and it's not happening with sham. Finally, we wanted to look, amongst others, but other lifestyle factors. So what lifestyle parameters affect TDCS efficacy? Now be careful here, red is not TDCS and is not sham, and red is not TDCS. Red is bad sleepers, according to a specific questionnaire, and blue is good sleepers. We have also actigraphy, but that's just the questionnaire. So you see that those who sleep better improve better in both TDCS and regular language therapy. And in TDCS in particular, we see an even better effect that lasts even longer. So all in can we say that we find any cure? This is any cure, and of course not. But we can definitely say we have a method that has behavioral and neural effects that may not treat, it may not cure, but it can treat the symptoms, and that we hope can prolong the disease and make the life of the people a little better and a little easier. So I hope I have convinced you that even for people who are at a loss for words, they are not at a loss for hope, and more clinical trials we have that are underway. These are my collaborators. I would like to thank all the patients, all my team over the years, all the physicians who are referring to us from all over the country, and of course the generous funding from NIH through all these years. Thank you very much.
Thank you very much for a fascinating presentation. I have many questions, but I will save them at the end. Is there any other question? Is there any question from the audience? It's great to see this kind of result showing really an effect of TDCS on brain connectivity, functional connectivity, and on behavior. That's really promising. Thank you. Now, I would like to invite our next speaker, Dr. Vasilis Lioutas. Dr. Lioutas is a distinguished colleague who works across the city on the other side of Boston at Beth Israel Hospital. He's an assistant professor of neurology at Harvard Medical School, and he will be talking today to us about invisible lesions that cause visible damage. Dr. Lioutas.
Thank you, Alexandra. Thank you very much to the organizers for the invitation. This is a very exciting gathering. I'm hoping to pick up the thread from where Alexandra started with super agers, and maybe part of the answer lies in what I'm going to speak about. So the topic is cerebral microinfarcts and their impact and challenges on actually seeing them and characterizing them. So I'll start by just saying that we know very well there's a well-established association between vascular risk factors and dementia risk. This is data from the ERIC study, atherosclerosis risk in the communities. It shows that both diabetes, hypertension, and smoking are independently associated with dementia. At the same time, from the Framingham study, we know that there is a contemporaneous trend of decreased prevalence of cardiovascular risk factors, as you can see across time. The Framingham study is starting between 1948 and now, and the first epoch starts in 1948. The last epoch of this study is about up to 2015. You can see that all the cardiovascular risk factors are significantly less as we move across, and this corresponds to a significantly lower incidence of new dementia. So there is good evidence that cardiovascular disease associates with dementia, all-cause dementia, and Alzheimer's dementia, as you can see here. The question is just how. Up till now, we have some knowledge. This is what we kind of well know so far. These are all MRI markers of vascular injury. Perhaps the best known is the second, which is known with many names, one of which is leukaryosis. The current naming that prevails is white matter hyperintensity, but we have lacunes, we have perivascular spaces, and then we have the hemorrhagic markers of cerebral microbleeds. But all of these have not satisfactorily explained the variability in cognitive outcomes and dementia. And enter microinfarcts. So as their name implies, they're small infarctions. The size ranges from anywhere from 200 micrometers to about 1 to 4 millimeters. And obviously they were first seen in neuropathology studies. And very quickly we realized they're very ubiquitous. And the question, just how much, it depends who you sample. So in patients with a population with vascular dementia, the prevalence is as high as 60%. In the population, general population, about 16%. This is all pathology data. I can tell you from unpublished data in the Framingham study, we sampled 200 patients with appropriate sampling, AG and vascular risk factor, and we found about 11-12% prevalence in the general population of these microinfarcts. And as you can see, the distribution is about 40% cortical, 40% subcortical, and about a fifth is mixed location. Very interestingly, they're very prevalent, and many times they're present in the absence of visible microscopic vascular damage. About half the patients have microinfarcts and no macroinfarcts, macroscopic infarcts. So they're there, they're present, and the number. So that's a more difficult question to answer because, as you know, in regular neuropathology, we sample a very small volume of the brain, about 0.1%. But basically, with mathematical modeling, we have realized that if we see 1 or 2 in a pathology study, that means there's probably several thousand in the entire brain. And as you can see, there's a good correlation between the number of visible microinfarcts and the actual number in the brain that goes up to 7, 8, 9,000. So they're ubiquitous and they're numerous. And the question is, okay, they're very small. Do they really cause any damage? This is animal data. And basically what we've found, to not belabor the point too much, is that actually this is not 2, it should be 12. I apologize for that. But basically, although they're small, they cause functional disruption that affects a volume that's 12-fold higher than the actual volume of the lesion. And then we also see that not only they cause damage at the site of the microinfarct, but they also cause remote damage. As you can see, there's the dendritic spine density disruption that's remote of the lesion. And basically, the idea is that we have both local and downstream effect. And although the individual lesion is very small, minuscule in size, the cumulative effect can be fairly major and cause significant disruption. And just how much we can see here. So cortical microinfarcts are strongly associated with dementia, all-cause dementia. They also associate with individual cognitive domain decline. Subcortical microinfarcts, they're more associated with mobility, so gait difficulties. And as you can see, the presence of multiple microinfarcts creates a 4-fold increase in the risk of dementia. And interestingly, on the right-hand side, you can see how taking them into account really does increase the probability of dementia. Interestingly, I won't go into too much detail about this because of time, but they seem to really lower the threshold of amyloid burden at which we have clinically manifest dementia. In other words, a Bragg stage of 3 or 4 sometimes can result in clinical manifestations just because there's a lot of microinfarctions. So they seem to be one of the missing links in our understanding of clinical dementia. Now, the problem obviously is that everything I've shown so far is coming from pathology, and these are post-mortem studies with ante-mortem cognitive data, mostly from the Rush study of aging and the another similar study. So translating this into in vivo has been a challenge. And it all started with going from ex vivo to imaging. On the left-hand side, you can see ex vivo MRI 7 Tesla. They take a slab of brain tissue, they mark microinfarctions, and then they leave the tissue in the MRI for about 12 hours. And they've been able to show that there is pretty good likelihood that you can identify those microinfarcts in the MRI, 7 Tesla MRI. The next step was to go from ex vivo to in vivo. On the right-hand side, you can see such a study. This is someone who were able to identify a microinfarct, which you can see, they're very, very tiny, in the cortex during life. Again, this was 7 Tesla. Obviously, 7 Tesla is not very ubiquitous and it's not very feasible. So we wonder if we can actually move to 3 Tesla MRI in the research setting, and that was actually possible, and you can see such an example. Obviously, the resolution is not as good, but we trade, resolution for feasibility. 3 Tesla is much more feasible. And there are some studies that show you can even see them in good quality clinical 3 Tesla MRIs, especially from Singapore. Now, the current status of microinfarct imaging is as such. I'm showing you what we're doing currently in the Framingham study. It's a very, very laborious process. You have to have the T1 image and the FLAIR T2 co-register in the same 3D space, so that takes some processing. And then you have to basically go over every single slice in the sagittal plane and mark whatever you think might be a microinfarct. As you can see down here, I have marked this one. But sometimes it can be misleading. It may be just a small sulcus or something else. So the second step is to go to the co-registered axial image and make sure this is indeed what looks like a microinfarct. And then you want to make sure it's hyperintense or isointense in the FLAIR image. So the whole thing takes at least 25, sometimes 30 minutes per scan. It can really drive you mad. And of course, extensive training is necessary. And I would say that the inter-rater reliability is modest at best, even in well-trained raters. So we're working on a solution. The solution is probably AI. We know that already there are good software for other markers of cerebral small vessel disease. So on the top panel, a publication from a group, I think in the Netherlands, who have created an algorithm to automated detection of perivascular spaces with very good resolution. It's fairly straightforward once you train the algorithm. On the bottom, we have the same thing for microbleeds, and you can appreciate how you go from too many lesions to the right lesion. I'm not at liberty to show it yet, but there is some preliminary data on microinfarcts. The idea is because it's such a difficult marker to identify, we create software that's oversensitive. It overcalls the lesions, and the human rater then goes and cleans up what the machine has overcalled. It takes about 2 minutes as opposed to 25 minutes. So there's many challenges. In the interest of time, I won't go over everything. We know a few things. There's many things we don't know, the natural history, risk factors, how early do they appear in life, any role in amyloid deposition, tau deposition. Can we actually reliably do this in longitudinal real-life studies? And we're planning some studies in the Framingham and Eric cohorts. We're going to use longitudinal well-phenotyped cohorts, which will allow us to disentangle associations between vascular risk factors, lifestyle risk factors, and all that stuff. Also leveraging novel techniques such as amyloid and tau PET, and then structural MRI. And hopefully we'll have interesting and exciting data in the next few years. Maybe explain some of what Alexandra described before in the super agers. They probably have a lot fewer microinfarcts. And with that, I'll thank you for your attention. And I'll...
Thank you very much, Dr. Lutas. That was a great presentation. Thank you. We're moving on to the next speaker, Dr. Katramados Angelos. Dr. Katramados is a professor of medicine at Wayne University. He will be talking today with us about stroke, and he will be giving updates on where we are with stroke treatment. Dr. Katramados, thank you.
Thank you very much, Dr. Toutoglou, and to Dr. Mezitis and the organizing committee. It's an amazing conference, and most of all, it's great to be in the presence of many new and old friends. So to give continuity from the previous talk, we're going to change the scale of how we do things. And we start from microscopic lesions, and then we move to macroscopic lesions, and then to the actual person that has the stroke, their family, the hospital that takes care of them, the community, the country, and eventually we see it as a public health problem. So we will start with two small examples of patients that we have had in our stroke centers over the last years. The first one came probably about 5 or 6 years ago. He came with sudden onset right-sided weakness, had a moderate to severe stroke, according to our stroke scale that we classify, with symptoms that suggested that the left side of the brain was affected. And on the initial CAT scan, it was easy to see that the left MCA had a thrombus, had a clot. And this was the reason for his stroke. And we did see this in the angiography, where we actually see that the vessel is missing because of the clot. And at the time, the next thing that we did was, with a catheter, the interventionalist went and took the clot out, and the patient recovered. And this is the actual clot as it was removed from the vessel itself. So remarkable as it is, things have progressed since then. And another patient came earlier this year with a major stroke. And this time, as soon as the CAT scan happened, the software was able to tell us that there was an occlusion, and it was able to tell us the approximate part of the brain that was expected to be affected. The patient received the clot-busting medication because they came early enough. They got significantly better, and then they got worse. They got worse, but by that time, it was already too late to do anything else. So again, we did the second study called the perfusion study. And on the left side, you see the part of the brain that already has a stroke. And on the right side, you see the part of the brain that is likely to develop a stroke if the clot is not removed. And that is substantial. And not only that, but we're able to see the heterogeneity of the stroke and which part of the brain is affected more and which part of the brain is affected less. So it is remarkable that we have the ability to do this in real time, within seconds. And the patient, again, was considered to be a candidate for a procedure and had the clot removed and the vessel recanalized. And in the end, this is a study, an MRI study that shows the final outcome of the stroke, which is a very small percentage of what it would have been. So this is a big change from the beginning of time to the 1990s. Even the pioneers of neurology would say that treating a stroke is futile. It's like treating a hole in the brain because there were no drugs that could do this. But then more than 40 years ago, in the early 80s, it was recognized that a stroke does not happen immediately, but over the course of several hours. And it is during those first few hours that the stroke becomes what we call a neurological catastrophe. And every second, every minute, every hour, a certain proportion of the nerve cells, the connections, and the brain is getting injured. The first thing that was developed was a way to quantify a stroke, and that was the NIH stroke scale, and this is universal by now. The second thing was the development of stroke unit care. So it was recognized in the 90s that treating people in stroke units has remarkably better outcomes compared to the general units in terms of mortality and in terms of recovery. The next thing was the development of clot-busting medications, what we call thrombolysis, with alteplase, now with tenecteplase. And initially, this was a landmark study from the mid-90s. It was only possible to give thrombolysis within 3 hours from stroke onset. So most people did not have the opportunity to benefit from this treatment. But then, in 2008, 13 years later, with the ECAS-3 study, the window, as we call it, was extended to 4.5 hours from stroke onset. So more people were able to obtain this life-saving treatment. But this was still not enough. In 2015, 5 landmark trials came by, and all of them established that removing the clot with mechanical measures was effective within 6 hours from stroke onset. And those 5 studies subsequently became 6, 8, and this is the standard of care now. But even after those 6 hours, because a great percentage of patients don't have pain, do not realize they have a stroke, they come at 10, at 12 hours. It was recognized that some people develop and increase their stroke very slowly over the course of several hours, and some others very fast. And the question is, how do we identify and define those that are called the slow progressors? And this has been helped by software, AI, and the increased computational ability of current computers, and we are able to do it now. There were 2 landmark studies in 2018, the DIFFUSE-3 and the DAWN trial, that established the benefit of mechanical stroke treatment up to 24 hours from stroke onset. And if we see, if people with stroke come, almost half of them improve, and almost a third of them go back to living independently. And those are people who have had a major stroke to begin with. There are still open questions. What do we do with smaller strokes, bigger strokes? But all those open questions essentially mean that we now have an effective treatment, and we try to refine it. So how do we administer those life-saving treatments? We do it in stroke centers, but not all stroke centers are the same. There are 4 levels of stroke centers that have been recognized. And basically, they are the acute stroke-ready hospitals, the primary stroke centers, the thrombectomy capable, and the comprehensive. And each one of them can do a few more things than the previous one. So initially, they can give the thrombolysis, then they can keep the patient, and the higher levels can have neuro-ICU, neurosurgical, and other abilities. But those stroke centers only exist as elements of stroke systems. So a patient enters a stroke system of care by EMS, by walk-in anyway, and then they may come to a certain hospital center level. And then the question is, how do we process them during the first few minutes of their stroke so that they get the optimal care that they need and they deserve? And in order to do that, we need destination plans. And those have been developed in principle. What happens to somebody who comes with a small stroke? They can go to a smaller center, but if it's a bigger, then we have to calculate the distance. If it's more than 30 minutes to the bigger center, they may go to the smaller ones. Otherwise, they can go directly. There are different paradigms, the drip and shape, as we call it, the spoke and hub. And many hospital systems, including ours, try to organize their care across this type of hierarchy of stroke centers. This is not something that can be defined nationwide or even within a prefecture or a county or a state. This is something that's very local because stroke centers are very asymmetrically distributed, and we have to have what are called the travel time maps. If a patient is in any specific place, what is the exact time to reach the primary or the comprehensive stroke center. And the stroke burden itself is not uniform. There are areas, this is what we would call the stroke belt, that have a very high stroke morbidity and mortality. But sometimes we see that market forces are not sufficient to determine the optimal distribution of stroke centers. So this is the distribution of primary stroke centers, and we see that many of them are not where the stroke patients are, and the same for comprehensive stroke centers. So maybe this is sometimes better for systems as Greece, which tries to develop their stroke centers now and has a single payer and a public health system. A stroke system of care is not just a consortium of hospitals. It also needs to include domains such as community education, primary prevention, the acute stroke treatment, but also what happens after a stroke happens, secondary prevention, rehabilitation, and quality improvement. So when it comes to quality improvement, those need to happen at a national level, but also at any particular hospital. This is a nationwide quality improvement project that targets stroke, that significantly increased the speed of giving thrombolysis. Phase 1 was around 2009, phase 2, 2013, and a metric that we call door to needle, a greater percentage of people have been able to obtain it in 60 minutes, and the same thing for 45 minutes. We say that many times time is brain, so the faster you get the treatment, the better. Now we are in stroke phase 3 since a couple of years ago, and now the goal is not only what we call door to needle, but also door to device. How long does it take for the clot to be removed? Community and public education is very important. There is the FAST acronym with face, arm, speech, and then time to call 911. This has been refined to other iterations. It has been translated in other languages, including Greek. So as a summary, effective stroke treatments exist. They can be given by different levels of stroke centers. Stroke centers exist within systems of care, and those systems of care are paramount in every country to give stroke care across the spectrum of the disease, measure outcomes, participate in quality improvement. And then we need the regulatory bodies that are outside their own leadership that will evaluate them and recertify them periodically and participate in community education efforts. Our time is up. Thank you very much. I think that we will take questions at the end.
Yes, thank you, Dr. Kataramado. Thank you very much.
Thank you.
We're going to take questions at the end. Would like to be cognizant of the time. So I would like next to move to the next session on back pain management and give the floor to the moderator.
Yes, thank you very much. So I would like to start with the next session, which is back pain management indeed. We have 4 distinguished speakers. We'll start right away. And if there's any kind of question, please go on. Actually, after each talk, at least after the first talk, because our speaker needs to leave. So I'll start with Professor Konstantinos Margetis, who is Assistant Professor of Neurosurgery in the Mount Sinai Hospital. My name is, by the way, Xenofon Baraliakos. I'm a rheumatologist and orthopedic surgeon in Germany.
Thank you. It is a great pleasure for me to be back in Thessaloniki, where I did my medical school many years ago. I'll try to move fast and respect the time that I have available. So today we're going to discuss about spinal fusion and what is the current state of the art. It is a very important topic because it's a very common operation. It's expected to be performed even more frequently in the future as the life expectancy increases, and these problems are related to degenerative spine disease, which is more common in elderly people. Some disclaimers: this presentation cannot be comprehensive, and there are some inherent biases due to the time constraints. So the degenerative spine disease, the most common indication of spinal fusion, and it comes with normal aging, but there are also some occupational lifestyle factors that accelerate this process. And basically, degenerative changes induce change the biomechanics of spine, induce even further degenerative changes in a vicious cycle. A very quick refresh. The main thing that induces the degenerative spine disease is this dehydration, and that induces kyphotic deformity and changes the way that the spine is stressed during the normal movements. A very common indication that we do spinal fusion is spinal instability, where basically is, according to this definition that we still use today, is the loss of the ability of the spine to maintain its pattern of displacement. So basically there is like neurological deficit or incapacitating pain with normal movements of the spine. So that's basically the spinal stability. Another important concept that we use when we're selecting the type of fusion operation, or when we're selecting whether we're going to do a fusion operation or not, is the alignment of the spine, especially the sagittal plane alignment, because if there is like kyphotic deformity, there is more load for the muscles to maintain that posture. So the increased loading of the muscles leads to muscle fatigue and muscle-related pain. So that's why we pay so much attention to maintain or restore the proper spine alignment. About the pathobiology, so degenerative disease causes axial pain in the form of neck, back, or thoracic spine pain. Several mechanisms for that axial pain to be produced. I know there are talks on the subject later. And degenerative disease can also cause radiculopathy in the form of pain that shoots down the arm or the leg, depending on the cervical or lumbar location of the disease. And this is mainly due to nerve compression, either dynamic or static. So in terms of the classification of the lumbar fusion operations, there are many different techniques to achieve the same result. And we usually divide them in anterior approaches, where we approach the spine through an abdominal incision, in lateral, where we perform incision in the flank, or posterior incision. So the main indications to perform fusion in degenerative spine disease is if there is deformity, or if there is stenosis. Basically, stenosis might be due to the overgrowth of the ligaments, or the infolding of the ligaments, or overgrowth of the bone. And if there is some associated instability or spondylolisthesis, or some of these additional factors. So spondylolisthesis, because you're going to hear that being mentioned very, very frequently, is the slippage of one vertebra over the other. It most commonly happens at L4-5, or like in this figure at L5-S1. There are several classification schemes. The most commonly used is the Megerting, where depending on the degree of how much that bone has slipped over the other, we have like 1 to 5. And another important concept is the iatrogenic instability. Sometimes when we need to treat lumbar stenosis, we need to remove a significant amount of the bone, and that bone is there for a reason, is to provide stability to the spine. So if we're going to remove adequate amount of bone to achieve the decompression of the nerves, then we might induce instability by removing that bone. So in these cases, we have to perform a fusion to prevent any adverse consequences of iatrogenic instability. So I've mentioned earlier, the importance of spinal alignment. So basically, we call that the cone of economy. So basically, the spine needs to be aligned. If it's not aligned, there is more work for the muscles, and there is basically more pain for the patient. And now we have understood very well what are these parameters that we need to be aiming when we're doing a spinal fusion. And not only we have defined them for the general population, but lately we have been able to define them for specific age groups, because the goals usually change according to the age of the patient. And we also have started developing criteria for the cervical spine. We have very well established for the lumbar spine, but we're developing right now for the cervical spine. Another important concept that I think that it will become even more important in the near future is the concept of expandable cages. We use them currently very, very extensively for corpectomies, but also in order to achieve their body fusion. So you can see here, this cage over here is in collapse form, but once it expands, it becomes much bigger in both height and width. You see how small it's initially here, it looks like a pencil, but once it expands, it becomes much, much bigger. And why is that important? It's because when we're trying to fit that cage between the lumbar vertebrae to achieve a fusion, we have a very narrow space to work. We have to pass that cage under the nerve, which is the yellow structure here. And you see here how narrow this space is. And that's the shape and the dimensions that we want the case to have. So imagine trying to fit that in through the tight space. You'll have to retract the nerve, and there's higher risk for nerve-related complications. While if you insert it in the collapsed form, you can more easily and more safely put it in and then expand it once you're inside the space. So that's a very interesting concept, and I think it will become more commonly used in the near future. We also now have robotics. There are some limitations with the current technologies that we have, but as newer technologies emerge, I think they will become also much more commonly used in the near future. We have some new options for instrumentation, like these expandable screws. We have carbon fiber screws that allow us to get MRIs in tumor cases and don't have any kind of magnetic artifact from metallic screws. While we're developing the spinal fusion, we have a renewed interest in the options that maintain the motion of the spine. There are some limitations with these techniques, but they're very, when you have the right candidate for these operations, a very good alternative to a spinal fusion operation. And we have some newer approaches on how we're going to approach the spine to perform the fusion. One of them I'm very interested in, and I like a lot, is the endoscopic fusion. So how do you do that? So basically you do the whole thing through a very, very small incision, like 7 millimeter in length, and you feed that instrument in, and you do most of the work with through the very, very small incision. You can approach the spine through the interlaminar approach or through the transforaminal approach. And for the transforaminal approach, basically you approach the spine through the Camden's triangle, which is this triangular area here, basically the axilla of the extinct nerve root. And while in normal cases, here's the nerve root, here's the thecal sac, in case without any degeneration, this space is pretty big. But in degeneration, in cases with the degenerative spine disease, you have hypertrophy of the facet joint, and basically this space is very, very small. It becomes like a slit-like space. And that presents some challenges in the endoscopic fusion, because when you do the endoscopic fusion, that's where basically the area that you approach the disc space to achieve the interbody fusion. For the interbody fusion, we use some special instruments like this expandable disc saver, the articulating curette. We have the articulating bear like this one. We have expandable cages, and all these instruments are very, very important for the performance of the endoscopic lumbar fusion. And now a quick video of this case with dynamic instability. You see here how this L4 is slipping over the L5. And this is a view of the disc space. We have inserted the endoscope through the Camden's triangle, and we're working inside the disc space. All this white material is basically the disc. Here we use a cautery to shrink that disc material. And here we use the articulating drill bit to drill off any cartilage from the end plate and expose the bone, which is very, very important for the fusion. You need to remove all the cartilage from its end plate so that you can put the bone graft. And you can see here the bleeding bone, which is very, very important in order to achieve a fusion. So this is the end plate of one of the vertebra. And we inspect the disc space. We have removed most of this material. And here we're working on the facet joint. We're using this cautery to shrink the soft tissue, the synovial basically tissue. And then we're gonna use the articulating drill bit to perform the cortication inside the facet joint to induce fusion there. And this is a post-op X-ray. So there is some low-level evidence that it's a very promising technique. It's still at the early stages, and the indications are currently limited. But as the technology advances and we learn more about the technique, I think it will become much more commonly performed in the future. And we have some very promising, again, initial results that they have been even been able to perform fusions without general anesthesia, which is a very, very important consideration for some patients. So we now know more things about spinal alignment and how we can optimize it. And we're trying to do operations with reduced operative time, blood loss, hospital stay. And I believe, in my opinion, endoscopic fusion and robotic technology are very, very promising concepts for the near future.
Great. Thank you very much, Konstantinos. indeed very, very up-to-date. We're just a few people in here. I don't see any questions, and I know you have to catch your flight. So thanks a lot for coming.
Thank you.
And we'll move on. So the next presentation is going to be given by George Mattis, who is a neurosurgeon at the University of Cologne in Germany, and I know he has pre-recorded the presentation.
Hello, good afternoon. Thanks for having me. I'm Georgios Mattis. I'm a neurosurgeon. I'm the head of the Pain and Spasticity section in the Department of Stereotactic and Functional Neurosurgery in the University Hospital of Cologne. The topic is back pain and spinal cord stimulation and journey in time. Over the next 10 minutes, I'm going to outline the current role of spinal cord stimulation in the interventional pain management, and I'm going to say some things about the future of the therapy. Let's start with the current of this therapy. The problem with chronic pain is that the chronic pain patients are really difficult patients. This is the pain detect questionnaire. It's a questionnaire we are using in order to see if the pain is neuropathic or nociceptive or something between the two types of pain. And here you can see that the patient has written some numbers. She should have written how intense the pain is on this scale from 0 to 10. She wrote all these numbers. It took us some seconds to figure it out that it was her mobile number. There are different types of treatment for back pain. This is one of them. But we do have some more scientific approaches to this problem. We have the interventional pain therapy. We have different therapies. We can act at the level of the first neuron, at the level of the second neuron, at the level of the third neuron. What's important for this talk now is the second neuron, the spinal cord stimulation, and the intrathecal therapy with opioids or without opioids are acting at this level. There are several chronic pain conditions which we can treat with spinal cord stimulation. For example, trigeminal neuropathy, not neuralgia, neuropathy, patients with back pain, neck pain, arm pain, leg pain, these patients with failed back surgery syndrome or the new term persistent spinal pain syndrome, patients with phantom or stump pain, polyneuropathies, plexus lesions, angina pectoris, peripheral vascular disease, postherpetic neuralgia, and complex regional pain syndrome with or without capsalgia. It is true that we do have a paradigm shift away from the World Health Organization analgesic ladder toward an earlier surgical intervention. You all know this ladder. You all know we should start with non-opioid drugs, then use weak opioids, and then strong opioids, and then we have the intrathecal opioid or non-opioid therapy. But we have seen that if we start with all these neuromodulation options, for example, pulse radiofrequency, peripheral nerve stimulation or peripheral nerve field stimulation or spinal cord stimulation, before even starting with the opioids, then the clinical results are much better. Everything started with this paper published in Science 1965, the gate control theory, which states that activation of large diameter fibers inhibit the pain transmission to the brain. The first clinical application of the therapy was 1967 in a patient with lung cancer. The colleagues implanted the lead. The patient was satisfied, but unfortunately he died 6 days after the implantation of the lead because of endocarditis. What is the concept here? The concept here is to implant 1 or 2 leads near the spinal cord, stimulate, deliver electrical impulses, and if the patient is satisfied with the result, then we should connect these leads to a neurostimulator, to a permanent battery. How it works? There are segmental effects at the level of the spinal cord, but also there are also supraspinal inhibitory pathways that are being influenced by this therapy. It is not a new therapy. We have it for more than 50 years. This is the first spinal cord stimulation meeting in Germany, in Freiburg, and all the devices you are seeing here are receivers, are devices implanted under the skin, and when the patient wanted to stimulate, should use this antenna over the device in order to stimulate. It was not very practical. We have gone a really long way. The colleagues back then started with leads with only one contact. You can see such a lead here. Then we had leads with 2 contacts, with 4 contacts, with 8 contacts, and now we have up to 32 contact leads, percutaneous leads, or surgical or bundle leads. So this is what you can see using a C-arm in the operating room. If you implant 1 lead with 8 contacts, if you implant 2 leads with 8 contacts, or if you implant leads with 16 contacts, this is one more option. There's only one lead in the market to do that, and this was the first European implantation of such a lead in my department 2018. And then you have the neurostimulators, the permanent batteries. It could be rechargeable, could be non-rechargeable, with advantages and disadvantages. As with all therapies, the spinal cord stimulation has some indications, some contraindications, and some gray zones. These pictures were taken at 6 o'clock in the morning. This is my home, the University Hospital of Cologne. According to the German guidelines, according to the German Society for Neuromodulation, inclusion criteria for this therapy are patients with chronic pain, insufficiently treated with drugs or psychological therapy. More importantly, exclusion criteria, patients with severe coagulopathies, mental disturbances, addiction problems, secondary gains, inability to use the spinal cord stimulation system, advanced malignant tumor, and of course, infections in the area of implantation. According to the German Society for Neuromodulation, the best 2 indications for this therapy is complex regional pain syndrome with outcome salsia and persistent spinal pain syndrome, or failed back surgery syndrome if you like. For other indications such as angina pectoris or peripheral vascular disease, the recommendation is open. The majority of patients that are coming to us are patients with failed back surgery syndrome. And we know that unfortunately the failure rate of the lumbar spine surgery is somewhere between 10 and 46%. We also know for every additional spinal surgery, the satisfaction of the patient is not really high. But spinal cord stimulation is not a therapy only for such patients, for failed back surgery syndrome patients. There are other many good indications, for example, intractable angina pectoris, where we can implant the lead with a tip at C7 or T1. If a heart infarct is coming, then the patient will notice that. So the therapy cannot cover this acute pain. Patients with peripheral vascular disease, if it's possible, grade 2B or 3 or 4, you can implant a lead with a tip at T10, and you can see that the flow of blood, the perfusion is much better 30 minutes after the stimulation, and the pain is much less. If you're interested in the topic, you can read this review article on spinal cord stimulation and peripheral vascular disease published in the British Journal of Neurosurgery. We can also have a hybrid stimulation combination, spinal cord stimulation and peripheral field stimulation. Here is a patient with 2 subcutaneous leads, and after some years we added a spinal cord stimulation lead. He is still satisfied with the therapy. Spinal cord stimulation for me is music. Spinal cord stimulation is mathematics. If you see, the definition of music is the science of art of ordering tones or sounds in succession, in combination, and in temporal relationships to produce a composition having unity and continuity. This is exactly the same with spinal cord stimulation, with electrical impulses in succession, in combination, and in temporal relationships. Why is this important? Because different waveforms, different types of stimulation can activate different mechanisms and can act in different areas in our brain. There is a big discussion now if we should always perform a trial before implanting the neurostimulator or not. There are several articles. I just chose 2 for you. This comes from Duarte and Thompson, published in Neuromodulation. And the authors here are saying that if we do permanent trials, we can have more infection, more punctures, more productivity losses. And they estimated that if we do a trial and we have a success rate of 85%, or if we are using rechargeable systems, and 55% if we are using non-rechargeable systems, then actually, financially speaking, we don't have to do a trial. We can implant directly the lead and the neurostimulator. A second paper, really recent, coming from Professor Eldabe and his team, published in Pain, shows that the sensitivity of this screening trial is 100%, but the specificity only 8%. And the authors are concluding that although spinal cord stimulation screening trial may have some diagnostic utility, it provides no patient outcome benefits. If you're interested in the topic, you can read this small review article in the International Journal of Neurosurgery. And what about the future? The future is more data. We have apps, smartwatches, we can collect data, and we can use artificial intelligence or machine learning to use this data to provide more information, to have more waveforms to treat different types of pain. In October 2021, scientists used artificial intelligence to complete the 10th Symphony of Beethoven. So artificial intelligence can be used for many, many things. We have also merged reality. Let's say I'm in Cologne, my sales rep who is doing the programming is in Greece. He can see what I'm seeing on my laptop and he can show me on my phone what I should do. We have also the remote programming. For example, here I'm sitting in my office. I have a sales rep in the room of the patient. I have a second sales rep in Greece, for example. We can all work together. The future is also spinal cord stimulation for spinal cord injury to improve the motor functions. We are now at the very first steps. We need some more time, but it looks really good. A more practical issue, respiratory function in cases of spinal cord injury, we can implant a lead at T2 to 5, and this can facilitate the respiratory function, and the patients can move from ventilators to CPAP devices, limiting the complications that are related with the ventilation. Spinal cord stimulation can also be used with these new waveforms for mixed pain, for a combination of neuropathic and nociceptive pain, and this is only a small series of 6 patients. And here we can see that not only the pain relief is substantial, but also the overall disability index and the quality of life are much, much better after this therapy. This is something I found on Instagram, and I think we can say more or less the same thing for the chronic pain patients. We are thinking that we are treating these patients, but actually, if we forget the emotional, the cognitive aspects of pain, then the pain relief could not be adequate. What we really need is compassion, not only for our patients, because this is the antitoxin of the soul, but also for ourselves, for our colleagues as well. And international and national collaboration is a must in this field. These are my sales rep, people that are helping me provide a very good programming to my patients, and I'm thankful for that. If you have any questions, please don't hesitate to ask me. This is my email address. Please send an email if you want to ask something. Once again, thank you very much for the invitation. Enjoy the Congress.
Great. Thank you very much. I don't know if, yes. Georgios is with us. Georgios, I have to.
With you. Good afternoon.
We are running very, very late, unfortunately. And therefore, I know that you have been maybe waiting for the one or the other question. I would like to leave it to the email, if you don't mind, and continue with the next presentation. Thank you very much. It was very insightful. Thanks a lot.
Thanks for inviting me.
Thank you. So we'll move on. We'll go to the next presentation. Is Professor Konstantinos Afitsas, who is also coming from Germany, and he will tell us some things about the injection treatment in degenerative spine disease and the low back pain.
Thank you. Thank you very much. Nice being here in Thessaloniki. I would like to say something about what we do, the common practice with therapeutic injections and epidural injections for degenerative low back pain. The epidemiology is in Germany, for those who are in Germany known, but it is a widespread disease, I think, in Greece as well and all over the world. We have 74% of the population that has low back pain. 12.5% have a chronic low back pain. This causes almost 20% of lost work days, and 70% of the early retirement cases are caused by that. The treatment of low back pain is, on the one hand, conservative, on the other hand, operative, and we always have a multidisciplinary treatment as far as the chronic low back pain is concerned. The injection therapy is an alternative before doing an elective operation. It's a supplement to the guidelines that are current known in Germany, and it's the principle of it has the principle of avoiding operations. But these effects have not yet been examined and proven by evidence. So, historically seen, we have the first extradural injections in 1901 by Sicard. Paget is the pioneer for peridural anesthesia. Evans did 1930 the first injection with isotonic NaCl. The first randomized prospective study took place in 1973. Well, the controlled double-blind study was done by Kuckler in 1985. The epidural injection are some discrepant in the literature. We have positive effects such as pain relief, function restoration. We avoid an operation. We also have questionable long-lasting results. The pain relief in radicular low back pain is a given fact, but there is no strong evidence for acute and subacute chronic low back pain, for subacute and chronic low back pain. So this study here, over an evaluation over 2 years, showed that the epidural injection do have an impact in managing low back pain. The epidural steroid injections were also compared to a placebo group, and there is a significant pain relief, which is only temporary, better results in young patients, and also some complications. For the facet joints, we have not enough evidence on the therapeutic influence for the injections. We have initial pain relief in 42 to 92% of the patients. We have a long-lasting pain relief that varies. We have different opinions about intra-articular injections over peri-articular injections. In both cases, we have significant better results. But between intra-articular and peri-articular injections, we don't have significant differences. We have a high diagnostic accuracy of facet joint blocks. So we now have the epidural injections, we have the facet blocks, the facet joint blocks. Now we have the cortisone. Should we use corticosteroids, which have a vasoprotective effect and deteriorate synthesis of interleukins and phospholipase? So the use of cortisone is done beyond its FDA spectrum and in Europe as well, so it's an off-label use, but it showed a long-lasting effect and pain relief, significant pain relief. But there is no significant difference between combined local anesthesia and cortisone and local anesthesia alone. Well, this randomized trial showed that we have 400 patients randomized and showed that the epidural glucocorticoid injections for spinal stenosis are significantly better as far as symptom is concerned, but there is no effect in the lasting effect after 6 weeks. But with cortisone, we could address the problem of depression and the patient satisfaction after the treatment. So is the facet no cortisone? Well, this is why we did our study. It's a retrospective study in both centers where I'm working. We had 351 patients with low back pain. We had a narrow indication window for degenerative spondylolisthesis, osteochondrosis, facet joint arthritis, and spinal canal stenosis. So we had almost only degenerative diseases. We did the modified short form questionnaire and the ODI, and we had the follow-up over 2 years. We did an injection. We had a standard therapy. We did an injection once a day over 4 days. Initially, we have a diagnostic injection of facet joints, and on the next day we had epidural injection, and in the last day we had the injections with cortisone, and those injections that showed a good result. So all the injections were performed under fluoroscopy. Physiotherapy and back school in every case is given. So we had about 200 women and 151 men. Women are a little bit older than men. In the modified short form, we showed in every group of the questionnaire, we found a statistically significant improvement of the physical and psychological management, pain management for the patient. And as far as the ODI is concerned, we found pre-interventional and post-interventional a significant improvement. As far as the limitations is concerned, of course, the retrospective data, the cause of the low back pain is only reduced to these entities that I showed before. We have different patient characteristics, different age. Some of them have side diseases, so that we have to, in order to make more individual analysis of the study, then we should go furthermore to greater numbers and more centers. In summary, we have the interlaminar epidural injections that are a reliable treatment method for patients with low back pain. We had no complications in our study. The epidural injections under fluoroscopy are safe and with subjectively less pain. The facet joint injections do have a positive impact on low back pain, and we have a positive diagnostic intervention with significant improvement of symptoms, so that in low back pain we could use cortisone with a positive effect, and also under fluoroscopy we minimize our complications. Interesting of the study, the interest of the study was also pointed and focused on the side results. In 70% of the patients, we had a consistent pain relief after 2 years. 30% of the patient repeated the injection therapy in the first 2 years. 10% of the patient decided for an operation either after the second or more injection therapies. And over 50% of the patients came to us in our outpatient clinic with a solid advice for operation. Only 19 of them underwent operation. So I think this is a thing an idea that should focus on the next studies. Thank you very much.
Great. Thank you very much indeed. Also, it was very interesting data to see and also compare with to what we saw just before. I would like to go on with the next presentations. Again, if there's any question, we can take them up hereafter. And I would like to invite Professor Eleftherios Sarhavlis to the stage, who is coming from Frankfurt and Mainz, and he's going to speak about the interdisciplinary spine centers for the treatment of complex adult spinal deformity.
Yes, good evening, dear colleagues. Thank you very much for the invitation. I'm very honored to be here. My topic, which I'm working on the last 2 years, is interdisciplinary centers for the treatment of complex adult spinal deformity. This is the journey of such a spine center in Frankfurt since it was founded in 2020. I want to give you some insights and present also some preliminary results of ongoing prospective study about decision-making in such a center. So what is the definition of spine center of excellence? It's of course the collaboration of different disciplines to optimize patient care. What is the difference of multidisciplinarity and interdisciplinarity? Well, from multidisciplinary teams, you draw knowledge from different disciplines, but every discipline stays within its boundaries. In an interdisciplinary team, we analyze, synthesize, and harmonize all the links between the disciplines into a coordinated and coherent whole. So the different experts are working independently, but all decisions are made together. What were the goals for such a center? We wanted to enlarge our spectrum to offer all the diagnostics and therapeutic aspects of spinal diseases at the highest level. We wanted to offer a patient-tailored treatment with a commitment to trying the least invasive options, to enhance therapy, to decide depending on scientific evidence, and to reduce practice variation in order to improve the quality of medical care. How we wanted to achieve this? Through evidence-based therapeutic approaches, working according pathways defined early in the process for all the different common spine diseases like herniated disc, spinal stenosis, and spondylolisthesis, and of course trauma, as you see here. Working according algorithms also helped our clinical physical assistants and nurses for the simple tasks of organizing an appointment, for example, or working with pathways to organize the process of hospital admission and discharge. And we assumed that the biggest profit for the patients would be for complex spine diseases. Why? Because these kind of operations are bloody operations with major perioperative complications, with a mortality rate, according to the literature, up to 3%. And overall complication rates of 55%. Like in this case, operated in other unit, pre-operated in another unit where you see there is some imbalance, disbalance of the sagittal alignment, and we had to do a bigger surgery with pedicle subtraction osteotomy. And during the surgery, we had a cardiac arrest, a very severe complication, and the patient should be reanimated. The underlying reasons for the high risks associated with these diseases are multifactorial. These patients may have cardiopulmonary dysfunctions, neurologic compromise, or ischemic heart disease that you don't know. For example, this patient with this spinal deformity, scoliotic deformity, had to be operated with hybrid surgery from the side and from posterior. And after the second postoperative night, the patient developed cardiac infarction. So you see that the spinal deformity surgery may lead to detrimental patient outcomes because of rehospitalization rates, because of revision surgeries. For example, because of pseudarthrosis, like this patient with breakage of the rods, because of pseudarthrosis, we had to do a big surgery. This also called, also known as heavy metal surgery. And we had to do this kind of surgery. We know that, of course, out of the literature, that the outcomes in the first year may be worse, but on the longer term, the follow-up may still demonstrate continued improvement in the patient-reported outcomes. So the multidisciplinary approach has gained popularity, and in the US, for example, there are 4 multidisciplinary programs that are very well documented, and the Americans show us now in which way the future is going. And all of these programs are based on 3 pillars: the preoperative multidisciplinary conference, and the postoperative the intraoperative and postoperative communication, consistent and close communication of the teams. We have also two very good papers reporting surgical planning alterations in up to 30% of the cases, which may improve perioperative optimization. So based on this knowledge, we organized our interdisciplinary program with a conference of multiple disciplines and spine rounds, medical records, algorithms that I showed you before. And we defined a core team of this preoperative conference with a neurosurgeon, orthopedics, trauma surgeon, pediatric scoliosis surgeon, and pain medicine specialist, and extended team or also with different disciplines. Some of our prospective data, our purpose was to study the effect of the surgical indication conference on surgical decision-making and surgical strategy in these complex adult deformity cases. We acquired data from the start of our spine center, and now we have data of the last 2 years. We had the preliminary therapeutic plan that was introduced from the primary surgeon. Then the conference plan, this was a concept plan of the whole team, and the implemented plan, and we tried to find correlations between demographic data, clinical and complication data. And we identified out of the 1,000 patients, 56 consecutive patients. Regarding demographics, comorbidities with respect to the decision whether surgery or conservative, we didn't find any correlations with except of smoking. We found that out of the 156 patients, 11% were offered additional therapies, conservative therapies like physical therapy, injections, internal medicine, consultations. And we also found that up to 20% of these patients, we had a change in the therapeutic plan. Why is that? What was the reason for a change? It was the medical or additional diagnosis that were discovered through the conference. There was the likelihood to benefit from lesser surgery, less invasive surgery, or minimal invasive surgery, or the likelihood to benefit from extensive approaches because of sagittal disbalance, for example. And we saw that the change of the preliminary plan was independent of the discipline, neurosurgeon or orthopedic surgeon. And after the preliminary plan was decided, there was a homogenization between conventional and less invasive surgeries between the different disciplines. So we concluded that surgical decision-making may result in suboptimal treatment recommendation. With the interdisciplinary conferences, we can provide patients with more diverse operative treatment options. My personal consideration is that launching a spine center, you should have a clear understanding of what the patients want, rather than what the hospital, health system, spine surgeons may want. We had a lot of challenges to face, not collaboration issues between the disciplines, but moreover practical issues like operating room and clinic capacity, turnover of our trainees. If you ask me, can this method or philosophy change the world of spine? I don't think so, but we can bring added value. We can increase the quality of spine care. And one of the important issues is that the mutual respect we have inside the team. Thank you very much for your consideration.
Great. Thank you very much. Also here, we've had a very nice session, including both more invasive or less invasive or no invasive even considerations in back pain management. Is there any question from the floor? Which is something I do not see. And because of the late time, I would like to conclude the session. Thank you very much for those of you who have been here, and have a nice summer from now on.